Okay. Okay, just second. We are live, going live. Okay, live है मैम हम.
ठीक है.
Okay, thank you.
Okay, hi guys. So can you all see me and hear me? All right. So nice to see you all finally. Sorry for the chaos. And we will have to increase our Zoom limit. This is something we did not expect. That I will only not be able to enter my own class. So we couldn't start it on Zoom. So we are now streaming it on YouTube. Okay, so we're streaming it on YouTube, and subscribers need not have FOMO that अरे मैम अब तो सब देख लेंगे. Why did we take subscription? Don't go into that vicious cycle, because we'll make the video private after the live has ended, and we'll upload the recording on the app for the subscribers. Okay, so itna FOMO and anxiety mein mat jiyo. Don't let anything and everything give you anxiety. Okay, so just to clarify that, if that was your major concern. Having said that, those of you are here because somebody has told कि इसमें पेपर डिस्कस होने वाला है या पेपर लीक होने वाला है. That is not the case. Let me just give you a disclaimer. What we have here are the highest yield points that are there for the short subject. So I'm targeting that we'll finish one subject in around 30 minutes. So let's see how it goes. So we have 8 short subjects today that we're doing, and I'm including ENT Ophthal as short subjects here, right? These are BTR nomenclature that you all know. Okay, so I will try and keep up with the chat. I hope you guys keep it limited to answers, and any other queries that you have which are academic in nature, I will solve them in the latter half. So how you have to use this classes, use it for active recall. Should you make notes of everything? If you have not studied BTR till now, if you have not studied well till now, make notes simultaneously. All right, and at least make sure that this content that I'm teaching you right now is mastered. If you have done BTR well, you've done your PYQs, then what you can do is just keep a piece of paper with you. Whatever are the extra points which I'm saying, just write that on that piece of paper. Don't make extensive notes, because that's not the idea now. 3 days before the exam, 5 days before the exam, don't panic. 6 days before the exam, you don't want to make notes and then read. You are already at that point where you have made notes, you have read them, and now you just want to do active recall, and whatever are things you don't know, just write that selectively. Okay, I hope this is clear as to how you have to approach. I have addressed both the groups. अगर सब नया लग रहा है तो सब लिखो, जो नया लग रहा है उसको लिखो, right? So that is the bottom line of how you should use. Apart from that, keep answering. Every question is meant in the form of first I'll be addressing theory. For example, the first subject is psychiatry. So what I'll be doing is that the first half will be all of the previous year questions, the points, the topics which potentially can be asked or have been asked, and then there are few niche questions which have our PYQs. I've covered everything till 2017. So all of these subjects till 2017, I've included everything. Okay, fine. Just don't type random stuff now in the chat, okay? Because I'm taking out time to read, so I don't want to read cockroach and all of that stuff, okay? So stop writing random stuff. Group link, screen is not hazy. You need to change your resolution. Okay, so I can't disable chat because people will answer, but if you don't want to see, you can just, there's a cross over that, you can just cross that and it is disabled. Okay, all right. Yeah, I'll only be using English. In case I do use some Hindi, I will translate it immediately. Okay, so that there is no FOMO. All right, everybody all set. Now please don't spam and don't write random stuff, otherwise we will ban you. Okay, so please, somebody from Cerebellum who's watching, please just ban people from the chat if they are randomly spamming. Okay, so we are going to be pretty strict now. Fine. So let's start. So first half we will do theory, second half we'll be solving some previous year questions. Okay, unannotated PDF is there on the group, but I'm not sharing group link on YouTube. You just join day after tomorrow's class. Just wait for 2 more days to join BTR group and I will share the group link. Please don't ask for group link now in the chat. I just request you very sincerely, please don't ask for group link. अभी पढ़ाई कर लो, एग्जाम आ रही है, ग्रुप में पेपर नहीं आने वाला, ग्रुप में कुछ नहीं होने वाला, ग्रुप ज्वाइन करके पढ़ाई करके रैंक आएगा एंड दैट इज व्हाट वी वांट टू डू. Alright, let's start now, please. No group link. Okay, I hope there is no lag. I don't know if there is some lag between what I'm saying and what is reaching you, but hopefully it will all settle as we go along. Okay, all right, let's start. So first thing is about general psychiatry. So here we have a few points from general psychiatry which have been tested or can be tested. So the first thing, I can still seek messages only about a group link and hopefully it will come back. Okay, so tell me quickly, delusion is a disorder of thought what? So is it a disorder of thought form, thought stream, thought content, thought possession? Delusion is a disorder of thought. Just waiting to see answer. Yeah, so I think finally there's 1 minute lag, but I am finally getting your answers. Okay, so delusion is a disorder of thought content, right? It's a firm, unshakable belief that whatever you're thinking is true. And remember, difference between delusion, schizophrenia, here there is no functional decline overall. It's only a problem with that delusional aspect. Otherwise, the person is carrying out the day-to-day living just fine. Okay. Obsession, controversial question, but if it's an AIMS question, I will recommend you going with possession. But again, two psychiatry textbooks say different things, hence the controversy. So don't go into the controversy. I think this you can trust or whatever you want to trust. Obsession is a disorder of thought possession, and the thought process behind it is that, you know, in obsession you have ego dystonic. It is not something that you relate to. These are thoughts which are intrusive. So it's a disorder of thought possession. You feel they are not my thoughts. Okay. Hallucination is a disorder of, a lot of people think, अरे ये तो हमने पढ़ा नहीं, thought stream, formal thought. No, hallucination is not a disorder of thought only. It is a disorder of perception, right? It's the perceiving without any stimuli. If you falsely perceive a stimulus, that's illusion, but this is a disorder of perception. A true hallucination versus a pseudo hallucination. What is the difference between a true and a pseudo hallucination? If a true hallucination is going to be in the outer objective space, right? It's going to be in outer objective space. Whereas if they tell you inner subjective, it is a pseudo hallucination. So I'm going to be fast. Okay. I'm going to say as much as possible. And I'm also adjusting, so speed will increase. Okay, so just give me some time also to get into it. You guys also will be adjusted, and before you know it, speed will be on 4th gear. Okay, so hallucination is a disorder of perception, outer objective space. Most common delusion overall is the delusion of persecution. Persecution means entire world is after me, entire world is conspiring to bring me only down. ये YouTube live इसीलिए हुआ है ताकि मेरा रैंक ना आए. वर्ल्ड wants कि मेरा रैंक ना आए, इसीलिए ये क्लास फ्री हो गई. That is delusion of persecution. Then what is Capgras and Fregoli? So these are two delusions of misidentification, which is something which is very, very important and very, very confusing. So Capgras, how you have to remember is, you go to your house today and you see, oh, mummy is replaced by stranger. So what do you say? You say, oh crap, mother replaced by stranger. So when you are confident that it's not my mother has been replaced by stranger, that is when you say, oh crap. Okay, that's how you remember Capgras, when family replaced by stranger. In Fregoli, what you're going to remember is family giving goli. Family giving goli means now you feel that, oh, my mother is playing games with me. She is coming and becoming like this stranger. She is becoming like this person. So now you are suspecting your family only. It's not that you are worried for mother. Oh crap, mother replaced by stranger. Now you think family, I'm going to write that only. Family giving goli, because that is how you will remember. So now when I show you this image, what do you think it is? Is it Capgras or is it Fregoli? Fregoli, the one where the person is wearing masks. So this is not Capgras. Capgras mein you don't think mother is wearing mask. In Fregoli you think, oh, mummy mask badal ke apna face badal rahi hai. Mother is changing her form, right? So this is how this question has come in names, that what does this represent? It represents Fregoli syndrome. All right, I hope this is clear to all of you and you don't mistake this again. Fine. Then we go to D. Clermont. What is D. Clermont syndrome? It is erotomania. Erotomania meaning Shahrukh Khan loves me. वो तो मैं उसको भाव नहीं देती. That is erotomania, right? That a very famous person loves me and then I am only not interested. So that is erotomania. Othello syndrome is morbid jealousy. Can you tell me which substance abuse is morbid jealousy also associated with? Substance abuse, or what abuse is morbid jealousy associated with? Is associated with alcohol only, right? So associated with alcohol. Then Cotard syndrome. Last year question, Cotard syndrome is a syndrome of nihilism. Nihilism means world is ending, everything is coming to an end, my intestines are rotting. Okay, so that is Cotard. Now, abhi tak ye sare delusional syndromes I was telling you. Okay, now what I am telling you is not a delusion syndrome. I just kept it together so that you remember all syndromes. What is Ganser syndrome? Ganser syndrome is something that you see one in prisoners. Second point you want to remember is Vorby-Reden. What is Vorby-Reden? This is known as pseudo stupidity. इनको हम पूछते हैं what color is the sky? They will tell us color of the sky is orange, meaning they understood कि color की बात हो रही है, but they still give us a wrong answer. They give us approximate answers, right? So they are not doing it on purpose. Remember, it is something which is a dissociative disorder where they are not lying on purpose. So remember, this is Ganser syndrome, buzzword, prisoner, Vorby-Reden. All right. Next, what is transference? So if you know transference, you know countertransference also. So transference is when the patient develops feeling for the doctor, meaning not just romantic feelings, any feeling that the doctor is like my father or like my brother. So when the patient develops feelings for doctors, that is transference. The vice versa is countertransference. That's also a repeat question. Then when I ask you what is the most common obsession, the most common obsession is contamination. You feel that, oh, this is dirty, intrusive thoughts that everything is dirty, needs to be cleaned. So that is obsession, contamination. But most common compulsion is not washing. So here remember, the most common compulsion is actually checking. अरे door तो बंद है, ये तो ठीक है. So checking again and again is the most common compulsion, followed by washing. Okay, so this is about compulsion. Can you tell me the psychiatric disorder associated most commonly with OCD and anorexia? So two different questions. The answer here is depression. Mood disorder, depression is the most common association of OCD, most common association of anorexia. If I ask you what is most common association of panic disorder, पैनिक डिसऑर्डर का एक एसोसिएशन बताओ, which was previously a part of diagnostic criteria but now has been unlinked. It is no longer linked with panic disorder. It is associated but not a part of criteria. This is agoraphobia. So agoraphobia is phobia of any place where escaping may be difficult, right? Like such a YouTube class. If it was offline, a person with agoraphobia will not attend. Okay, so that is something which is linked with panic disorder. Fine. Changing gears into the defense mechanism in OCD, just remember the mnemonic Duri. All right, so Duri is what you want to remember. Displacement. Displacement means somebody's anger you are taking out on somebody else. HOD scolded JR, JR scolding intern. That is known as displacement of feelings. Undoing. You had a fight with your husband, then you undo it by giving him gift the next day. Reaction formation is going opposite. A stepmother resents her stepdaughter but shows unnecessary extra affection. That is reaction formation. Inhibition, isolation of affect is just not letting your feelings show. No need to remember the just remember examples. Baki yaad rakho, OCD Duri, they can give you all except questions. Fine. Now coming here into the test for orientation, attention, concentration. Very, very important. So I've just picked out the most important stuff which are potential questions. Orientation, we check to time, place, and person, right? I want to know that if orientation is not there, diagnosis will be delirium, right? So important, delirium versus dementia. One thing only I want to remember, that agar orientation nahi hai and consciousness is clouded, two things go in delirium which do not go in dementia. Very, very important. Remember, agitation is not something you will use to distinguish. I will use two things: orientation, consciousness. ये दोनों गया मतलब delirium. Is this clear? This is how you'll distinguish delirium versus dementia. Now, testing attention and concentration. Attention is digit span test. We keep increasing the digit. You keep giving random digits 1, 3, 5. Then you keep, patient will repeat. Then you say 1, 9, 10, 15 in any random order. Don't give in a fixed order. So you keep increasing digit span test. That is attention. What is concentration? Concentration is sustained attention. Can you sustain your attention for the next 8 subjects? Psyche के पहले पेज में तो है attention, but is there concentration is what will be tested today. So concentration sustained, also tested by serial 7 subtraction. Ask person to subtract 100 minus 7, then 93 minus 7, and so on and so forth, right? So this is attention concentration. Now, a few questionnaires. This has been asked. What is the CAGE questionnaire for? This is for alcohol abuse. Okay, so you all know the full form. CAGE questionnaire for alcohol abuse. Here, what are the what is the full form of CAGE? If in case they do ask you. So here, C is when you what is the full form of C? Let's go to G is when you feel guilty. E is when you need an eye opener drink, right? So these are all the questions that you're gonna ask for anybody who has alcohol abuse, right? Then SCOFF questionnaire is for eating disorder. For eating disorders, we have the SCOFF questionnaire. PANS, what is PANS for? So in PANS, what you have to remember is this is for schizophrenia. The S here is for schizophrenia, right? So this is for schizophrenia. Confusion assessment method, CAM. Yeah, C is for cutting down, correct. C is for cutting down. Do you feel angry, guilt, and eye opener, correct. So this is about alcohol. Coming back to CAM, confusion assessment, as the name suggests, confusion matlab orientation consciousness gaya hai. So this is for delirium. This is for delirium versus dementia. Spikes protocol, what is spikes? It is for delivering bad news. And pearls is something which is to build rapport. This is for building rapport with people. This is in general an acronym. So these are the acronyms that we need to know. All right, so this is about the acronyms. C, again, I'll just clarify. C is, do you feel you need to cut down on your alcohol? A is, do you feel annoyed by your habit of drinking alcohol? Do you feel guilty? And in the morning, do you need an eye opener? वैसे सबके full form जानने की जरूरत नहीं है, but CAGE somehow, it's very relevant in a day-to-day basis. Any one is positive means we have alcohol abuse. Okay. Now going on to catatonia, something that does give you lots of questions. They can give you image-based question also. So a few confuser terms here. Catatonia in general means either you are not moving at all or there is excessive. Both of these come under catatonia. The one spectrum is where you are not moving, you are not talking. Negativism means whatever you tell patient will not do only. है ना, उल्टा जाएंगे, negativism. Posturing is what is important. So if the patient is assuming posture against gravity, actively contracting muscle, remember this is posturing, versus catalepsy is passive posturing. Here you are not actively going against gravity. So this is a difference you should know. Posturing versus catalepsy. Don't confuse catalepsy with cataplexy. Cataplexy is seen in narcolepsy. So this is like a cross mnemonic. You want to remember that lepsy is not in lepsy. So narcolepsy, I am going to see cataplexy, which is a sudden loss of muscle tone. In narcolepsy, you will have sleepiness during the daytime. You will have hypnagogic, hypnopompic hallucination. That is what they'll describe in narcolepsy. Drug of choice for narcolepsy, modafinil, right? So modafinil. All right, so this is a side note, cataplexy and catalepsy. Now talking about waxy flexibility. Waxy flexibility means just the name itself tells you that shuru mein patient will not move. Then if I move patient's limb, apne aap hi, like a wax, the patient's limb will move. All right, so this is known as waxy flexibility. Echolalia, echopraxia is repeating whatever examiner says, doing whatever examiner is doing. Okay, so these are the terms you need to be aware of. They can give you image-based question. फाइन, तो ये कंफ्यूजिंग टर्म्स हो गई. ड्रग ऑफ चॉइस फॉर कैटाटोनिया, इफ दे टेल यू दैट देयर इज अ पर्सन विद schizophrenia who is coming to you with this sustained contraction in this image based question, they ask you what will you first do. First I will give him lorazepam. So the drug of choice is lorazepam. Don't mark haloperidol. This is the biggest mistake you can do. You will mark haloperidol. So remember, this is lorazepam is what you will do in catatonia. But if it is resistant, not responding to lorazepam, then it is an indication for ECT, right? So this is one of the indications for ECT. Remember, now we don't do direct ECT. We only do indirect ECT. Indirect ECT ka matlab hai we have to give anesthesia. Without anesthesia, it is banned. Okay. Talking about prognostic factors, one thing which you will get wrong is acute onset and advanced age. Both are good. अचानक से schizophrenia होना and late older patient में होना are both good prognosis. बाकी सब is pretty logical. Catatonic paranoid subtype, you have female sex, which is a good prognosis. Positive symptoms can be treated. Mood disorder can be better treated. So बाकी सारे कर लोगे. This is where you will get confused. So remember this. This is about good prognostic factors. Okay. Going on to OCD related. This is the newer update in the classification. So I just want you to be aware of this. What are all grouped under OCD related disorders? One is hoarding, not throwing anything off. Body dysmorphic is also OCD. Fine. Body dysmorphic means you feel मेरा नाक ना टेढ़ा है. Your nose is completely fine, but you keep feeling that नहीं नहीं मेरा नाक खराब है. So that's body dysmorphic. Or factory reference that, oh, I am smelling very bad. I am smelling very bad. Then this is what was tested. 2 body focused repetitive behavior. Trichotillomania, OCD. Excoriation, all right, is again OCD. Excoriation means to keep scratching, right? So these are all OCD. Just remember this classification. Okay. Now coming to autism spectrum disorder. So the criteria previously included ki ek to impaired social interaction, second repetitive behavior, and third language delay. So now the newer classification says that this is not necessary, plus minus language delay. Okay. Few questions from autism you need to know. Which vaccine was linked, no longer linked, but was linked with autism? It is influenza, right? So influenza vaccine was linked. Remember, it was not proven, and this is not true. ठीक है. Regression. So tell me the autism spectrum. Very, very important question. In general, if a girl more than 6 months, they tell you microcephaly ho raha hai, regression of milestones, these stereotypical hand movements, they tell you hand stereotypical movements. What disorder am I talking about? I'm talking about Rett syndrome. All right. So I'm talking about Rett. Influenza and correct MMR. Yeah, my influenza and MMR, both of these vaccines were linked with autism. Okay. Yeah, you guys are correct. Influenza and MMR. So remember, Rett syndrome is when we are going to have this microcephaly after 6 months, and these stereotypical movements are going to be seen here. Fine. So remember this. The gene which is affected in Rett syndrome is MECP2. MECP2 gene is linked, which is on what chromosome? So if you know the inheritance, the chromosome becomes very easy. It is X-linked dominant. So remember, all 4 with X-linked dominant here itself, today itself, are. So what are the 4 things which are going to be linked with this? R for Rett syndrome, A for Alport syndrome, V for vitamin D dependent rickets, which is nothing but hypophosphatemic rickets. This is where you have hypophosphatemia, and I for incontinentia pigmenti, which I'm going to teach you in some time in derma. Okay, so these are all X-linked dominant. So hence the chromosome becomes X chromosome. Okay, the drug which has been approved last time ka INI-CT question is strophenitide. All right, so this is strophenitide. The name itself, no need to memorize. Tide means it's a polypeptide. It's a tripeptide. There are 3 amino acids. It's a tripeptide is what you want to remember. So the drug here is strophenitide in approved in Rett syndrome. Okay, so this question can also be asked. It is an IGF-1 analog. Okay, IGF-1 analog. But if I tell you in any gender, not just females, and any gender more than 2 years, then what is your answer going to be? Then what is the syndrome that I'm talking about? I'm talking about Heller's syndrome. Okay, so remember, Heller's is regression more than 2 years. Fine. So these are the high yield points from pediatric. Now, going to Psyche Pharma, everything clubbed here in one slide for you. So when I say maximum extrapyramidal symptoms are going to occur with what? So they're going to occur with typical antipsychotics. So the most potent is haloperidol because of D2 blockade. We have extrapyramidal. They've asked you with receptors also. So D2 blockade, haloperidol. 5 extrapyramidal or 4 extrapyramidal side effects we need to know. If it occurs in hours, timeline very, very important. It is acute dystonia. Here they will give you image-based question wherein, okay, here they will give you image-based question wherein they'll show you that somebody comes to you with sudden uprolling of eye or sustained contraction of sternocleidomastoid or trismus. Any sustained contraction in hours after injecting haloperidol, acute dystonia. If it occurs in weeks, days to weeks, and you have restlessness, subjective restlessness, just got to move around here and there, feeling so nervous, happens to us before exam, right? That is akathisia. Then after months of taking antipsychotic, we can have Parkinson's symptoms like rigidity, bradykinesia, rest tremor, okay? And finally, what occurs after years and years of treatment is tardive dyskinesia. Tardive dyskinesia, why does it happen is a repeat question. Remember, it happens because of hypersensitivity to dopamine receptors. Hypersensitivity हो गई. आप किसी को बहुत time तक block करके रखोगे, they'll become very sensitive, right? So same happens to D2 receptors. They've been blocked for a long time, they become hypersensitive. Now the treatment for all of them. So remember, first and 3 go together. For acute dystonia and Parkinson, the treatment is going to be anticholinergic drugs. Okay, so in the option, they can either give you a pure anticholinergic like hexfenadil or benzhexol, they can give you, or they can give you antihistaminics, right? So antihistaminics or anticholinergics here will be your drug of choice. So they can give you promethazine. Usually in the options, they give you promethazine. Okay, so any anticholinergic will do the job. What about akathisia though? Akathisia, the drug of choice is beta blocker. And lastly, in tardive dyskinesia, never give anticholinergic. They are contraindicated. The new drug approved for this is VMAT inhibitor. So what do we give now? In tardive dyskinesia, we can give tetrabenazine, right? So we can give tetrabenazine. Any VMAT inhibitor can be given here. All right. So this is what you need to know about extrapyramidal side effects. Now let's go to atypical antipsychotics. So now tell me which is the one which is the best drug but has the worst side effect. So I can give tetrabenazine, valbenazine, both of them are approved. Okay, both of them you can remember. Fine. So remember, the one drug which has minimum EPS has maximum metabolic side effect, and because it's the most efficacious, it is the drug of choice for refractory psychosis. Refractory psychosis means any two you have given, more than 2 antipsychotics we have given and it's not responding. This is what is known as refractory psychosis. Obviously, I'm talking about clozapine. We don't use it before refractory because it has seizure, it has myocarditis, it has agranulocytosis. Agranulocytosis is the most threatened side effect, and that's why we have to constantly monitor. Once a week for 6 months, we have to monitor the patient, and after that, we can reduce the frequency. What is the cutoff when we need to stop? So if WBC becomes less than 3000 or the absolute neutrophil count becomes less than 1500 is the indication to stop clozapine. Okay. So now, two things which atypical antipsychotics do is they can cause 5-HT2A inhibition and 5-HT2C. They are usually serotonergic receptor inhibitors. What gives them what ability is also a repeat question. So remember, 5-HT2A inhibition से dopaminergic activity actually increases. ज्यादा हो जाएगा. Whereas 5-HT2C inhibition से क्या होगा? It leads to metabolic side effects. So if they ask you कि weight gain किस receptor से हो रहा है, it is happening because of 2C inhibition. Fine. Is this clear, all of you guys? So ये हो गया हमारा side effect of clozapine and atypical antipsychotics. Few other one-liners. Which typical antipsychotic causes QT prolongation and retinal pigmentation? Both. These are both going to be because of thioridazine. Okay, so thioridazine has R in it, R for retinal pigmentation. Okay, any other drug that you know which causes QT prolongation? QT prolongation is because of one other drug. Remember ziprasidone. So one more drug that you can remember here only is ziprasidone. But agar मैं retinal pigmentation भी डाल दूं, then it is thioridazine. Okay. Then one-liner question. What is the drug of choice for PD induced psychosis? I just see P's here, है ना? तो P ही याद रखो. Parkinson and psychosis. P for pimavanserin. Okay, so PPP is what we remember. Fine. Most common side effect of SSRI, if they ask you in an acute setting, it is GI. है ना, जो हमें पता ही है, nausea, vomiting, diarrhea. Here it is the most common. But most common chronic side effect is sexual side effect, something for which you may have to change the drug also. So sexual side effects. Other important side effects which can be tested, SIADH, very important side effect of SSRI. Vivid dreams, sweating and dry mouth. So this is the only place. Everybody pay attention now. This is the only place जहाँ पे आपको साथ में स्वेटिंग मिल रहा है, कोलिनर्जिक एंड ड्राई माउथ मिल रहा है, एंटी कोलिनर्जिक. वेरी यूनिक. दिस वाज आस्क्ड वंस. ऑल ऑफ द फॉलोइंग आर साइड इफेक्ट्स ऑफ एसएसआरआई एक्सेप्ट सेक्सुअल लिखा था, जीआई लिखा था, एसआईडीएच लिखा था, एंड दे रोट लैक्रिमेशन. इट्स नॉट लैक्रिमेशन, इट इज ड्राई माउथ. ओके, इज दिस क्लियर एवरीबडी? तो ये पोटेंशियल क्वेश्चन. फाइन. देन व्हेन आई आस्क यू व्हिच ड्रग इज अ स्पारी एजेंट, okay, which is the sparry agent? Sparry agent means it's a serotonin reuptake inhibitor but also partial agonist. Dual mechanism है, two new drugs. इससे अगर question आया, I will take party. It is vilazodone. All right, so this is vilazodone. It is the mechanism is sparry. Another new drug from V, which is a modulator. Look at its action. 1A पे agonist, 1B पे partial, 3 को inhibit कर रहा है. So very weird mixed sort of action. What is this? This is vortioxetine. All right, so this is vortioxetine. Okay, so just remember ऐसे दो drugs हैं, vilazodone and one is vortioxetine. Okay, fine. इसका mechanism देख के you will be like what? Okay, so that's how you'll remember what. All right, so if you remember what, तो दूसरा भी हो जाएगा. So what is what? Another one is another with V, जो है स्पारी, है ना? तो इतना याद रखेंगे. फार्मा में never sit and memorize name of drugs. Just see what and then you will be able to see in options, right? That's how I study pharma. Next, antidepressant of choice in pregnancy, it is sertraline. So remember, per se pregnancy and per se paroxetine. Paroxetine is the one which is most teratogenic, है ना? तो वो PP दोनों साथ में नहीं जाता. This is most teratogenic, whereas sertraline is the antidepressant of choice. ठीक है? Fine. Then minimal sexual side effect. Minimal sexual side effect will be with mirtazapine, whereas minimum metabolic, minimum sedation, but it has a side effect of seizures in bulimic, and it's also an anti-smoking drug. Now, which drug am I talking about? Here, people confuse buspirone and bupropion. So, buspirone is anti-anxiety. Usko साथ में छोड़ दो. Here, we are talking about bupropion, right? So, we have bupropion, which is anti-smoking, and one of the, and what you have to remember, another important question, which drug causes priapism? We remember trazobone. If you remember trazobone, you will not go wrong. So, trazobone causes priapism. Fine. Bupropion is what class? It is an NDRI, norepinephrine dopamine reuptake inhibitor, anti-smoking drug. Another anti-smoking drug that you should know of is varenicline. Varenicline is a nicotinic acetylcholine receptor partial agonist. ठीक है. TCA toxicity drug of choice, sodium bicarbonate. We give it if QRS is more than 100 millisecond. Okay, so this is something that they keep asking. Toxicity is like any other toxicity, CVS and CNS. Okay, LA may be CVS, CS, TCA may be CNS, CVS. If they ask you theophylline, CNS, CVS, so nothing very fancy to be memorized. है ना, सबका यही होता है. So this is sodium bicarb. Can I do hemodialysis for sodium for TCA toxicity? Answer is no. No role of hemodialysis. तो यही question आया था. All of the following can be done except hemodialysis is your answer. Which is the new drug which is approved for postpartum depression? Remember, it is brexanolone. Okay, so it is brexanolone or zuranolone. इससे first कैसे जाऊं यार? how do I go faster than this? I will try, but it is difficult because I have to speak. No, listening is always easier. You can do it on 1.25x, 1.5x, but speaking on 2x is not possible. No, so brexanolone and zuranolone are the two drugs. This is the one which is IV, given as long IV infusion, whereas zuranolone is given as oral drug. Okay, so this is what has been approved now. Drugs with anti-suicidability. One is lithium, second is clozapine. Okay, so this is what is extremely important. Yeah, you guys are correct. These are both GABA A modulators. Okay, these are both new drugs which are GABA A modulator acting on postpartum depression. And this is new drug lecanemab, because it's INICT. I have collected some new drugs also for you. What is the new drug? This is the new drug which is approved for Alzheimer's disease. It's a monoclonal antibody जो amyloid beta को ही, the long chains which are accumulating, usi ko it will destroy. Okay, so remember, this is approved for Alzheimer's. Remember, lay Alzheimer's. Okay, that's how you will remember. Okay, so these are your psyche pharma in one line. Very important slide of all psychiatric emergencies. Just focus on buzzword. Clonus, hyperreflexia if they are giving with altered mental status, and they give you risk factor. Ya to you have combined two categories, or any other serotonergic category of psyche drugs, or two important drugs, tramadol, linezolide, or ondansetron or triptan. Basically आपने serotonin uptake increase कर दिया है, or amphetamine, or something known as what? It is serotonin syndrome. So remember, somebody who is a depression patient gets admitted for sepsis, gets a drug, and then develops this syndrome, you have to suspect linezolide. Something of that scenario they will give you. Remember buzzword clonus. Typical antipsychotic ले रहा है patient को, altered mental status and fever, something like serotonin again, but now I have muscle rigidity, no clonus. What am I talking about? We are talking about neuroleptic malignant syndrome. The same thing if I see in an anesthesia patient has gotten some inhalational anesthetic or has gotten succinylcholine, it is known as malignant hyperthermia. This is linked with ryanodine RDHPR receptor on chromosome 19. Drug of choice for both of these. Why am I doing this together? The drug of choice for both of these is going to be dantrolene sodium. Okay, so we have finished two things. Tyramine rich food and MAO inhibitors, very clear. This is what is known as your hypertensive crisis. Okay, so red wine की बात हो रही है, cheese की बात हो रही है, and the person is on depression of older antidepressant like MAO inhibitor, hypertensive crises. Okay, then extremely important, they mention about ataxia, they mention about nephrogenic diabetes insipidus, and some sort of volume loss was happening है ना. अगर AKI, ACE inhibitor, NSAIDs, diuretics, or the person has gone into diarrhea, hypovolemia. What is this? This is lithium toxicity. So body treats lithium like sodium. Anytime we will have, increased reduced GFR where I need more sodium reabsorption, the body will also reabsorb more lithium, and that is what is going to lead to lithium toxicity. So remember this concept. They will give you, somebody has low fluid status, either they tell you diarrhea or they tell you some diuretic intake, it is lithium toxicity. Concept याद रखना है ना. नाम होगा BTR, but रटना कुछ नहीं है, सब कुछ समझ के जाना है. So this is lithium toxicity. So this is respiratory. The next one we have already done, prolonged QT, coma, cardiotoxicity, convulsion. So CNS, CVS, we are talking about TCA toxicity, sodium bicarb, drug of choice. Okay, so these are the important questions here from psyche. Very important, the levels of lithium. What is the level of lithium for prophylaxis? 0.5 to 0.8 milliequivalent per liter. 0.8 to 1.2 is acute mania. Anything more than 1.5 is toxicity. Anything more than 4 is dialysis. But I hope you guys remember, if patient is presenting with ataxia, if patient is presenting with hyperreflexia, will you tell patient कि no, पहले 4 तक लेवल लेके जाओ, फिर ओनली आई विल डू डायलिसिस? नो, यू विल डू विथ एनी लेवल. अगर लेवल 2 है and patient को symptom है, will you do hemodialysis? Yes. All right, this is one mistake all of you did in T&D. Do you remember this mistake? So this is dialysis or symptoms of toxicity. What is the T half of lithium? It is 24 hours. And when do we measure? We measure around 5 days after starting lithium. Why is that? Because in pharma, we study that a drug reaches steady state after 4 to 5 half-lives. So pharma ka concept bhi yaad rakho. Steady state comes after 4 to 5 T-halves, and that's why we measure. And if they ask you after last drug, what hours after the last dose? 12 hours after the last dose. Okay, so 12 hour after last dose. Fine. So these are questions on lithium. A confusing term here on levels of consciousness. So one is alert. Right now, you all are alert. You are typing answer, you are laughing, you are sending hearts. You guys are all alert. Okay. Yeah, but in some time you are gonna enter lethargy or somnolence. When I ask you batao bachcho answer, only then you will answer. Only when stimulated you answer. That is lethargy. In some more hours you will go into obtundation, where mummy will keep slapping you, utja beta padle, utja beta padle. Active stimulation needed, only then you will study, is obtundation. In a few days you will reach into stupor and semi coma, where no matter what stimulation, mother, eye, whatever you get stimulated, you don't care. You are not moving, you are not speaking. Akinetic mute is stupor, है ना? तो कुछ दिन अगर ऐसे ही क्लास चलती रही, we are all gonna be akinetic mute. And finally, end stage कॉमा, है ना, कि कोई कॉन्शियसनेस है ही नहीं, दैट इज कॉमा. सो दीज आर द स्टेज. इन बिटवीन टू phrases get asked a lot. One is twilight state and one is oneroid state. So both are these beach mein, somewhere in between, near the obtundation stage, you have these two dream like state where you feel ki am I sleeping, am I dreaming, what is this class, what is going on? If you have reached that stage, that is your twilight or oneroid state. So if they mention the word dream like, if they mention the term visual hallucination जैसी feeling आ रही है, but it's not a visual hallucination, it's visual hallucinatory state. That is what is known as oneroid state. Okay, so you remember these two terms, these have also been tested. Okay, clear. Alcohol withdrawal, most important. What is the earliest symptom? It is tremor. Tremor is the earliest, can happen as soon as 6 hours after last drink. Alcoholic hallucinations and delirium tremens both have hallucinations. In delirium, you have delirium plus hallucination. So that is what is the difference. Here, consciousness is normal. Here, person is in delirium. Timeline, this will always happen after 48 hours. If they give you less than 48 hours, you mark alcohol hallucinosis. I hope this is clear. Don't get this wrong. More than 2 days after the last drink, you have loss of consciousness, altered consciousness, delirium, and then hallucination. It is delirium tremens. Okay, will you remember this? I hope this is clear. What is the treatment of choice for anybody in alcohol withdrawal? We will give benzodiazepine as drug of choice. Anything else you want to give these patients who are alcoholic? We have to give them thiamine. And should I give thiamine akele, alone, in these patients who have alcohol withdrawal? Never give thiamine alone, always give it with dextrose. थोड़ा biochemistry घुसा देते हैं. Why not alone thiamine without dextrose? Because what does thiamine act on? Thiamine acts on pyruvate dehydrogenase. If I don't have glucose and I activate PDH, what will happen? This pyruvate is going to become into lactate, right? So we will have so much lactic acidosis. So we don't want just thiamine. I want glucose and thiamine both, so that pyruvate can be formed, right? So that PDH can act. Some glucose is there so that it can go to TCA cycle. Okay, clear? Which benzodiazepine you will give? Very, very commonly asked. Remember, lot drugs. So lorazepam, oxazepam, टीमाजेपाम. सो लॉट ड्रग्स आर सेफ, जिसमें से एक बताएंगे लोराजेपाम. ठीक है. देन एंटी क्रेविंग के लिए क्या दोगे? पहले हम बोलते थे अकैम्प्रोसेट, बट नाउ बेटर इज नाल्ट्रेक्सोन मोर देन अकैम्प्रोसेट, है ना. सो दिस इज अबाउट अल्कोहल. हेरोइन की बात करते हैं. टॉक्सिसिटी में व्हाट आर द सिम्टम्स यू विल गेट? इट्स अ डिप्रेसेंट, एक्सट्रीमली इंपॉर्टेंट. यू विल हैव रेस्पिरेटरी रेट विच इज गोइंग डाउन and meiosis. It's a depressant. Drug of choice for toxicity is naloxone, but withdrawal, cold turkey, बहुत important. We will have midriasis, and with midriasis you will now have cholinergic symptoms. So here आपको क्या मिलेगा? आपको मिलेगा sweating हो रही है, किसी को lacrimation हो रहा है, किसी को yawning हो रही है. Very specific. Please don't forget this. Now tell me two things. दो contradictory चीज. एक contradictory चीज I already told you. What was that? This is the second one. जहाँ पे midriasis के साथ मुझे cholinergic manifestation मिल रहे हैं. What was the first contradictory thing where I told you? Cholinergic, anticholinergic, both are going together. आज ही पढ़ा है. These are the two things. And in withdrawal, what is the drug of choice? The drug of choice is, by the time you answer, I will go on. The drug of choice for this is gonna be methadone supplementation. Okay, so these are the two things that you want to remember as far as heroin toxicity goes. Okay, so this is about the points of psychiatry. Yeah, one was SSRI ka side effect, and second one is this. Will you remember both of these together? ठीक है? All right. ठीक चल रहा है सब कुछ? आर यू गाइज ओके? गोइंग ऑन टू सेकंड पार्ट. 7-year-old चाइल्ड. सो दीज आर ऑल नीश क्वेश्चंस जो हमने अभी तक कवर नहीं करे. सो बेड वेटिंग हो रहा है 7-year चाइल्ड में. एनी चाइल्ड हु इज मोर देन 5 year, वी डिफाइन दिस एज nocturnal enuresis. Okay, so that is the timeline. उससे पहले it is physiological. Fine. So this is nocturnal enuresis. Always the first line is this Bell pad based classical conditioning. Anytime the bedwetting happens, an alarm should go off, and धीरे धीरे child will stop to it doesn't want to wake up from sleep, right? Like any of us, तो he'll stop voiding क्योंकि alarm उसे उठा देता है. Okay, FMG BTR की बात करेंगे ना, अभी नहीं, अभी आईना ही हो जाने दो इनका. इसके बाद it's all about FMG, है ना? तो I will take a class on Monday or Tuesday and we will plan. Okay, fine. Patient says that he feels that there's something wrong with him mentally and it is because of summer season. What would he score on the insight scale? So what is this? When you have awareness but you blame it. So let's do the scales level of insight. Level 1. So let's relate to something that you guys can understand. So let's say you didn't do well on your GT. The first level would be denial. मैंने अच्छा नहीं किया, ऐसा हो ही नहीं सकता. No, I have done well. That is first stage, which is denial. Second is awareness कि यार result अच्छा नहीं आया. And then you go on doing your thing. फिर friend का call आता है, चल चल party चलते हैं. You are like हाँ चलते हैं. So second is awareness है कि अच्छा नहीं किया, that you didn't do well but don't care. Third is you are aware but you blame it. I didn't do well because GT was bad. बहुत tough test set करते हैं यार, इसके तो देने ही नहीं है. Blame. So fourth one is now when you have intellectual insight. I have not done well in my GT. I need to analyze why have I not done well. Was it recall error? Was it because my concepts are not good? I'm not applying well. And fifth is emotional insight, that okay, I have analyzed that it was because of a lot of recall errors. That's because I'm just reading notes. I'm not doing active recall. So this is what is known as emotional level of insight. तो इसने क्या करा है? बोला summer season के कारण. So that is level 3. Okay, so these are the insights. Fine. Then we have what is false about bipolar. So sometimes they ask you these weird questions on epidemiology. Don't go and sit and study all epidemio because of these questions, but inke answer dekh lo, right? In psychiatry, epidemio is not something that you study, it's just something that you study from PYQs. Okay, so what is false about bipolar disorder? It is not something that affects 35 to 45. It can affect like a wide spectrum of age from adolescence till elderly. So ऐसा कुछ नहीं है. It type 1 is common in both sexes. Okay, prevalence in general population is 1 to 2%. Okay, fine. Attempt to suicide is 15%. तो बस ये 3 point देख लिए, that's it. Now don't sit and study entire epidemiology of bipolar. ठीक है. Then what is this image? देख के सब लगेगा कि सब कुछ ही है, but it is known as a hypnogram. When you study the different phases of sleep and how much time you're spending in each of them, this is known as hypnogram. ठीक है, तो this is the answer to this. चलो next बताओ जल्दी. 14-year-old girl with sudden onset blindness for 4 hours. She is not concerned. इसको बोलते हैं labile indifference. But there is a stressor that her mother has passed away. Physical exams are normal. So this is what is known as a conversion disorder or a functional neurological disorder. What is the epidemia? Again, just know the answer that in children it is more common in females than in males. How many of you have seen Never Have I Ever? You know Devi, right? So Devi there has also, she also has paralysis. So with that only you can remember Devi is a child or an adolescent and she is a female. तो मैंने तो इसी से सॉल्व करा था ये क्वेश्चन दैट ओ देवी इज अ चाइल्ड एंड मोर कॉमन इन फीमेल. सो दिस वे यू कैन समटाइम्स सीरीज कैन हेल्प यू if you are a nerd and also like to watch series. This is how you can get result. Mutism and akinasis in a person who is aware of his surrounding and somewhat alert. So what did I tell you? Mutism, akinasis. In some days, if this class continues for days, you will not speak, you will not move only. That is known as stupor. Okay, which is not a feature of atypical depression. Atypical depression is something you will all relate to. More sleep, reactive mood response है ना. Right now you are sad but then friend will call, चल 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 party चलते हैं, then you'll be very happy. So ऐसा नहीं कि persistently you are anhedonic, you are hedonic. Okay, so you have mood response to positive stimulus and heaviness of body. ऐसा लगता है कि body काम ही नहीं कर रहा. So that is all symptoms of atypical depression, but it does not respond better to TCA. It does respond well to SSRI. SSRI is the drug of choice for that only. ठीक है. So this finishes psychiatry. So I think it took more time, much more time than I expected. I thought 30 minutes, one subject I will easily finish. But clearly that's not the case. But now we will slowly increase. Are you guys okay? Can we go at this speed and maybe somewhat faster? The problem is I'm not getting your replies immediately. Like I have to wait for your answers, which I'm not waiting, but still I can't see your answers like immediately. If that was happening like in Zoom, no, it would really help my speed. But anyways, it's fine, right? We make do with what we have. Okay, chalo shuru kare. So 1 out of 8 done. Second one to go. 5 minutes का break नहीं. ऐसे करेंगे तो कभी खत्म ही नहीं होगा. Stupor में चले जाएंगे. We don't want to go in stupor. Okay. All right. Let's start off with derma. All spotters. Fatafat. We will do spotters. What is the first one? 2 erythematous lesions for you. Small lesion in the hand. This is erythema multiforme. Okay, this is erythema multi. I love that you guys are asking me to go faster. It just means you are confident with the content and you guys are not feeling like, ma'am, ये सब क्या पढ़ा रहे हो? What subject is this? So that's good. It makes me happy. So this is erythema multiforme, which are small lesions associated with herpes simplex, associated with mycoplasma, associated with a drug which is chloroquine. Remember, chloroquine is bullseye maculopathy. So to target bullseye in the eye, bullseye in the hand. When I see a tick bite, forest officer में ऐसा lesion मिला. What is it? It is erythema migrans. Erythema migrans suggestive of Lyme disease, association with hard tick bite. Borrelia burgdorferi. Okay, psychiatry, one question missed. Where? एक तो हर जगह छोटे-छोटे question है. Which question missed? No question missed, no? Okay, next. So this is erythema migrans, Lyme disease, heart tick. Then we have this. When you see these extensor surface with erythematous plaques and then you have silver scales, this is typical psoriasis. Psoriasis, if it is less than 10% involvement, we can give topical steroids. But if it is more than 10% involvement, so this is for less than 10%. If it is more than 10%, then what do we give? Do I give systemic steroids? No, not systemic steroids. What do we give for more than 10% involvement? I have to give either we can give PUVA, UVA radiation with Soralen, or we can give narrow band UVB radiation. If it doesn't respond, we go on to methotrexate. Very important. ठीक है? But when I show you this pregnant lady with this diffuse pustular, look at the pustular lakes. What is this? This is pustular psoriasis in pregnancy. What is the name I want you to remember? It is impetigo herpetiformis. A complete misnomer. ना ही ये impetigo है, ना ही ये herpes से हो रहा है. This is impetigo herpetiformis. I want you to tell me drug of choice. That is why I have brought it up. The drug of choice here is steroids. Can I give PUVA. Can I give radiation in pregnant female? I can't. Can I give methotrexate? No, category X. So the only treatment left for me is steroids. Okay. Then when I show you this lesion, photo exposed area. So any area which is exposed to sunlight has these lesions with central clearing. This is DLE, has been asked twice now. So if they show you face with the central clearing wale lesion, DLE, discoid lupus erythematosus. All right, very, very important. And again, two more ring lesions I wanted to show you. So look at the first one where there is a big lesion, which is the Herald patch. And then you have this Christmas tree arrangement of multifocal lesions. What is this known as? I've told you all the clues. You will tell me two things. You will tell me diagnosis and you will also tell me what kind of scales am I going to see. Here, the diagnosis is pityriasis rosea. And the scales I will see is known as either cigarette paper scales or a collarette of scales. This is linked with HHV 6 and 7. Kaposi sarcoma, HHV 8. साथ में ही याद रख लो 6, 7 यहाँ, 8 Kaposi. Okay. Next, if I show you this true annular lesion and you are seeing that scales attached here, central clearing, this is typical tinea, right? So this is typical ringworm tinea corporis. This is what we need to remember. Agar scales hai, central clearing hai, so all DDs I have just brought together for you. Okay. Then if I show you the face of a person with these hypopigmented lesions, you will ask me two questions. Ma'am, is there sensory loss? If there is sensory loss, this is known as indeterminate leprosy. This is the type which is there in the Indian classification, not in Ridley-Joplin. But if I tell you, no, there is no sensory loss, but there is indeed some itching and there are some scales, then this becomes pityriasis alba. Okay, so this becomes P alba. Very, very important. The same image came in Ames INICT where you have the central crusting now. I am having this central crusting. And what are you seeing? If I put a slide and press, I'm going to see apple jelly nodules. What is this? This is lupus. This is TB. Lupus vulgaris. Vulgaris mane most common. Okay. So this is about the spotters in the first image. Is the speed fine now? Because you guys, I think, are not writing everything. I'm just going a bit faster. I'll give you the PDF. Okay. Fine. Next, two diseases particularly important for INICT, where you see these crop grains, crop ronds. And I'll give you one more hint. If you look at the nail here is going to show you a V-shaped defect. What is the diagnosis here? It is Darier's disease. But when you see this erythematous plaque here, and if I give you the nail appearance, the nail is going to show you these longitudinal lines, dilapidated brick wall appearance. Diagnosis is Haley. So how to remember? What question they will ask you is what is the defect? The defect here you want to remember is the ATPase defect. So here the ATPase, calcium ATPase, which is defective, is 2A2, whereas here it's 2C1. So how to remember is Halley's comet. Halley की comet ने आके brick wall को तोड़ दिया. Dilapidated brick wall. Halley's comet broke the brick wall. Dilapidated means destroyed. ठीक है, ऐसे करके याद रख लो. All right. Yeah, this is central scarring. Central scarring, not crusting. Like थोड़ा terminology is also important. So this is central scarring. Okay, not crusting, because crusting is Kala Azar. Very good. So this is Darrier and Haley. Okay. So this is a sign कि पूरा का पूरा BTR हमें word to word याद है कि मैम crusting के नीचे scarring है, scarring के नीचे clearing है. If you go wrong, we will correct you because we have studied more than you. So I'm very happy that you are doing that. So we have Darriers and we have Haley. Okay. Right. Next one, we have erythrasma. So this is erythrasma, which is associated with Corynebacterium minutissimum. also known as Corynebacterium, not diphtheria. Okay, so just remember it's a Corynebacterium, which is not diphtheria. So this is Minutissimum. If I do a UV Woods lamp examination, I will see coral red appearance. ठीक है? Then what is this? Black velvetish patches. This is Acanthosis nigricans. So either you will have a fat person, obese person with metabolic syndrome, or they can give you paraneoplastic syndrome. So either paraneoplastic देंगे या फिर आपको कोई ना कोई metabolic disorder देंगे. Fine. Then what is this? This is known as a disease of apocrine glands or eccrine glands. That is my first question. Is this eccrine problem or apocrine problem? So when you see that there are these spots which are happening, this is what we call as the Fox-Fordyce disease. Where do we have eccrine? Eccrine is not associated with hair follicles. Apocrine is what is associated with hair follicle. So anytime you have a problem with axilla or groin, remember axilla या groin में problem है, it is going to be a problem with apocrine. All right, so this is a problem with apocrine sweat glands. Eccrine में problem है, that is your mylaria, है ना, mylaria crystallina, rubra, वो सब acrine में problem है. Okay, but don't confuse it with these spots on the lips. These are known as Fordyce spots. So these are what? These are not apocrine or eccrine. These are ectopic sebaceous glands. Okay, so this is very important. Two types of leprosy lesions can you classify according to Ridley-Jopling? The first one, these are the only two that they'll ask you. Santa Banta. What is Santa Banta? If you see satellite lesions, you see nerve abscesses. So SN Santa is Banta borderline tuberculoid. And when you see anything else, when you see central clearing, geographic, you see annular. What is this? This is what is known as your BB. So in the exam, BB is what is most likely to be asked unless you see satellite lesions. Okay. What is the diagnosis? Non-scarring alopecia, patchy alopecia, spares white hair. If I see histopath, I will see swarm of bees appearance, association with other autoimmune disorder. I will see question mark appearance. What am I talking about? Alopecia areata. If I look at the nails, I'm going to see regular pitting versus irregular pitting seen in psoriasis. Okay. Then what are these erythematous polycyclic vesicles? Erosions, the only STD where you don't see ulcers, but you see erosions and vesicles. We're talking about HSV 1 or 2. Below the diaphragm, 2. Above the diaphragm, herpes labialis, encephalitis, HSV 1. Okay, so this is what you need to remember. What did I say? Exclamation mark, right? Did I say something else? I might. Okay, so exclamatory mark, but I think you will understand. Fine. Okay, so this is about HSV. Now going on to the next one. When they show you white, there's just so much to say very quickly that sometimes my mouth might not be in sync with brain, and I might say question mark instead of exclamation mark, but I think you will understand. Okay, so here we have white forelock of hair, and then you have these islands of sparing. What is this? What is this known as? This is known as piebaldism. But the same thing, if I show you white forelock of hair with heterochromia iridis, agar heterochromia iridis के साथ बताऊंगी, then it becomes Waardenburg syndrome. Okay, then it's called as Waardenburg syndrome. Okay, so these are two things with white forelock. Then next one, when you see a baby with a membrane, so this is how they will describe that a baby was born with a membrane. It is a colloidal baby. Nobody will ask you this. They will give you options like ichthyosis vulgaris, X-linked ichthyosis, or lamellar ichthyosis. So this is lamellar ichthyosis. So here there will be colloidal baby, and then the scales are going to be on the trunk. If the scales are in the limb, it is typical vulgaris, but only trunk, no colloidal baby, only trunk is X-linked. All right, that's X-linked. But if it is colloidal baby and trunk, then it's lamellar. ठीक है, तो ये कंफ्यूज मत करना. Now tell me, what is this disease जिसके 4 phases I am showing you? What are these 4 phases which I am showing you here? The first one is vesicle. then it becomes verrucous. You can see this verrucous appearance. Then you have hyperpigmented, and then you have hypopigmented. किसकी बात कर रहे हैं? We are talking about incontinentiae pigmenti, which we already know from Ravi, because it is X-linked dominant, and these lesions occur along Blaschko lines. What are Blaschko lines? These are lines of embryological development of the skin. So here they will show you these two figures. Imagine these are two figures of people. How will you distinguish whether it is Blaschko line or it is Langer's lines? So if you see that they are meeting at the midline, it is Blaschko. If they are not meeting at the midline, continuous है, midline पे vertical नहीं आ रहा, that is known as Langer lines, along which you give incision, because this is how collagen is arranged. Okay. I hope you guys are understanding, because I am getting your comments like 1 minute later. All right. Don't pass comments like RIP to BTR subscribers. We will take this video down and it will only be available to subscribers. So itni negativity mat phailao life mein. Okay. Next, we have fixed drug eruption. So this is fixed drug eruption, which is only the name itself tells you everything, that it will happen in fixed site with fixed drugs. Okay, so what is the fixed site? It will happen in genitals, it will happen on face. These are the common sites where it will be seen. And the drugs which it's associated with is NSAIDs, is the most common drug with which fixed drug eruption is seen, and it's a type 4 hypersensitivity reaction. Okay, and they have asked you one more question. It heals with hyperpigmentation. It's gonna leave hyperpigmentation. Okay, fine. Next, what is this? This is what is known as the Darrier sign. What is Darrier sign? Darrier sign is SSS और lamellar ichthyosis में confusion होता है क्यों? See, Staphylococcus scaldate syndrome, baby is not covered with membrane at birth. No, there you will have scalding. All right, that will be seen in infants. If they describe baby was born in a membrane, it can't be Staphylococcus scaldate skin syndrome. Got it? अच्छा, पूछा ये तो ये बताओ, Staphylococcus scaldate skin syndrome, will it involve oral mucosa or not? Oral mucosa involve होगा या नहीं होगा? Oral mucosa will not be involved. Remember, it is the subtype DSG1. This is like DSG1, pemphigus foliaceus, where oral mucosa is not involved. ठीक है? Fine. This is cutaneous mastocytosis, where you are seeing this Darrier sign. And the mutation here, you can remember this associated with CKIT or CD117. Okay, CKIT or CD117, just like GIST, it's associated. Fine. Now, two things, which is irritant contact dermatitis, which is allergic contact dermatitis. So if it's seen with detergent, stuff which can happen in anybody, no immunological mediation here, this is known as irritant. है ना कि detergent ही irritant है, irritant contact dermatitis. But if it's seen with certain things in certain people, type 4 hypersensitivity, again, it's allergic contact dermatitis. Like this person has had an allergic contact dermatitis against what? Against nickel, which is most common because artificial jewelry में ही होता है. So somebody has worn a ring with nickel, resulting in this. अभी लग रहा होगा ना क्या इतना easy. You will get confused in exam and you will in your hurry, you're gonna mark this as irritant. So don't get confused. ये something है जो यहाँ पे गलत हो सकता है. PPD, these are the common allergens we need to be aware of. This is what is seen in hair dye. Neomycin is what is seen in topical antibiotics. Dichromate is what is seen in cement. PTPB. Where do we see PTPB? This is something that you're going to see in Bindi adhesive. This is a repeat question. In Bindi adhesive, if they show you a female with red here, that is known as PTPB के वजह से allergic contact dermatitis. And what you can remember is अब उसको बिंदी नहीं लगानी पड़ेगी. There is permanent red there. Okay, so that's how you can remember. And monobenzyl ether of hydroquinone is seen in rubber chappals, in rubber, in slipper. If they show you somebody has either leukoderma or has dermatitis, it's because of this hydroquinone. Okay, so this is about this. Two images of acne, which are not common acne. What is this? Here, if I tell you there are systemic manifestations, there is fever, there is arthralgia, and they give you this fulminant acne, red, pura red. This is what is known as acne fulminans. नाम ही ऐसा है, fulminant acne, one variant of acne where you will have systemic manifestations. Then what you have to remember here is, no, it's a type 4 hypersensitivity. Okay, that's why what do? You do a patch test, isn't it? It's never type 1. Remember, we do a patch test. No, when do you read this patch test of allergic contact dermatitis? You're gonna read it at 48 hours and then 96 hours. These are your best answers. Okay, चलो ये हो गया. This one, which is the severe acne, which is conglomerating, nodulocystic का भी severe type. This is what is acne conglobate. Okay, that is what you guys are answering. This is acne conglobate where it's fulminant. फटाफट से acne का treatment बता दो. Step up. What is the first thing you will start off with? First thing is topical retinoid. Then I combine topical retinoid with topical antibiotic. उससे भी resolve नहीं हुआ, topical antibiotic के साथ oral antibiotic start कर दो, plus minus benzoyl peroxide. And if it doesn't resolve, then we go for isotretinoin. Isotretinoin, what is the most common side effect? Most common side effect is going to be cheilitis. Can I give it in pregnancy? I can't give it in pregnancy. It is a category X drug. The washout period is going to be 1 month. थोड़ा अलग अलग दिया है अलग जगह, but 1 month is the best answer. Whereas अगर मैं acitretin पूछूं, which we are giving in psoriasis, that has a washout period of 3 years. 3 years a woman can't get pregnant if she's taken acitretin. Okay. Apart from that, you have to monitor LFT. You have to monitor what else? Lipid profile, right? So this is about isotretinoin. Fine. ये कौन सा acne है? This is what is known as atypical acne, which is drug induced. Okay, so this is something because of drugs like steroids. This is will have two important features. One, it is monomorphic. It does not have these multiple stages. Second, there are no comedones. So no comedones and monomorphic is your drug induced acne. ठीक है everybody, इससे fast नहीं बोल सकती. Then what do we have here? Can somebody tell me this diagnosis? There is no fun because I'm not getting your answers in time. I'm asking and then I'm only answering. This is pitted keratolysis. This is pitted keratolysis, which is seen in Corynebacterium minutissimum. Again, this is another manifestation of Corynebacterium minutissimum. Okay. And what is this, which you can confuse with this? So I've kept both of these images together. यही वाले देख लो, यही आएंगे Google से hopefully. This is what is warts. This is nothing but viral warts, plantar warts because of HPV. All right. Next. What is this syndrome? This is just random, which was asked last time, where you have this tiger tail hair appearance. This is what we call as trichothiodystrophy. बस एक बार सुन लो, tiger tail, tiger जैसा नाम है. Okay. Then what you have to remember here? What is this? ये तो सबको ही आता है. Along a dermatomal distribution, this is zoster. All right. So this is herpes zoster that you have to remember. Herpes zoster, shingles, right? So here the most common complication is going to be neuropathic pain. There's going to be pain along the neuropathy. Question जो मेरे दिमाग में आया है is, what are the two things where you will see along a dermatomal distribution? So one is shingle, second one, remember, segmental vitiligo. Also a question. So when you see such a segmental distribution, there are two SIRS that you want to remember. So this is varicella zoster, shingles, reactivation. Okay. Then what is this? This is molluscum contagiosum. This is MCV, which because of pox. It is a pox virus. Remember, molluscum contagiosum is a pox virus. Varicella zoster, even though it has chicken pox, is not a pox virus. It is herpes. नाम में ही है herpes zoster. It's a herpes virus, but this does not have the name pox in it, but it's still a pox virus. Okay, has these Henderson Peterson bodies. Okay, big name, HP bodies. बड़ा से stain भी होगा. Fine, big name it will have. So that is what you need to remember. Going on to vesicobullous diseases. Epidermolysis bullosa is congenital or acquired. Congenita or acquisita. Congenita has 3 types: simplex, junctional, dystrophic. You need to know the target. For simplex, it is keratin 540. For junctional, it can be integrin or laminin. And for dystrophic, most important is type 7. And this is also the target for acquisita. So this is where they will tell you about trauma, pressure-induced bullous disease. Fine. Important extra edge. Okay, so dystrophic is type 7. Where do we have a lesion in bullous pemphigoid? Oh, very easy. BP. So now, can you see how BP ऊपर है and type 7 नीचे है? So if I need to distinguish between dystrophic and bullous pemphigoid, we can do a salt split immunofluorescence. Yeah, this will be uploaded as recorded in the app. Okay. known as salt split immunofluorescence. तो जो BP है, bullous pemphigoid है, that shows you a defect on the roof. All right, on the roof because it's higher up. So this is BP, whereas epidermolysis bullosa is going to be on the floor. This is how you remember. One trick to remember is BP अगर पीते हो तो roof पे पीते हो. That's how you can remember BP roof पे पिएंगे. So this is about this. If you don't understand Hindi, you don't understand what is BP, what is PINA, forget it. Just remember BP on the roof. Then we have immunofluorescence patterns. What are the immunofluorescence patterns? So when you see this fish net pattern or you see this split, look at this split and tell me the diagnosis. This is what is happening just above the basal layer, right? So this is a supra-basal split. So supra-basal split, fishnet immunofluorescence is both things you see in pemphigus. So this is which pemphigus if I ask you? This is pemphigus vulgaris. Pemphigus vulgaris is DSG3. नीचे होता है split. Whereas pemphigus foliaceus, something that I related with staphylococcal scalded skin syndrome, is going to be ऊपर. It's going to be subcorneal split. So subcorneal, remember, is DSG1. The prototype is P foliaceus. ठीक है, सबको familiar लग रहा है ये सब? नहीं लग रहा तो बस याद कर लो. Okay, so this is pemphigus vulgaris. Then what is this? Where you have uptake at the dermo-epidermal junction. This is bullous pemphigoid, BP antigen. Here you will have tense bulle. यहाँ तक pemphigus flaccid bulle. Nikolsky positive. If I rupture, if I spread, they will rupture. Whereas these are tense bulle, will not rupture. So this is Nikolsky positive. This is Nikolsky negative. Fine. So this is all IgG and C3. BP and pemphigus is IgG C3. If I tell you there is linear IgA deposition, you will be very happy because name of disease is also linear IgA disease. How wonderful. And this is also known as chronic bullous disease of childhood. It will have this string of pearls appearance where lesions are around the mouth and the genitals. Then if you see this IgA deposition on the papillary tips only, it is known as dermatitis herpetiformis associated with celiac disease. Both of these drug of choice. कहीं पे भी IgA आ जाता है, the drug of choice becomes dapsone. Okay. I hope this is clear. This is a misnomer. Dermatitis herpetiformis, nothing to do with herpes, nothing to do with dermatitis. It's just itchy red lesions. That's why the name. Okay. This is also known as picket fence appearance. Very good. What is this image-based question? All of these are repeat questions. This is nummular eczema. Okay, so nummular discoid shape of eczema. Then we talk about atopic dermatitis. Atopic dermatitis in a child is going to have the involvement of face. Important. Face, scalp, ears in a child till 2 years with extensors. On the other hand, in childhood, again, till puberty, face and flexures. But in adults, no face involvement. Adults will only have flexural involvement. So after 2 years, it is all flexors. But before 2 years, it's extensors and the face. That's what you have to remember here. This is atopic dermatitis. Then if there is secondary infection by herpes simplex, what do we call it? This is what is known as eczema herpeticum. Okay, so eczema, herpeticum, I have just kept all of these names together so that you don't confuse it. It is not, so impetigo herpetiformis, eczema herpeticum. Remember this. So this is indeed herpes, secondary infection in atopic dermatitis. Okay, yeah, this does look like slapped cheek also, but slapped cheek में ऐसा crusting मिलेगा क्या? ऐसा oozing मिलेगा? If I tell you oozing है, crusting है, no. Slapped cheek erythema infectiosum will not have. It will only have a red macular rash, right? It will have this red colored rash without any crusting oozing. Okay, so that's how you can distinguish. ठीक है? And so this is how you will have lichenification. In adults, in chronic stage, we have this lichenification, more linear involvement in adults on the flexure. So this is about atopic dermatitis. Fine. Going on to the PYQs of derma now very quickly. So क्या दिखा रहे हैं इसमें? We're seeing the black dot appearance. Black dot मतलब inner part is involved. So that is endothrix. Caused by what? Trichophyton, microsporum, or epidermophyton. So TME is how we have remembered. Endothrix is going to be T. Ectothrix, which is a gray patch, is going to be micro, whereas E only involves the nail. Skin, everybody involves, right? So this is what you have to remember. So this is black dot. Agar pura gray patch hai, then it is microsporum, ectothrix. Can you also tell me the shape of their microconidia simultaneously? PSC, pencil, spindle, club. All right, so pencil, spindle, and club shape is what you have to remember. Okay, one of you asked how to distinguish with defense cuts. That's a good question, but will you have defense cuts at the elbow? No, right? So that's a good thought, but unlike you and I, the people who are going to set the paper will either know derma or they'll either know forensic. They will not know both. So you will not have options like, is this defense cut, hesitation cut, or is it atopic dermatitis? So चार option में दोनों कभी नहीं होंगे. All right, so that's how you will distinguish. So PSC, this is about the shape of the microconidia. Then patient with known case of chronic plaque psoriasis with more than 50%. Which one of these will you not recommend? इसमें आपको problem आ जाएगा not नहीं देखने का. So this is what we have to do. अभी I have made too much effort for this class. You guys have put too much effort into preparing. If you get a question wrong because you did not read not, that is something which I will not be happy about and you will also not be happy about, because we are both collectively very worried for your rank and your result, isn't it? So one thing you all promise me right now, before I go on and continue this session, is that, ma'am, we will be very careful in exam and we will not miss out on not reading not. Please promise me right now that in the exam, no matter what my emotions tell me, what my limbic system tells me, I will not panic. Everybody here, 4.7k people will type right now, I will not panic in exam no matter what happens. Write this entire sentence no matter how much time it takes. I will not panic in exam no matter what happens. Don't write this, but I am saying, so listen to me. I will be in control. I will not let my limbic system get the better of me. No matter if I don't know 10 questions, I don't know 20 questions in a row, I will not panic. I will read every question on its own merit. Answer is in front of me. I will choose the best answer. I will mark it. That is what you have to remember and ensure and promise me. Okay, if you can do that, you will all get rank. Hopefully we will all get rank. So that is what we are all preparing for, working hard for, and it will happen. If you are in control in the exam, it will happen. Okay, fine. Now let's go on. So which will you not give? We have just seen steroids has no role in psoriasis except impetigo herpetiformis, except pregnancy. All right, so other drugs I can give. Cyclosporin also I can give. This question has come twice. Very one-liner question. Dense irregular collagen is something that you see in dermis. Baki sab mein regular arrangement of collagen is seen. Okay, very good, very happy. Next, MI, methyl isothiazolinone is used as a preservative. That's just a one-liner that we need to remember. हाँ बस अब आ जाओ वापिस आंसर करो. Now answer. Match the following scale types with their lesion. So collar rate of scales we have seen 1B. तो ये तो आंसर बहुत इजी हो गया. 1B is collar rate. Let's just confirm 2C psoriasis. In such scenarios also, when you think that अरे आंसर तो यही है, क्यों पढ़ना बाकी का, let's save time, don't do that. Just confirm कि पक्का है या नहीं, is everything matching or not. Don't just leave it at 1B and go to next. ठीक है. One more tip for you. 3D mica like scales. I didn't know about this, but ठीक है, चलो यही होगा. Brany scales is Wurzi color. Okay, so this is about the types of scales. Which is the drug against tinea cruris, which is having widespread resistance? Earlier, this was the drug of choice for tinea corporis cruris. It was terbinafine, but now it is having more resistance, so we are preferring itraconazole. Griseofulvin is for tinea capitis, right? So this is also a repeat question. Tinea capitis, drug of choice. And remember, this is a microtubule inhibitor. Another microtubule inhibitor, very important, colchicine. Okay, so colchicine, griseofulvin, apart from two anti-cancer drugs where you have taxanes and vinca alkaloids. So these are all acting by microtubule inhibition. Okay. Next, what is this? So again, along a dermatome, what did I tell you? Leukotrichia, lesions like this is segmental vitiligo. If it's just this patch, I would have said focal, but when it's spreading, it's segmental. This is not piebaldism because no white forelock, not nevus depigmentosus. इसमें होता है vasoconstriction. So this is transient whiteness, will not have leukotrichia. It's a misnomer. It is not a depigmentosus. It is just transient vasoconstriction which happens because of problem with alpha receptors, and that is why this is seen. Okay, next is a good question. Which of the following should not be considered for the lesion in this forest officer? In the hurry, what you're going to see is you're going to see eschar, you're going to see forest, and you're going to go and mark scrub typhus. But no, do not miss, very important. अब तो promise कर दिया है, अब नहीं करेंगे, है ना गलती. So this is something where eschar is not seen in Kyanasur forest disease. It can be seen in scrub typhus. It can be seen in anthrax, spider bite also. It can be seen. Fine. Leprosy chemoprophylaxis should be given to which of the following people? Contact for more than 20 hours per week. This is one of the criteria. Anybody who is more than 2 years of age. This is the criteria. Living with patient of leprosy for more than 6 months. So yes, this is also technically true. So anybody who is living with the patient for more than 3 months, we have to give chemo prophylaxis. So 2, 3, 4 are correct. Sharing same clothes and towels is not in the criteria. So the criteria says anybody more than 3 months, age 2 years, for more than 20 hours per week. This is what you have to remember. And we give a single dose of rifampicin for chemo prophylaxis. All right, so this is about this. So now we have completed 2 subjects, 5 o'clock. We have 2 more hours to complete 6 more subjects. No, but we started late, right? I can take some more time. But radio we all know, isn't it? Radio is what we all love and we all just know. Whether I teach you or not, radiology questions you will not get wrong. One more promise that you will all do. चलो शुरू करें फटाफट. All spotters very quickly and then a few one-liner PYQs. Are you all okay? 2 minutes. All right. चलो रेडियो शुरू करेंगे. First with MSK. So in every, no break. You take break whenever you want. I will not take break. All right. So चलो शुरू करते हैं with all musculoskeletal. More than 2 years of age. This is age. मतलब patient का age more than 2 years. 2 साल से छोटे बच्चों को we don't give leprosy prophylaxis. All right. चलो. Are you guys okay? Are you guys enjoying the class? Depression में तो नहीं गए कोई? हाँ, nobody is in depression, no? कि मैम हमें तो कुछ नहीं आता. Are you guys getting confidence out of it that yes, मैम अच्छा active recall हो रहा है, isn't it? All right, चलो, let's start. So The first image, what I'm showing you, I'm telling you that this is a young male of 30 years of age who is coming and presenting with low backache. He also has uveitis. He also has bilateral heel pain, which is associated with enthesitis. This is what we call as enthesitis. Attachment is known as enthesitis. So diagnosis becomes ankylosing spondylitis. So this is, can you guys hear me if I talk this loud? I realize I'm literally shouting, and at this rate, my voice will go in the next 1 hour or so. Can you hear me at this volume also? Can I be this loud? So this is ankylosing spondylitis, HLA B27. What you're going to see is this complete fusion of the spine. You are going to see these vertical syndesmophytes which are fusing. This is known as track, and on a sagittal view or on a lateral view, what you're going to see is this complete fusion known as bamboo spine. Okay, so this is bamboo spine, this is track, this is ankylosing spondylitis. Okay, perfect. So I will be this loud now. Then the next patient, I'm giving you one hint. There is black discoloration of the pinna. There is black discoloration in the sclera. What is the diagnosis? Now, when I look carefully at the first look, I would have marked ankylosing spondylitis. But with this history, when I look again, you can see how the IV discs are appearing white. The IV discs are showing calcification. So now what is the diagnosis? The diagnosis becomes ochronosis, which is seen in alkaptonuria. So they will give you black urine on standing, but that's almost a giveaway. So they might not mention that, but that is what you will also find, homogentisic acid oxidase deficiency, right? So that is alkaptonuria. On the other hand, if they tell me an elderly patient is coming to me and look at the X-ray, X-ray is not showing complete homogenticid oxidase deficiency. What you are seeing here is a fusion, right? You are seeing that there is ossification along the anterior part of the vertebral bodies. So this is a defect. So this is an ossification along the ALL. So this disease is known as DISH. Here there is not complete fusion of the spine. There is just flowing ossification along the ALL. So these are 3 DDs of the spine that you need to know about: angspond, alkaptonuria, ALL. All right. Remember, the fourth option they will give you is rheumatoid arthritis. It does not affect the spine entirely. It causes atlantoaxial dislocation. It only affects the cervical spine. It does not affect rest of the spine. What tumor is this? The moment you see epiphyseal reaching up to joint space, especially distal end of radius, you see 30 to 40-year patient. This is a giant cell tumor or an osteoclastoma. Don't confuse it with ABC. ABC is going to be seen in the metaphysis. It will not reach the joint. If it has to be ABC, it will not reach the joint. It can have soap bubble appearance, but it will not reach the joint. That's how you distinguish. It is the closest variant of a GCT, but we can distinguish it. All right. So this is about ABC. Then when I show you these two in collection, in continuity, what is this? Where I can see the hand bones getting involved. These are multiple enchondromas. What do we remember? Hand is enchondroma. And when I combine it with these blue lesions, there are hemangiomas here. What is the diagnosis? You have to tell me the syndrome. It is Maffucci syndrome. If I was only seeing enchondroma, it was all yours. But when I see hemangiomas also, it becomes Maffucci syndrome. ठीक है, तो ये हो गया enchondroma. Don't get it wrong. Hand ka tumor matlab enchondroma. Then when I show you this, femur bent like a shepherd crook deformity. Repeat question. What is this? This is fibrous dysplasia. 2 syndromes of fibrous dysplasia. If I give you this person has precocious puberty, there are café macules. I know café macules in NF1, but one more cause of café macules. This is known as McCune Albright syndrome. But when I tell you that there are multiple myxomas, They can describe that in the heart there is a lesion which is giving me a mid-diastolic plop. Will you remember this? Atrial myxoma gives you a mid-diastolic sound, mid-diastolic plop. So that's a myxoma. What gives you a mid-systolic click? Two mid sounds you remember साथ में. Mid-diastolic plop is myxoma, mid-systolic click is MVP, mitral valve prolapse. Okay, वो याद रख लेना. Mitral valve prolapse, mid-systolic. Anyways, so what is the syndrome? The syndrome is Mersey-Maza-Broad syndrome. So now you know 3 syndromes from M. Maffucci with enchondroma, McCune-Albright, and Maza-Broad with fibrous dysplasia. All right, next what we have is a PET or a PET CT. So see, when you see bones are white and then you see something orange, this is a PET CT. It's a hybrid investigation. It has maximum radiation because you're combining 2 radiation wale modalities. The brain, the bladder is physiological uptake. The compound you use is 18-FDG. So any tumor is going to show you this red or this spot, this color, avidity. This is what we call as FDG avid, which shows you this hot spot, not the brain, not the bladder. Okay, so this is FDG avid lesion. Can you tell me a tumor which is false negative on PET? Even though it's a tumor, it will not show uptake. Repeat question. It is typical carcinoid. So typical carcinoid will show me a negative on PET CT. Next, what is this? Question, they give you fever, they give you productive cough. So this is a pneumonia presents as a consolidation. And what you are seeing is the bronchus is black coursing through the white alveolar opacification, consolidation with air bronchogram sign. Just to correlate respiratory physiology here, when we talk about the hypoxia that a consolidation or a pneumonia causes, there is complete alveolar opacification. So there is no air coming in. So this is what we call as a physiological shunt. Remember, this is what is known as shunting, where V is absolutely 0. All right. So remember, where V is 0, or other way of putting it is VQ equals 0. Ratio ही 0 hai. That is a shunt. That is a consolidation with air bronchogram sign. Right. Next, we have a person who is very tall with very long fingers, very long hands, and now comes to you with acute chest pain. Can you tell me the complete diagnosis? Air bronchogram is the presence of patent bronchi. Bronchi are patent, the alveoli are opacified. All right. Yeah. Coming back, so yes, this is indeed aortic dissection. What structure is this? What am I showing you? Which vessel is this? This is the arch of aorta, isn't it? So when you don't see the bifurcation, when you see this banana-shaped thing, this is the arch. It's the dissection of the arch of aorta. So the diagnosis, complete diagnosis in this tall male, one of the risk factors for dissection is Marfan syndrome, because there's a problem with the fibrillin gene, right? So fibrillin gene, the vessels are affected here. The other point that you want to remember, Stanford. What Stanford will this be? So anything which is proximal to the left subclavian artery, anything proximal to this, which includes the arch, is Stanford A. This is a surgical emergency. Anything distal to it, anything rest of the aorta is Stanford B, where you can do medical management with IV esmolol. Okay, so this is about the management of aortic dissection. Fine. Next, what do we have here? When I give you that there is history of in vitro fertilization, somebody comes to you with acute pain, abdomen, you see 2 ovaries with multiple large follicles. This is ovarian hyperstimulation syndrome. But if I tell you that there is history of molar pregnancy, I'm seeing these cluster of grapes in the uterus. What is it? It is known as theca lutein cyst. The same appearance is known as theca lutein cyst if this was history of molar pregnancy. Both of these, you have more follicles. You have these large follicles because of high beta HCG. But on the other hand, when I have 2 bulky ovaries which are showing me these tiny choto follicles arranged in the periphery like a pearl necklace, this is what we call as PCOD, right? So PCOD, small follicles. There is, there were lots of criteria on the size and the number. as radiologists, what we are trained is, do not look at number, do not look at size. If they are arranged in the periphery, there is no, the most important is there is no dominant big follicle है ही नहीं, कोई graphene follicle है ही नहीं. Because what is the problem in PCOD? It is anovulation. Lots of questions on PCOD from OBG. They ask you a lot of questions from treatment. So 3 main drugs you have to give. One is metformin to increase the insulin sensitivity. Second drug, if the person is having hirsutism, you're going to give some sort of anti-androgen here, which could be in the form of an OCP. Fourth generation OCP has anti-androgen ability. But if the person wants ovulation, wants fertility, drug of choice is letrozole more than clomiphene citrate. So either of them, letrozole more than clomiphene citrate. So this is how you manage a patient of PCOD. All right, अगर fertility नहीं चाहिए OCP, अगर fertility चाहिए letrozole. Diagnosis here, when you see that the inferior pole, the kidney is meeting in the midline, this is horseshoe kidney. This CT image has been asked in the exams. Horseshoe kidney, 2 questions for you. One, association with Turner syndrome. Second, what is the vessel which blocks the ascent? ऊपर आने से कौन सा vessel रोकता है? Yeah, no, not tamoxifen in the previous one. That's correct. Not tamoxifen. That was one of the options there. Okay. Anyways, क्योंकि मुझे कमेंट बाद में दिखते हैं तो वो थोड़ा इधर उधर होता है, बट दैट्स ओके. विच इज द वेसल बिकॉज ऑफ विच इट डजंट कम? इट इज inferior mesenteric artery. Inferior mesenteric artery stops the ascent of the horseshoe kidney. ठीक है. Then the next kidney pathology, where I see bilateral kidneys showing me these big large cysts. The liver has them. This is autosomal dominant polycystic kidney disease. If I ask you, can this be ARPCKD, what will your answer be? Let's say this is not an adult, this is an infant. Can this be an ARPCKD? Answer is no, it cannot be an ARPCKD, because ARPCKD will not show you these large cysts. We are gonna see these small micro cysts here. Micro cysts milenge. The outer contour is smooth. I'm not gonna see these large big cysts here. Okay, so this is how you distinguish. These will be seen in adult and this will have large cysts. All right, this was not sausage. The previous one is not pancreas. The pancreas, remember, will be very lobulated and it will not enhance so much. Can you see the cortex and the medulla? Can you see this under medulla hai, bahar cortex hai, white. Pancreas will not be so white, will not show you this corticomedullary differentiation at all. Right? That's how. Okay. So this is about this. 2 bladder ruptures, 2 patients with history of bladder trauma, 2 ruptures. Tell me what is this one, what is this one? The 2 options are, one is extraperitoneal bladder rupture, one is intraperitoneal bladder rupture. Correct. In the previous one, another difference is ARPCKD will show me liver fibrosis. It will not show me these liver cysts, isn't it? And just because we are on it now, ADPCKD, if this person comes to me with sudden history of headache, what will I have to rule out? History of sudden thunderclap headache. I need to rule out SH because this is associated with berry aneurysm. It is associated with MVP. We were discussing mid-systolic click. It's associated with mitral valve prolapse. It's associated with diverticulosis, right? So these are all the associations of ADPCKD. Right, coming back to this now. So when you see that the contrast is leaking in front, pre-vesical space of Retzius, this is extraperitoneal bladder rupture. It's not going anywhere, right? Here the trick is, क्या contrast इधर उधर जा रहा है? That is how you will distinguish. क्या contrast bladder के पास, bowel के पास जा रहा है? Is it going into peritoneum? So if it's spreading इधर उधर, here and there, everywhere it's going, this is intraperitoneal, because peritoneal cavity तो ऊपर तक है, right? So this is where it will go. But this is extraperitoneal bladder rupture. Okay, so this is how, and again, in the exam, if you don't know, you mark EPBR, because this is what is seen in 80% cases, whereas IPBR is seen in 20%. This is an indication of surgical management, whereas EPBR can be managed conservatively. All right, so this is about bladder rupture. The moment you see this and you read कि patient को sterile pyuria है, this is putty kidney, complete kidney है. Look at this. One thing you notice, this is unilateral. Second, it is complete kidney. It is not the collecting system. If just collecting system was white, this would have been staghorn calculus. If it was bilateral with the medullary pyramid or the cortex showing calcification, that would have been called as a nephrocalcinosis. But this is unilateral putty kidney. So nephrocalcinosis bilateral hoga, either cortex or medullary. Staghorn will be just this. And if they tell you delayed IVP hai, which is showing you that the contrast is accumulating in the kidney and not going into ureter with a cutoff here, that will be pelviureteric junction obstruction. That will be PUGO. All right, so got all the answers. These are the ones that you need to know. Then going on to GI radiology, when you see the smooth tapering distal end of esophagus, this is achalasia. Investigation of choice is manometry. Then when you see that there is this claw-shaped on a barium enema, this is investigation of choice for intersusception. Barium enema, investigation of choice for intersusception, that shows you this claw sign. Here they will give you history of rotavirus. The moment you see rotavirus vaccination, pain abdomen, it is intersusception. All right, so these are the important images here. आगे बढ़ते हुए, something you can't get wrong the moment you see sudden pain abdomen, chest guarding rigidity, and what you see is a chest x-ray. कहाँ देखोगे? सीधा सीधा हम देखेंगे मैम अंडर राइट डायफ्राम. Will I see left diaphragm? No, because there is fundus there. So when you see black right air under the diaphragm, this is perforation. Peritonitis, this is pneumoperitoneum. All right, so pneumoperitoneum. Next step, IV fluids. Next step, exploratory laparotomy. Should I do a barium meal to look for the stomach ulcer which may have perforated? Never give barium in a patient who has perforation. Can I do a CCT? You can do a CCT, but it is not done. If the X-ray shows you perforation, it's a surgical emergency. Take patient to OT. CCT is technically investigation of choice, but not done if X-ray is positive. Remember this, it is technically the most sensitive one. But if X-ray, which in the exam they will give you, if the X-ray shows you that there is pneumo, no need to do a CCT. I hope this is clear, because this is how these questions will come, asking you next step. Please identify whether this is small bowel obstruction or large bowel obstruction. When you see that there are these complete lines, you will not get to zoom in the exam, so I was not zooming, but still, if you zoom, you will see that there are these complete lines, valvulae conniventus. This is what describes jejunum dilatation, small bowel obstruction. Remember, this is most commonly because of adhesions, and that's why we don't operate. This is conservatively managed, whereas a large bowel obstruction is something where you have to operate. In the liver, if you see this white calcified lesion, CT है, bone white है, bone जैसा ही white calcified lesion है. This is a calcified hydatid cyst. It's a calcified hydatid cyst. It is the inactive stage. No need to do anything. No indication of pear or albendazole here. Nothing needs to be done. And finally, when you see this MRCP image, you can see there are black signal voids. These are CBD stones. So remember, for CBD stones, investigation of choice is MRCP. But for gallstones, where you see the shadowing, investigation of choice is ultrasound. For any other stone, answer is going to be NCCT. So for salivary, renal, ureteric, everywhere else, NCCT. For gallstone, ultrasound. For CBD stone, MRCP, because you will not see the entire CBD on ultrasound. Okay. But if they ask you next step after MRCP, what do you do? Next, we will do ERCP. Next step will be ERCP, because this is therapeutic also. I can remove these stones as well. And lastly, what do you see? You see multiple ring enhancing lesions in the brain. When you see these round ring enhancing lesion, this can be TB, this can be NCC, this can be toxoplasmosis as well if patient is HIV positive. So remember, TB, NCC, toxoplasma, all are DDs. If they mention that the patient shows you lipid lactate peak, repeat AIMS question, लिपिड लैक्टेट पीक मिल रहा है, एमआर स्पेक्ट्रोस्कोपी, ऐसा कुछ कुछ हाईफाई वर्ड्स दिख रहे हैं, मार्क टीबी. If they mention HIV, mark toxo. If they mention seizures, no other buzzword, mark NCC. Okay, this is how we have to approach these ring enhancing lesions, these multiple round white lesions. All right, can I go ahead? 5 hemorrhages for you, then this. All right, so 5 hemorrhages for you. In any acute hemorrhage of the brain, remember, investigation of choice is NCCT, particularly head trauma. So any acute hemorrhage I want to see, it is going to appear white on a CT scan. So now you will tell me diagnosis based on the history. Alcoholic, bathroom may fall, boxer means any trivial trauma, and I see this crescent shaped hematoma, this is SDH. If I see that there is this biconvex bleed, which is a lens shaped bleed, there is severe trauma which is happening, it is extradural hematoma. All right, so this is EDH. Here they will give you more G trauma, and it's an arterial bleed, which is the artery which is injured most commonly. It is middle meningeal artery. Which division? Anterior division, middle meningeal artery. Whereas SDH is a venous, bridging venous injury, right? When they give you RTA or they give you berry aneurysm, spontaneous sudden headache, and you see this star of death appearance, this is what is seen in acute subarachnoid hemorrhage. We have to rule out aneurysm here. For an aneurysm, gold standard is going to be a DSA, digital subtraction angiography, where you can do coiling as well. You can do coiling with the same modality. All right. Then not trauma, but a hypertensive with sudden hemiplegia. You see this bleeding here now in the basal ganglia. What is this? Most common site of hypertensive bleed. This is the putamen. So this is putaminal basal ganglia bleed happening in a hypertensive patient. Again, road traffic accident, very low GCS, but they'll give you NCCT either is normal or showing me small particle hemorrhages. This is the only place where investigation of choice is MRI, susceptibility weighted imaging, diagnosis is diffuse axonal injury. So remember, DAI is the only place where answer will be MRI. This will be the history. They'll tell you severe injury, but CT to normal tha. So this is when axons are breaking, leading to these chota micro bleeds on MRI. We can see that. All right. Now history of trauma and difficulty breathing. So trauma hai and 4 X-rays I'm showing you. Please tell me diagnosis in each and tell me the side. I hope sides are clear. Always on all imaging. This is right. This is left. Imagine it's somebody sitting opposite to you. First one. I see a meniscus. I see white opacity, blunting of CP angle. This is right pleural effusion, but because we're dealing with trauma, I'm going to call it right hemothorax. What do you do next? Whether patient is stable or unstable, I have to put an ICD. The biggest mistake you will do is if patient is unstable, you will put needle here. No role of needle thoracostomy in blood. Blood will not come out of your needle that you put. You have to put ICD. But if I show you this, where on the right side, now there is black, no bronchovascular markings, hyperlucency. This is right pneumothorax, right pneumothorax. Now, if the patient is stable, I will put ICD, but if the patient is unstable, we call it tension pneumothorax. We have to first put a needle thoracostomy, then put ICD, needle followed by ICD. When you see a horizontal level with pneumo and hemo both, this is what we call as hydropneumothorax, now on the left side in this case. And what is this? So this is how they confuse you. This is what AIMS does. They know air fluid level is hydropneumothorax. When you see this, you mark hydropneumo. No. Look at this. Here, the diaphragm is only raised. There is a diaphragm injury in a patient with trauma. This is a diaphragm tear, a diaphragm injury, where the stomach, this is the air fluid level of stomach, which has been pulled up. All right. So this is a diaphragm tear with the stomach in the thorax. They have asked you what is contraindicated in this. So you don't put an ICD. Here you will put an ICD. Here ICD is not put. So the only thing they have tested you is this hydropneumo? You will say no, it is below diaphragm. This is diaphragm injury. Investigation of choice for a diaphragm injury, remember, is a diagnostic laparoscopy. It's basically surgery, which is the investigation of choice. All right. So this is what is very, very important. A few theoretical one-liners from radio. बाकी इन images से हमारे सारे questions hopefully solve हो जाएंगे. Let's look at the questions which are from theory. Whole body CT in a trauma patient includes all except, remember, limbs are not included. Head, C-spine, torso. Torso means thorax and abdomen included. Eggshell is typical in silicosis sarcoidosis. It may also be seen post-RT, but never in metastatic. All right, so metastasis is very unlikely. Then patient with prostate CA had a super scan. Super scan is what you see on a bone scan. Bone scan पे से एक सवाल याद रख, दो सवाल याद रख लो. It shows you a cold spot in multiple myeloma. बाकी हर जगह पे hot spot मिलेंगे. Any pathology like bone tumor, metastasis, you'll see hot spot. And the other thing, osteoporosis. Is there a role of bone scan? No, no role in osteoporosis. There is just bone mineral density loss. There is no focal lesion. All right. So now when you see a super scan means all the bones are taking up uptake without the kidney and soft tissue. And this is because of metastasis. Itne metastasis ho gaye that all of the bones are taking up uptake. So either it is because of diffuse mets or it's because of metabolic bone disease. Okay, so these are the two cases of super scan. Fine. It's not uptake by carcinoma or the bone or the adrenal. It's diffuse metastasis or metabolic bone disease, which can lead to a super scan. Fine. Then what do we have here? This was a very tricky question where a lot of you felt trapped too. अगर मैंने ऐसे ही पूछा होता ये क्या है तो everybody would have told me CT scan, है ना? But then they gave you contrast study in the option and everybody got confused कि क्या ये है या ये CT scan है. So this is a contrast enhanced CT, but it's still a CT scan. A contrast study is a term that I use for an X-ray study. All right. I can't increase my speed beyond this. Okay, Anonymous, I request you to see this lecture later on 2x if you want to increase the speed. But my talking speed and my teaching speed, I can't increase beyond it. All right. So this is a contrast study where it's an X-ray study in which we are giving contrast. So something like an HSG, something like an ERCP. This is what is known as a contrast study. But this is a CT scan. Fine. Then we have a 40-year-old patient with confusion, constipation, low mood, ALP elevated, primary hyperthyroidism. This is what we see in PTH adenoma. PTH adenoma, investigation of choice is SESTA-MIBI. This question has come in a lot of exams. SESTA-MIBI scan, investigation of choice for PTH adenoma. What is the Miami criteria? This is when a surgeon will remove PTH adenoma. It's to know अगर 50% से कम हो गया PTH का level in 10 minutes, the surgeon can be assured that they have removed the culprit adenoma. All right. So this is about that. Most radio resistant is the S phase. So S is radio resistant. Most radio sensitive is G2M. Remember, S is not sensitive. So G2M is most sensitive. S is most resistant. ठीक है. Empty thecal, ये बस ऐसे one liner question they have asked. It is seen in arachnoiditis, where all the nerves are gonna stick to the thecal sac and you don't see any nerves floating. That's seen in arachnoiditis. को RAD score पता होना चाहिए. So remember, just like BI-RADS only, 0 score कभी भी देते हैं means it is an incomplete study. Okay, complete ही नहीं हुआ, technically adequate नहीं था. CORADS 1 is what is a normal lung. 5 is typical. This is correct. What is typical finding of COVID-19? It is GGO, right? So you will see bilateral, multifocal, ground glass opacity. When they describe this, it is CORADS 5. Pleural thickening, consolidation, cavitation, anything that you see in tuberculosis, these are not typical. These are atypical. COVID में typical मतलब, remember, GGO, ground glass opacity. All right, is this clear to all of you? So now going on to the next one. Going on to FMT. All right. Radiation syndrome. Yeah, that's important. So radiation syndrome, the order, the most sensitive is the hematopoietic syndrome, then GI, and lastly, we have CVS, CNS. The last is the brain and the heart, which are affected. All right. So this is somewhere close to 2 to 8 grays. This is around 20 grays. This is around 100 grays. All right. So this is increasing order, but death happens fastest here. Okay, so this is about this. Chalo, now going on to forensic. 3 down, 5 to go. No break. We can't take a break. We have no time to take a break. But you can take a break. You can join back after 5 minutes. That's okay. Video will not stay on YouTube. Rib counting pen, I don't want to waste time because we'll continue doing this, and in the end, you will not understand only. So that's what I have been there, done that. So what I want to tell you, one suggestion is that जो भी curved ribs होती है ना, whatever are the curved ribs that you are seeing, they are anterior. The horizontal ones are posterior. Okay, so at least 50% options you will be able to rule out. The second thing is you always start from the top. So this is the first one. This is the second one. If you can just mark 1 and 2, then you will not go wrong. 1 and 2 mark कर लो उसके नीचे. This is third. This is fourth. And if all fails, what I did right now, you don't understand. What you will mark is fourth posterior rib. That will be your answer. Okay. So this is about the rib counting. Fine. Chalo. Ab जाते हैं into forensic. So forensic, we have from some theory, we have some images, we have some antidotes, and then some theory. Forensic is very scoring for AIMS, all right? For INICT, you get lots of forensic questions. It's one of the subjects which is very high yield. Okay? Chalo, shuru kare. All right. What is the use of Glester-Keene rods? What are Glester-Keene rods? So try to accumulate like every question which I thought could be asked or has been asked. Okay, so please इसको revise करके जाना. I put in too much effort. उसको use करना अच्छे से. So this is what is used for hymenal assessment. Okay. For assessment of hymen in any penetrative sexual assault, we will use these rods. If you find that there's a posterolateral 4 to 7 hymenal tear, that is what is usually associated with sexual penetration, right? On the other hand, if it is a digital penetration or penetration with a foreign body, it's usually an anterior hymenal tear. And the second point you want to remember, where can a hymen remain intact despite having sexual assault? That's a child. So a child will have a deep-seated hymen, right? So it can remain intact despite having assault. All right. So this is what you have to remember. Okay. Thank you so much, guys. Chalo, आगे बढ़े. Medical legal, or what is common to all these three conditions? Medical legal autopsy, accused ka examination, and emergency. These are three conditions where consent not needed, right? We don't have to take consent from family, not patient, है ना. Don't think patient consent नहीं दे रहा autopsy में. कैसे? Patient नहीं, family. Other types of autopsy, we need consent from family. Here we don't need consent of family. Accused examination, emergency. Consent is not needed. Res ipsa loquitur. Res ipsa loquitur is when the facts speak from themselves. So facts speak from themselves can be asked to you in two conditions. One is wrong side operated. Criminal negligence, wrong side operated. Fact will speak. आपको दिख रहा है कि वहां पे scar है. Second is foreign body left inside. आपको दिख रहा है कि foreign body है. You can't claim. नहीं नहीं मैंने नहीं छोड़ा. You can't claim. You are negligent. So this is facts speak for themselves. Doctrine of common knowledge means कि तो सबको पता है ना. नाम में ही नाम में जो है, that is what is it. So if you have not given tetanus toxoid in a wound, right? I don't need any medical expert to come and tell me that there is negligence or not. this is common knowledge. So this is also been tested. Doctrine of common knowledge means facts तो सबको ही पता है ना, नहीं चलता फिरता आदमी ले लिया, अरे तुमने टेटनस में टॉक्साइड नहीं दिया, oh you are so negligent. That is doctrine of common knowledge. Then what is medical maloccurrence? Here the exam question will be that there is a person, or let's say there is an OBG surgeon who injured the ureter during surgery. Is this a criminal negligence? No, this is not criminal negligence. This is what comes under medical maloccurrence. It's a known complication. Criminal negligence means a person who is drunk on duty, injures a vessel, injures the aorta, and that leads to death of the patient. So everything is fulfilled. Person was on duty, there is dereliction of duty, and there is damages. All these are fulfilled. That is criminal negligence. Can you tell me IPC of criminal negligence? Okay, I'll give you options. 304A, B, C, or D. 304A. What is 304B? B for BV. This is for dowry death. Okay, abhi aayega dowry death ka question. I will tell you then. All right, so this is what you need to know. फिर रेस जुडिकाटा क्या है? रेस जुडिकाटा मीन्स दैट यू कांट अप्लाई फॉर द सेम केस. एक केस ने बोल दिया डॉक्टर इज नॉट नेग्लिजेंट, सेम केस नाउ यू कांट फाइल अगेन. ओके, कि भाई ये डॉक्टर ने मेरे से नेग्लिजेंस की. सो सेम केस कांट बी फाइल्ड अगेन once a decision has been made. Okay, what is the criteria for heat stroke? The criteria for heat stroke, you want to remember: one, the core temperature is more than 40.5 degrees Celsius. Second, there is CNS dysfunction, there is confusion, there are neurological symptoms, there may or may not be sweating. It's a common misconception that there is no sweating in heat stroke. So there is classical heat stroke where there is no sweating, but in an atypical heat stroke, sweating may be present. So don't rely on that. Rely on these two features in heat stroke. All right, that is what is very important. Then this triad is what is known as what triad? This is what is known as Marshall's triad. किसमें मिलता है? ACL, abrasion, contusion, laceration. This is seen in primary, secondary, tertiary or quaternary impact of a blast injury. प्राइमरी मतलब ब्लास्ट के कारण ही, दैट इज वेयर यू हैव टिम्पैनिक मेम्ब्रेन, लंग्स एंड कोलन, TLC गोइंग. दिस इज सेकेंडरी वेयर द फ्लाइंग मिसाइल्स, जो ब्लास्ट से निकली है, फ्लाइंग मिसाइल्स आर गोना कम एंड हिट यू. सो दिस इज सेकेंडरी. दैट वाज द क्वेश्चन हियर. Tertiary is when from the blast you fall and then you have head injury. That is tertiary. And quaternary is because of burn or something you have injury. So this is about blast injury in 2 minutes, entire chapter. Then we have few rules that you need to know. Hasse and Morrison are for gestational age, है ना? तो हास्य ने क्या बोला है that if it is less than 5 months, what you do is square root of the length of the baby. Morrison ने बोला if it is more than 5 months, you do length upon 5. So this is more than 5 months, length upon 5. So they give you 30 centimeter का fetus मिला है. What is age? So what you will do, 30 divided by 5 is 6 months, right? So this is what is gestational age. Ashley rule क्या है? Ashley rule कुछ पता नहीं होना चाहिए, just it is for sternum. Guessing to know the sternum, basically looking at the sternum, that is identification from sternum is Ashley rule. Durhan, Curran, Bronner. This is what they have asked, ki Durhan and Curran both are for insanity. These are rules of insanity, that a person who is insane cannot be punished. And what is the IPC for that? What is the IPC for insanity? You all know our McNaughton Dadaji story. Yes. So IPC 84, McNaughton's rule. Leading questions are permitted in. This question has come so many times. It's such a cliched question. In cross-examination, we ask leading question. What is leading question? Leading question means, are you guys sleeping? Are you guys awake? जिसका आंसर yes or no है, that is cross examination में leading question. Can I ask leading question to hostile witness? Yes, hostile witness को you don't have to wait for cross examination, you can ask anytime. Superfetation versus fecundation, focus on the C. Same cycle. If you have 2 acts of coitus with 2 different sperms, 2 different eggs got released somehow in the same cycle, I can technically, this is where a person can have twins from two biologically different fathers? That is what they ask you. Can I have twins with biologically different fathers? It is possible. How? By superfecundation. So I think details you will have figured it out. Okay, so that is superfecundation. Superfetation is when in the different cycle. This does not happen in humans. क्योंकि एक बार fertilization हो गया, we don't have ovulation in the next, but horse में हो जाता है ovulation. So they can have two different babies of different ages. All right, so that is fetation, fecundation. Barbario, remember BSP. Barbario is seen with spermine and picric acid. So this tests the picric acid, spermine. Then what I want you to tell me is, where do we check choline? Choline is Florence test. Okay, there is no space only to write anything new. So Florence is choline. Okay, but BSP, if you remember, everything else you will figure it out. And where do you see paradoxical undressing? नाम ही है paradoxical. Hypothermia is paradoxical undressing. Okay, ma'am, हाथ से CRL or CHL? CRL. Not even CRL, we take the complete length. So crown rump length plus length of the legs we have to take. Okay, so they'll give you both. You have to do some addition. Complete length of baby we need. Crown rump is only from crown to the buttocks of the baby. I need length of buttock to leg also. Total add करके we have to do square root 5 or divide by 5. ठीक है, चलो अब बताओ ये तीन. नहीं, यहाँ जगह नहीं है, यहाँ कुछ लिखना था इसीलिए. So distinguish the type of blister. Is it dry heat, is it moist heat, or is it chemical? So three types of burns. इस बार का सवाल. The moment I see burning of the hair, charring, blackening, this is what is known as dry heat. Dry heat मतलब burn, हमारा typical burn, आग में जल जाना. On the other hand, if you have blister, splashing, line of redness, this is what is known as moist heat. Moist heat माने scalding. What temperature beyond which we can have scald? We can have a scald beyond 60 degree Celsius. And ulcer, if you are seeing, you don't have any of these, you don't have blackening, you don't have blisters, but there are ulcers and there are coloration which is distinct. This is what is known as a chemical burn. So I've told you the buzzwords. This is what has been asked to distinguish the different types of burns. Now talking about police inquest, magistrate inquest. पहले तो मुझे इनके CRPC बता दो. पुलिस इंक्वेस्ट का CRPC क्या है? CRPC 174. Here the minimum rank of police inspector is head constable, but if it is a sexual offense, then we need a sub inspector for police inquest. But for 3, I need a magistrate inquest. कौन से 3 इतने खराब क्राइम है कि हमें magistrate inquest चाहिए? The IPC is 176. So magistrate inquest, custodial death, rape या disappearance. Now if it's in custody, it's the most severe crime. I can't rely on police only to do inquest, right? So now which magistrate I need? I need topmost magistrate, which is judicial magistrate. But for dowry, death and exhumation, I need magistrate, but I can have executive or जुडिशियल मैजिस्ट्रेट, दोनों मैजिस्ट्रेट चल जाएंगे. ठीक है. Then what do you do in sexual assault? Very important question has been asked. First is to inform the police. You have to take consent for examination. The consent here becomes 18 years, not 12 years. Otherwise, consent for physical exam, general physical exam is 12 years. But for sexual examination and in rape cases, it is 18 years. अगर patient बोलेगा नहीं मुझे नहीं consent देना, you will counsel and you will document it. Will you provide diagnosis and treatment? Yes. Here students ask me कि मैम अगर consent ही नहीं दे रहे एग्जाम का तो हम कैसे treat करेंगे, कैसे diagnose करेंगे? So this is about the first aid that you are giving them, right? It is about the overall injury management. And by first aid I mean management, not don't give them book first aid लो पढ़नी होती है. So this is for overall management of the patient. Okay, then what is the time limit for examination? For vaginal swab, you can take it up to 96 hours, and for semen sample you have to take it in 72 hours. Okay, fine. So this is about this. All right, I'm not even getting any laughs or anything. I'm getting it after 1 minute. I don't even get if my joke was funny or not here. I realized after 1 minute that हाँ शायद funny था. 96 hours, 72 hours. All right. Okay. So now going on to the next set of 8 images. So 8 images, then few plants, then few tables, then few snakes, then few antidotes, and then few questions. All right. चलो फटाफट image बताओ. सही लिखा ना मैंने. हाँ, why 72 hours for semen sample? Because sperms are motile for 72 hours. चलो ये क्या है? Is it incised looking laceration or is it laceration looking incised wound? So this is incised. Just remember one, otherwise you will get confused. So this is incised looking laceration. Anytime you have a laceration which is meaning a blunt force, किसी के माथे पे हथौड़ा मार दिया. हथौड़ा means hammer. Hammer, if you hit on forehead, which is matha, which is a blunt surface on a bony projection. So any bony projection, if you hit with a blunt trauma, it will produce a laceration which looks kind of incised. But the trick is you will see that the margins are irregular. Okay, what is this? This is filigree burn, arborization burn. This is seen in lightning or electrical burn. बस इतना ही पता होना चाहिए. This is seen in lightning and it's shaped like lightning only has come to your skin and it has spread. Fine. Then when you see electrical, high voltage electrical injury like this, what is this known as? This is known as a crocodile burn, right? So this is what we call as crocodile burn. Oh, one person has answered all questions so quickly. Very good. So crocodile burn. Maybe next class you can only take for me. I can get a break and maybe you can come and just take 1 or 2 slides. So this is crocodile burn. What is this? Where one person is holding mouth and one person is doing traumatic asphyxia. So 2 mechanisms in one, smothering also and traumatic asphyxia also. Why do 2 when you can do 1? Why do 1 when you can do 2? This is what is known as Burking. Okay, so this is Burking, two methods of asphyxia. Then when you can put person in a chair and then do this, this is known as Spanish windlass, also known as garroting. Okay, so this has been asked like way too many times. I don't know why. Spanish windlass or garroting. Then postmortem change. What is it? Why is it? And when is it? All questions have come. Marbling is what it is. When is it? It's beyond 48 hours. So 48 to 36 hours. And why is it? Is because of sulf-meth hemoglobin. ठीक है? What are these lines? These are Mees lines that you see in arsenic. What is this jaw? This is phossy jaw that you see in inhalation of phosphorus fumes. 2 questions for you. Can you tell me a drug which causes chronic osteomyelitis of the mandible? Yes, ma'am. We can tell it is bisphosphonates. Can you tell me infection which causes chronic osteomyelitis of mandible? It is actinomyces. Actinomyces will have yellow granules. Okay, so yellow granules, actinomyces, bisphosphonates, and phossy jaw. Okay, so actinomyces, is it aerobic or anaerobic? You will remember A, no, it is not aerobic. Is it acid fast or non-acid fast? A, no, it is not acid fast. खुद actinomyces आपको बताएगा दोनों चीजें. All right, now let's identify a few poisonous plants. What is this? Purple है purpura, digitalis purpura. Then what is this? One more purple plant. Very important. This is aconite. Okay, don't ask me how to distinguish. Just see plant and distinguish. Okay, so aconite is something. Both of these are. All of these are cardiac poisons here that I have put for you. Aconite is ideal homicidal because it is meetha zehar. Person will not know, and there will be hypotension and there will be hippus. All right, hippus and low BP. Then 2 oleanders for you. Here, thankfully, there are no controversies that this is indeed yellow oleander and this is pink oleander. So don't be Sherlock in the exam that, oh, if it is pink in color, it must be yellow oleander. Itna nahi sochta. How have they given me pink flower and they have asked me, is it pink oleander or yellow oleander? It is what it is only. Okay, so isme zyada hero aise question mein don't be hero and think that इतना easy question for me, such an easy question. No, I will overthink and screw it up. Don't be that person. Okay, some questions will be like that where it will feel ये ऐसा मेरे लिए, and you just mark answer and move on. Don't overthink in such questions. 5 to 10 questions will be like that. Okay, so this is pink oleander and yellow oleander. Pink oleander में क्या होता है? There is nerium. उसका दूसरा नाम है नीरियम ओडोरम. So nerium is the active compound, whereas yellow oleander is cerebra thevesia. That is the technical name. So cerebra and nerium, if you remember, you will be sorted. Okay, and finally ये plant तो सबको आता ही है ना? So this is cannabis. So this is cannabis plant, and ये plant भी सबको आता है. They will tell you child playing alone ate one fruit, and this was thorn apple. What is thorn apple? This is datura. So what will child have? Cholinergic or anticholinergic? Datura has active component which is hyoscine or atropine, right? So hyoscine or atropine, so anticholinergic. So remember, this is mydriasis with dry, high temperature, no sweating, no lacrimation. So all anticholinergic symptoms. All right. For hanging versus strangulation, you all know for strangulation, it will be a complete continuous transverse, whereas it will be non-continuous in hanging. This will be above thyroid, it will be pale, and abduction fracture. All right, so abduction, remember, if somebody is doing hanging, they want to go away from the world, so you remember it like that. Hanging is AB, abduction fracture. Fine. Another irritating table about fingerprints. Complete loss of fingerprint happens in burns and celiac disease. Permanent impairment happens in any radiation or electricity or leprosy. ये एक याद रख लो, ये एक याद रखने से क्वेश्चन आंसर हो जाएगा if it is a direct repeat. Change in distance happens in acromegaly and rickets, whereas alteration happens in these derma. So derma है मतलब ridge alteration. ठीक है, तो ऐसे करके थोड़ा थोड़ा याद रख लो. Fine. Oh, I can still reduce my voice. Oh, thank you very much for that. Then we have pelvis and skull. If I have to ask you, what is the personality disorder counterpart of this message that X has posted, where even if there are too many comments, still your attention will go to them. You know, it's a comment which tells you that, look at me, I have so many emoticons, I am in all caps. So ऐसा अगर कोई personality disorder है where you want to be center of attention, what is that called as? Just to correlate, that is known as histrionic PD, right? That's known as histrionic personality disorder. Okay, just like comparing for academic purpose. Okay, chalo, next. Then we have pelvis. We have pelvis and we have skull. So just those two tables, you know what I'm talking about, right? Just those two tables between male and female. If we have to distinguish, so pelvis may, what you have to remember is not narcissistic, histrionic. Chalo, वापिस आ जाओ. All are large and wide in females, because females have to deliver baby, they need larger pelvis, except 3 things which are larger in male. बताओ क्या है? अभी खत्म तो होने दो, फिर ही तो अपलोड करेंगे. Obturator foramen, then we have sacroiliac joint surface, and then we have acetabular notch. Okay, so these are the 3 things which are larger in males. If you just remember OSA, it will be sorted. Then skull, everything is large in males except frontoparietal eminence is larger in females, nasal aperture, and do this forehead, orbit, chin, these are larger in females. Okay, तो इतना हम याद रखेंगे तो everything will be sorted. All right, next, putrefaction is delayed by 3 things. So anything which is 3 is an all except question. So strychnine, metallic poisons, carbolic acid will delay putrefaction. Caloricity means the cooling does not happen after dying. It is not in burns. Remember, the body remains heated in a heat stroke, pontine hemorrhage or sepsis. External heat will not lead to a loss of postmortem cooling. All right, tell me, which toxin am I talking about when I say that there is priapism because of this toxin? I'm talking about Spanish fly. Okay, so Spanish fly will cause priapism because of this cantharidin. Indian red scorpion causes an autonomic storm. The drug of choice is prazosin. Both of these are repeat questions. Then what you have to remember, tactile hallucination किससे होता है? 3 things. CEA, cocaine causes magnum bugs. E for ergot, and A for arsenic. Interestingly, all three of these are gonna have black conditions. Ergot, arsenic both cause black foot disease. Ergot because it causes gangrene, arsenic का नाम ही है black foot disease. Cocaine causes black discoloration of the septum, right? When we snort the cocaine, it's gonna have blackish discoloration. Fine. So two things that you can relate from this table. Garlic odor, remember ALP. So again, arsenic. P say phosphorus. Remember, except for red, every other phosphorus is toxic. So red is non-toxic. Remember, matches, matchbox side में जो red होता है, when you do this, that is what is made up of red phosphorus, and one is ALP only. So aluminium phosphide. So all three of them are your garlic odors. Fine. Let's recognize our snakes. So the first one, anytime you see this hood that you all know very well from uncles dancing in shadis, is your Nagin dance. Nagin means cobra. So when you see hood, it is cobra. When you see spectacles with cobra, it is common cobra. Because have you ever seen a king wearing specs? No, they don't wear. Common people wear. So if you see just Nagin dance without spectacles, it is king cobra. ठीक है. Then when you see band, it is a crate. Normal black and white color, इतना common color, we called it तुम common crate. Black and white पहना है, common. But if it is yellow, you special banded crate. Together, king cobra and all crates, so cobra and crate are all neurotoxic snakes. They belong to the family Elapidae. ऑन दी अदर हैंड, सांप जो अपने बॉडी पे ही न्यूमोनिक लेके घूमता है, यू सी वी on the body itself. So this is viper. V for vasculotoxic. This is a vasculotoxic snake, and this one is lying on beach only. So this is a sea snake. Sea snakes are gonna have myotoxins. All right. So this is a myotoxic snake. What you have to remember: the first aid, carry no right was asked. Very very stupid. Very very easy. Carry means carry the patient. Don't put tourniquet. You can put tourniquet, but don't put very tight tourniquet that artery ही block कर दी. You should not incise. Don't do cautery. Girlfriend should not save boyfriend by sucking the snake poison. No coffee, alcohol. Okay, you have had a snake bite. Don't ask for beverages right now. And right, what is right? Reassure patient. कुछ नहीं हुआ, snake bite ही तो है, कोई बात नहीं. Immobilize patient, and best go to hospital. Tell symptom. This is Government of India mnemonic repeat question. What is carry no right? Wow. So this is what you have to remember. And then, so you went to hospital, you told a symptom. What will hospital do? Should I give anti-snake venom in all cases? No. Most of the snake bites in our country will be non-venomous. This is what we have to only give if it's a venomous snake bite. Means if the person has symptoms, only then I'm going to give anti-snake venom. All right. Ye surgery nahi hai, symptoms. All right. So only if patient has clinical feature, then we are going to give. Fine. Then yeah, most common cause of death is fear, so that's why you will reassure. So that's actually true. Okay, so polyvalent anti-snake venom, they have asked you हमारे देश में किसके against effective है? So cobra, crate, Russell viper and saw-scaled viper. This is what is effective, and we give it within 4 hours. We give 10 vials of this anti-snake venom. Neostigmine, atropine, remember I only give for cobra. Okay, only for cobra, not in crate. It's not useful in crate, even though that's also neurotoxic. So this is a repeat question. Neostigmine and atropine is in cobra. All right. Okay. Next, all antidotes in one place. Very, very high and important slide. And then we have this. Okay, let's continue. PCM, बताओ फटाफट चलो. ये एकदम high slide. You should not get any question wrong, and you will get 100% question from this. PCM is an acetylcysteine. What N-acetylcysteine is going to do is it's going to increase the glutathione reserves in the liver. Okay, antioxidant glutathione reserves is going to increase. Two very important points that you want to remember: methanol and ethylene glycol, both of them have the same antidote. Both of them have something common, where both are high anion gap metabolic acidosis and both have a high osmolar gap. तो ये common बात हो गई. How do I distinguish? Methanol, they will describe blindness. You know one tragedy here? Huge tragedy. So huge tragedy, methanol in desi daru, if person will drink, this entire village got blind. So that is methanol. The important specific feature of ethylene glycol is when they give you that there are calcium oxalate crystals in the urine. So now what is the common antidote? It is fomepizole, right? So very, very important 2 points that we have covered here. Benzodiazepine, the drug of choice is flumazenil. TCA, I already know, sodium bicarb. Beta blocker is glucagon. Cyanide, we give a Lilly's kit. What does a Lilly's kit have? It has sodium nitrite and thiosulfate. Okay, so nitrite and thiosulfate, and I can also give B12 hydroxycobalamin against cyanide as well. All right. देन मिथ हीमोग्लोबिन, मिथ से ही याद रख लो, मिथिलीन ब्लू अगेंस्ट मिथ हीमोग्लोबिन. Opioid, naloxone, we already know. Then let's do pharma also. Heparin, we have to give protamine sulfate. Dabigatran, DA, नाम में ही है. Ru, C, Zumab. So I, inhibitor of DABI. That's how you'll remember. XA inhibitor, sodium or amyl nitrate, both can be given, okay, for Lilly's kit. Yeah, coming back, XA inhibitor, remember, Andaxanet alpha. Again, the name itself tells you everything that you need to know. So option में दिख जाएगा, बिल्कुल रटना नहीं इसको. XA का antagonist, okay, XA का antagonist, Andaxanet alpha. Organophosphate carbamate, both are going to cause increased cholinergic activity. So I have to give atropine. The difference is organophosphate is going to be irreversible. So I can also give oximes, whereas I cannot give oximes in carbamate. Datura, because it is anticholinergic, I have to give cholinergic. I give physostigmine because it can cross the blood-brain barrier. All right, so these are all antidotes compiled for you. Few chelators also very important. So BAL, remember, is HAL. BAL is HAL, mane mercury, arsenic, lead. Same HAL is also for DMSA succimer. So mercury, arsenic, lead. So remember, HAL is for BAL and DMSA. D-penicillin just replace the mercury with copper. So copper, arsenic, lead. Cal is D-penicillamine, because we use this in Wilson's also, right? So not very difficult to remember that this is copper. EDTA is just lead. Desferrioxamine is just iron. Prussian blue is thallium. Okay, this is new. ये मुझे भी recently पता चला है. So not in any previous BTR. So Prussian blue is thallium. Then forced alkaline diuresis, forced acidic diuresis. Very, very important table. Forced alkaline diuresis I will do with sodium bicarb. This is for weakly acidic drugs. Okay. Muscle relaxant का अभी बताऊंगी ना anesthesia में. Weakly acidic drugs, like anything which ends with 8. So salicylate, TCA, all right, methotrexate, we will use this. Forced acidic is with NH4Cl, and this is for weakly basic drugs which end with enes. So your morphine, atropine, I will use this. So this is very, very important table. Just understand the concept. All right. Hemodialysis is indicated in all of these. Lithium, I already know. Salicylate, theophylline, you have to know. Baki barbiturate, alcohol, you can just see. All right. So this can be asked as an all except question. Fine. So ये हो गया हमारा ये. Now, let's do the one-liner questions from forensic. So identify the true statement regarding corpobasal index of sacrum. So आधा तो नाम से ही पता लग रहा है ना, basal. One denominator must be base. So answer is the. So what is the answer here? It is the S1 vertebra ka breadth upon the base of the sacrum ka base. All right. So this is what we use to distinguish between male versus female identification. And if you just want to know, male is 57, female is 52. Just numbers for you. So this is about coprobasal. Patient alleges negligence and sues him. So for misconduct, records कब तक देने चाहिए? We have to give within 3 days. So here remember 3 numbers. 3 numbers. 3 years तक we have to store the records. 3 years तक records need to be maintained for a patient and you have to give them within 3 days. All right. Penicillamine not for arsenic. Is it? Is it not copper, arsenic, and lead? I think it is this only. All right, but anyways, it's the best for copper. Okay, it's the best for copper. Identify the false statement. This is like the worst question that they can ask you ever. But just remember this direct answer that A is wrong in mongoloids. The cusp of molars are wide and deep with shovel-shaped cups. Caucasians have Carabali, CC. Upper third is absent in Mongolians and this is what it is. तो इसके बाद don't go into research of teeth of all races and how it has progressed कि मैं monkey में ऐसा था उसके बाद homo sapiens में ऐसा आया था बीच में homo erectus है this don't go into that okay just remember कि भाई पहला statement wrong है fine ऐसे question में बहुत सेंटी होके topic पढ़ने नहीं बैठना this is not what is previous year topic fine bullet fingerprinting involves both if they give you both in the option then it is this okay arsenic हाँ okay you guys are saying copper mercury lead fine fine यही होगा मेरे वाले से ही बता रहे हो ना देख के ठीक है copper mercury lead so this is D penicillamine fine copper के लिए best है okay now coming here so bullet fingerprinting if they ask you to choose however which is the best is it primary marking or is it secondary marking it is going to be secondary marking so primary marking what tells you about the make overall make of gun but secondary marking is what is specific for that gun because it has that lubrication ka defect and us gun ka defect so both but both nahi hai then secondary is better okay so I answered that question also for you identify the skull fracture this is hinge fracture okay motorcyclist fracture bolte isko this is the middle cranial fossa getting injured fine then this was again thoda difficult question that they had asked in iron toxicity. The trick that you have to remember is that strictures or fibrosis happens in the last phase. Okay. तो अगर ये पता है तो भी 2 ऑप्शन मिलेंगे so remember that first you can have bleeding then comes the asymptomatic phase so the answer here is C so how this iron toxicity progresses is first GI bleeding then asymptomatic then liver failure and this is the last stage okay so this you will not go wrong order of teeth so here they are asking about permanent teeth so first permanent teeth to appear is the first molar so let's see if that helps C1 gives you 2 options left so I can rule out these 2 then you know that third molar is the last one to appear right so that must be 4 so isse mera answer solve ho jayega so A is going to be next and then you have lateral incisor so the order in permanent is first molar then you have the canine and then you have lateral incisors coming okay ages of fusion इसमें एक चीज याद रख लो lambdoid suture is 45 years okay so if you know that answer वैसे ही solve हो जाएगा so medial end of clavicle is 21 to 25 okay no this is 22 to 25 yeah that's why it's so close that's why just remember lambdoid is 45 if they give this exact question this will remain the option so medial end is 22 to 25 sacrum as a single bone sacrum as a single bone is not 50 years. Wait, we have to see again. So, lambdoid is 3, no? D3. Ma'am solved wrongly. So, D3. So, answer becomes this. So, medial end of clavicle is 21 to 25. B is 1. Crista scapulae is this and this is 3. Okay, so don't make mistakes like me in reading stuff. So, this is answer B. Just remember what I said. Lambdoid suture is at 45 years and you will be sorted. Okay, fine. All right. Now we have few more plants and seeds that they have asked. So I don't know why they have asked this. It's not even poisonous. इस सवाल का लॉजिक मुझे समझ नहीं आ रहा if anybody knows do let me know these seeds are Nigella sativa seeds which are known as kanoji in Hindi okay which is useful. It has various benefits. I was just trying to read this up, Nigella, and they say that ye kanauji ke seeds are very useful to be eaten and it has various benefits. I didn't understand why this was asked. अगर किसी को कुछ significance पता है मुझे बताना. Now, drowning is something which always gets you kalonji. Yes, correct. So we have seawater and freshwater drowning. So apparently all of you know. Is it like really good? Is it good for you? How many of you eat kalonji? Anyways, so freshwater, seawater. So freshwater, seawater. Freshwater mein kya hoga? You have freshwater which goes in your body, so you have hemodilution. So low sodium, low chloride. And because of hemodilution, yeah, now don't tell me used in pickle and everything. Stop. Okay, come back. So low sodium, low chloride, it will be real. I asked medical significance, okay? What is medical significance? Don't tell it tastes good in pickles, it is good for hair growth. In higher doses it's cardiotoxic. See, so zyada if you think ki zyada kalonji aaj hi kha lenge to hair fall nahi hoga, you will die. Don't die. So low sodium and low chloride, what will happen? RBC will get lysed, so there will be more potassium. Okay, on the other hand, seawater, because sodium chloride is coming, you will have high sodium, high chloride, you'll have other strontium, magnesium, other impurities. Okay, so in seawater I will find hypernatremia and I will find myocardial anoxia. Okay, others are finding of fresh water. If I can test this chloride in the left ventricle, that is what is known as Gettler test. Okay, तो आंसर क्या बनेगा? B बनेगा. Okay, चलो next. Next, identify the plant in the image below. This also I don't know why they have asked. This is Argemone mexicana, तो इससे थोड़ा PSM पढ़ लेते हैं फटाफट. I will not cover this tomorrow. Tell me, Argemone mexicana is what toxin? What toxin can this give? It can be mixed with mustard oil. So this leads to epidemic dropsy. Sanguinary आएगा. Epidemic dropsy. They will tell you limb swelling, heart failure. Okay. So that's why this plant is important. You all know neurolathyrism, khesari dal. Okay. This also I will not cover tomorrow. Then what is this? This is cocaine. Erythroxylum coca. Okay. So this covers FMT. कितने हो गए? 4 subjects done, right? Oh, we are halfway through. We are only halfway through. So now we have ortho, then we have ENT, anesthesia, ophtha. So all surgical short subjects now. Are you guys ready to start? Ortho is very cute. Don't have much. Okay, fatafat ho jayega. Ortho will be the quickest. Ortho anesthesia will be the quickest. Tomorrow, nahi, day after tomorrow. Day after tomorrow. All right, chalo, let's start. No break. Let's take a break. I'll give you 2 minutes break after ortho. Okay, I will bring Zara and we'll talk to Zara after 2 minutes. Okay, because she has woken up. And thank you so much that I'm teaching like a wow. Thank you. 5 minutes break after ortho. ठीक है? Ortho के बाद. Okay. Because you will need break before ENT ophtha. ENT ophtha of INICT is literally something which is not a wow. Okay, तो अभी पढ़ लो ये फटाफट, फिर break दूंगी. ठीक है, चलो. 2 hours में 4 subjects is good only. That's true, but by our standards, we have raised our standards so much that when somebody says that we will cover one subject in 2 hours as rapid revision, we are like, what? We will cover 4 subjects in 2 hours. So that's what is our standard. But yeah, no offense to anyone. All right, let's start. Let's start with complications of fractures. So we have dyspnea, confusion, and fatigue. चलो शुरू करो जल्दी. Dyspnea, confusion, fatigue after fracture. Diagnosis: fat embolism. Okay, so any long bone fracture, particularly femur fracture has happened, then you have diffusion, confusion. This is the triad. Fat embolism, we have GERD criteria, जिसमें आपको urine में fat crystal मिल सकते हैं. There can be emboli anywhere. Remember, what is the treatment? Lot of people say heparin here. So heparin is something that you may give, but the mainstay of treatment here is oxygen. You just got to prevent this dyspnea. All right. So just give them oxygen and give them ventilation if needed. Otherwise, no treatment for this embolus. This is not a thromboembolism, right? That you need to give anticoagulation. If they tell you hyperkalemia, hypocalcemia, decreased urine output post limb trauma, this is crush injury. Crush injury leads to rhabdomyolysis, which is leading to renal failure. Then, if they tell you wrist flexion hua hai leading to spontaneous extension of the fingers, this is what is known as the Volkmann's sign. This is a complication of Volkmann's ischemic contracture, usually seen with supracondylar humerus fracture. This is also something which happens in the late stage of the compartment syndrome, right? So compartment syndrome के end stage में हो जाता है. So for that we have to do fasciotomy if the pressure exceeds 30 millimeters, right? What is the last sign in a compartment syndrome? Very controversial question, but you can remember pulselessness. Okay, so pulselessness, paralysis, people keep disagreeing on it. There is no answer with any reference particularly, but this is what you can believe, pulselessness here. Pain and burning of hand with patchy osteoporosis after fracture, very important. Sudex osteodystrophy. If this question comes, you will give me party. Okay, so if there is patchy osteoporosis word mentioned, there is Colles fracture followed by this burning of the hand, also known as complex sympathetic syndrome. Fine. So this is Sudex osteodystrophy. History of massage, I'm sure you all know, this is myositis ossificans. Again, something which happens pretty commonly with supracondylar humerus. Okay, so supracondylar humerus is what is very, very important. Okay, then what is this that you are seeing here? This is a type of myositis ossificans. It's just something very different, even though the name is myositis ossificans progressiva. Okay, so myositis ossificans progressiva is what you need to remember here, that there is complete fusion. Look at the bones, they are completely fused. You will see a lot of contractures here. So this is what you need to remember. It's nothing to do with myositis ossificans. Just because it mimics it, we have named it this. It's also known as FDOP. Okay, FDOP, or you can remember MO progressiva. Okay. Then we have STOS therapy. STOS therapy किसके लिए होता है? So complications are now done. Going on to the next topic. So STOS therapy is for vitamin D. This was previously recommended in rickets, where you would give 6 lakh international units in the same day. 1 lakh unit per, so you'll give 6 doses 2 hourly. So 1 lakh unit every 2 hourly in the same day you will give, either as IV or not IV, IM or oral stat. Okay, so this is what was known as TOT, and then you maintain it with 400 international units OD. Okay, so this was for treatment of rickets. Now let's talk about a few displacements and deformities. In supracondylar fracture displacement, FDOP is fibrous dysplasia ossifica progressiva. It didn't tell you because of this reason only. नाम से पता लग जाएगा. If you see progressiva, it is that. Okay, it's the same thing. Supracondylar fracture displacement. What is the displacement type? It is going to be a dorsal displacement. So this is the extension type of fracture, which is very common. It is proximal impaction, and there is medial tilt. So you can remember DIM here. This is the displacement in a supracondylar fracture. The most common one is your extension type. So dorsal impaction, medial tilt. This is the detailed answer. They can give an all except question. Okay. Not 60,000, 6 lakh. It is 6 lakh. Okay. Just check. You are also Zainab. Zainab, please check. So this is supracondylar fracture displacement. Yeah, the 3 bony relationship is going to be maintained. Fine, the 3-point bony relationship will be maintained. The deformity is gunstock deformity in supracondylar, which is cubitus valgus or varus. Valgus will be seen in lateral condylar humerus. This is because of malunion or non-union. So it is malunion that you see in supracondylar. It is going to be non-union in lateral condylar. Fine. Then fishtail is what you see. No, this is what is STOS. Okay, 6 lakh, 6 doses, 1 day. This is what I have read. Okay, if it is 60K into 10 days, effectively the same thing only. It's a more relaxed regimen. It's not something that Stoss said. Stoss ne bole ek din mein khatam karo. Fine. Then fishtail. So that, you know, anyways, so fishtail is distal humeral deformity, distal humerus fracture deformity. Then we have dinner fork and garden spade. Dinner fork is what you see in coolies, and coolies happens because of push in what? Coolies happens if there is fallen outstretched hand in extension. And the order of correction, how do we remember? We remember it as propaganda. So propaganda, you are gonna do pronation. So propaganda याद रखो तो ये सारा हो जाएगा. So propaganda. Okay, not propaganda. One other way of remembering is you are a proper gunda. Okay, if you want to say in Hindi, proper gunda. Anyways, let's not waste time. So this is pronation, then palmar flexion, and ulnar deviation. Okay, ulnar deviation. Okay, so this is the order of correction. And then what cast do you give them? You give them this hand shaking cast. Okay, so this is the hand shaking cast that you're going to use in Kohli.
चल रहा है मैम। वो कर दिया मैम, कर दिया।
हाँ ठीक है। Can you guys see me and hear me now? Am I back? All right. Okay. Yeah, something happened with my Wi-Fi. So here I am. चलो स्टार्ट करें। सब तो ब्रेक हो गया है ना? नाउ नो ब्रेक्स, ओके? ब्रेक वाज डन। सी ऑटोमेटिक व्हेन यूनिवर्स सीज दैट एवरीबॉडी कलेक्टिवली नीड्स ब्रेक, यूनिवर्स गिव्स ब्रेक। ऑलराइट, चलो लेट्स स्टार्ट नाउ। सो दिस वाज अबाउट दिस। नाउ हो गया ना ये वाला सब कुछ? फाइन। नाउ लेट्स सी सम मोर इमेजेस। ऑलराइट, ओके, थैंक यू। When will the video go down? Go down? Go down or get uploaded? When will it be deleted? I mean, after the session is over, we will delete it from YouTube and then we will upload it on the app. Okay, chalo, let's start now very quickly. First one, just tell me whether it's choke part or it's Liz Frank. So here what you have to see, is it intertarsal? Here Hindi mnemonic, we say no कि बीच चौराहे में. So बीच चौराहे, you remember beach tarsal. Intertarsal, in the middle of big tarsal bone, if you have dislocation, it's chopa. Okay, but if it's very French, very subtle, you know, French people very subtle, so that's how you will remember. So this is what is Liz Frank. Last में कुछ रह गया था? क्या रह गया था लास्ट में? ओके, मैंने तो बोल दिया था, इट डिडंट रीच यू. सो गार्डन स्पेड is it Smith fracture, which is in flexion. Fush is in flexion there. All right, fallen outstretched hand is in flexion. There you will see garden spade deformity. ठीक है, चलो आगे बढ़े. Right, so this is Lisfranc, which is tarso-metatarsal dislocation, whereas intertarsal is going to be Chopard. So that's the first confuser for you. The second confuser that I have for you here is this one. Is it a Jones fracture, a pseudo Jones fracture, or a stress fracture? So when you see it's a horizontal fracture, right? It is at the metaphyseal diaphyseal junction. This is what is known as a true Jones fracture. If it is an avulsion fracture where just the tip is out, that is what you call as a pseudo Jones. That is what is known as a pseudo Jones fracture. And if you see a diaphyseal fracture, that is what we call as a stress fracture. Okay, so stress fracture, Jones fracture, pseudo Jones fracture. Okay, that is what you need to remember. Pseudo Jones fracture is peroneus brevis. All right, it's an avulsion fracture from peroneus brevis. Okay, this is what you need to remember. No, this is not glass holding, this is hand shaking. Remember, for hand shaking, you need to have the thumb out. तभी हाथ मिला पाओगे ना. Glass holding will have the thumb also covered. Fine, that's how you can distinguish. Okay. Going ahead now into the next confuser, anterior versus posterior hip dislocation. So when you see that the hip joint is dislocated and the femur is upper, they will give you that there is limb shortening, and the patient will assume this position, which is known as FADIR, flexion, adduction, internal rotation. So shortening and FADIR, posterior dislocation of hip, most common dashboard injury. So when will I have FADIR? I will have FADIR in TB, hip arthritis and posterior dislocation. Just remember this. So everything else becomes Faber, right? दूसरा table करना ही नहीं है. Everything else will be Faber. Fine. Then when we look at this, what is this? If I tell you there is an obese adolescent with hip pain, what is your diagnosis? This only will tell you I am seeing skiffy, slipped capital femoral epiphysis. There is posteromedial displacement of the epiphysis here. So this is skiffy. Here what you have to do for diagnosis is you draw a line from the metaphysis. Normally it should cut. Normally it should cut the femoral epiphysis. Here, because the epiphysis is shifted, it will not be cutting. This is known as the Kleen's line or the Tridovan sign. Okay, so just remember these name: Kleen line, Tridovan sign. This is skiffy. It's a type 1 Salter Harris injury. It's an epiphyseal injury. It's a type 1 Salter Harris. Then can you tell me the diagnosis on this MRI? When you see that there is a paradiscal involvement around the disc, you have this collection, you have an epidural component. This is typical pot spine where you see a paradiscal involvement. This is typical pot spine. A few one-liners for you. What are markers of bone formation? Because there are 3, they will ask you all except question. So ALP, calcinectin malformation, everything else is resorption. So ye 3 yaad rakh lo, everything else will be done. Posteromedial displacement of the epiphysis is what you see here. Okay, just the theory part. Then we have 3 triads for you in 3 different colors. Femister's triad is for TB. Okay, it's not stuck. It's not stuck. It's in TB where you have osteopenia, erosions, joint space, very non-specific triad, but it's for TB is what you need to know. O'Donnell's triad, remember, is MAM. So 3 ligaments in the knee, MCL, ACL, medial meniscus, and terrible triad of elbow is dislocation, radial head fracture, coronoid fracture. So just go through these once, and these are the 3 triads that we need to remember. Then in the hip, when you have this sclerosis and you see that there is a lucency within, black within, this is what we call as crescent sign, something that they love asking. This is avascular necrosis of hip. In the exam, if they give you hip x-ray, आपको नाम नहीं पता, mark AVN. All right, so this is crescent sign. Out of these 2, which is fracture? The first one that you have here is fracture patella. So this is fracture patella that you are seeing, whereas here, because the margins are very well corticated, this is what is known as bipartite patella. So this is bipartite patella. It's a congenital variant. It is not something which is trauma. It does not have this clear-cut line as a fracture does. Remember, in fracture patella, what we do is tension band wiring. This is something which has been asked. So this is what we do for patella and olecranon fracture. And what they do is D2C. They convert the distractive forces into compressive forces. Remember D2C. Shark Tank में बोलते हैं ना D2C direct to consumer, वो याद रख लो. So distractive to compressive. Then what you see here, can somebody tell me diagnosis on this? There is history of trauma. I'll be very happy if you can pick this diagnosis. So what you see here, can you see there is one avulsion fracture on the lateral part? How I know lateral? This is fibula. So on the lateral part, there is this avulsion fracture from the lateral capsular ligament. This is what is known as Segond fracture. Okay, so this is known as Segond fracture that you are seeing here. And what you can remember in Segond fracture is, there's something very cool on YouTube. I don't know if everybody can do it. Like if we block one person, then we don't see their comments, right? So we can block people also. This I didn't know earlier. Nice. So this is Segond fracture where you have lateral capsular ligament avulsion. Okay, so Segond fracture is lateral capsular ligament avulsion, and this is associated with ACL injury. Okay, so ACL injury is Segond fracture. Okay, is what we need to remember. Then in meniscal injury, what we have to know is we have red zone, we have white zone. Red zone is the one which is bumper fracture is a tibial plateau fracture. Complete tibial plateau will be fractured. This is just an avulsion fracture. Okay, right. Now coming back to meniscal injury. So the red zone is the one which is vascular. है ना, यहाँ पे vascularity ज़्यादा होती है. So this is where we can repair. This is where we do meniscal repair. But here in the white zone, the central part, if there is an injury, we don't repair. You have to resect. Just resect the meniscus. This is what you need to know about the management of meniscal tear, repair versus resection. Then what you have to know about CTV. In CTV, we have cave. So cave are the 4 things that we have. cavus, adduction, varus, and equinus. So cavus, adduction, varus, and equinus, these are the 4 deformities. There are 2 methods of correction that you need to know. Kite's method was followed earlier, where 1 by 1, every 2 weeks you're gonna correct 1, 1, 1. Ponseti method is the one that we prefer now, where C is treated first, AV in between, and then E later on. All right, so this is the order. Ponseti method is what is preferred now. Okay, so remember cave. The angle that you need to remember here is the kite angle in CTEV. ठीक है? Few questions, repeat questions. What is this? You see all of this black, black, black. They're talking about prosthesis and implant. This is metallosis. Where do we see a patellar clunk? Remember, this is seen in femoral component during extension. So these are just questions which you need to know as theory. Then what is the diagnosis in this one? What is the diagnosis here? So here this is not very clear on the image, but what you are seeing is a triangle. So we will see this Fairbank triangle here. The Fairbank triangle is something that you're going to see in coxa vera. Okay, so theoretical question आता है coxa vera में Fairbank's triangle मिलता है. Can you tell me the gate in coxa vera? The gate that we see here is the Tredellenberg gate. Okay, so Tredellenberg gate is what you see in coxa vera. That reminds me of this question. You have to remember Dolly. They'll give you a scenario and the droop is going to be on the opposite side. So Tredellenberg gate can be seen with superior gluteal nerve, greater trochanter fracture, and the muscles which are inserted here are gluteus medius and minimus. Okay, so these you remember in continuity. Okay, droop on the opposite side. Fine. Then Gustillo-Anderson classification. So patient with open wound, which is 3B. So here it's actually arranged in order only. So if it is less than 1 centimeter, it is Gustillo-Anderson 1. If it is 1 to 10 with no soft tissue injury, it's 2. If it's more than 10 with soft tissue coverage not required, it is 3A. More than 10 with requiring soft tissue coverage is 3B. And the moment they tell you vascular injury, it is 3C. So this way we have revised entire Gustillo-Anderson. They can ask you vascular injury, or they can ask you where is periosteal coverage or soft tissue coverage required. All right, this is what you need to remember. Then while examining a patient in supine position, examiner keeps his hand below heel of one foot and asks to flex the other hip while keeping this weak leg straight. What is this known as? Here, if one of the options I add as Thomas test, I know for a fact that most of you will read flex hip against resistance and you will mark Thomas test. But in Thomas, do I keep hand below the heel? No. This is what is known as Hoover's sign. Remember, just because Thomas has been asked, everything is not Thomas. Okay, I know where you will make mistakes. So Hoover's sign is what you test for, again, paralysis versus pseudo paralysis. If person has pseudo paralysis, if I flex one limb, the other limb gets lifted. Okay, so this is what is known as Hoover's sign. Then in spine straightening surgeries, screws which are used for fixation are always inserted through the pedicle. So this is the spine, right, where you have the 2 pedicles, and this is the spinous process. So when we want to enter the spine, this is how we enter via the pedicles. Okay, we never go so medially, varna spinal canal mein chala jayega, but this is how you enter pedicle screws. Okay, so they can ask you about pedicle screws. Fine. Next, very easy question. Maid lung deformity is seen in the wrist. This is associated with Turner's syndrome. Hag lung deformity is calcaneum. Don't confuse these two. Maid lung is wrist. Haglund is calcaneum. So let's see if our answer can be made from this. हाँ, पहला ही अगर पता है तो आंसर बन जाएगा. C is 5. Buttonhole is seen in RA, and gunstock we already know is cubitus varus, which you see in supracondylar humerus. Valgus is lateral condylar humerus. Okay. Intertrochanteric fracture. Very, again, epidemio, should I remember? Not at all. Let's see if we can still solve the question. Look at option C. It is associated with non-union. You know miss and you know flutes. If you remember miss, everything is sorted. So malunion is more common in intertrochanteric, it is more common in supracondylar, and it is more common in Colles and clavicle. Right. So if you know this, I know that non-union is more common in neck of femur. So this is definitely false. So can you see how मेरा आंसर वैसे ही हो गया. I don't even have to read the other options. है ना? B and D. So what is true? 1 year mortality is 20 to 30. It can be reduced by operating. So fine, good to know, but I didn't have to know this. Okay, so this is how you don't leave questions by just looking at them superficially. All right. Next question. We have an old female with backache not responding to conservative treatment. She has pain that worsens on walking, but she feels no pain on climbing up the stairs. This is very typical of lumbar canal stenosis. Here, the neurogenic claudication is pain on the first step, and when they are climbing up, or they have shopping cart. Remember, there is a shopping cart sign. अगर आप उनको ग्रोसरी स्टोर ले जाओगे, और यू विल टेक देम टू एयरपोर्ट्स वेयर दे हैव ट्रॉलीज, यू नो, wherever there is support, ट्रॉली है या फिर शॉपिंग कार्ट है, their symptoms will improve. This is the typical finding of neurogenic claudication of lumbar canal stenosis. Okay, then arrange the following external fixators in order of increasing stability. So obviously ये तो बड़ा लॉजिकल, कुछ पता भी नहीं है फिर भी आपको पता लग जाएगा कि one rod obviously must be less stable than two rods, which must be less stable than biplanar frame. So let me see. So then the answer becomes this, Ilizaro is the most stable. है ना? तो ये भी again logical है. Pain on first step is osteoarthritis. That's also okay, but the fact is we're not comparing OA-RA. I'm comparing neurogenic claudication versus vascular claudication, right? So we're on a different topic altogether. Fine. So steps of surgery of DDH in a child. Again, if I don't know, just look at the options. Placing the head back into acetabulum. Okay. So why not A? So anyways, so placing the head back into acetabulum obviously has to be the last step, isn't it? So that's how you approach the question. Ki pehle capsulotomy, identify true acetabulum, femoral osteotomy. Even if I don't know, I have to take a guess, I will go with this one. Okay. Is the answer given as A in other places? Yeah. 2, 4, followed by 3, followed by 1. Yeah, that only. Sorry. I said that only, but I marked the wrong one in a hurry. So we have one rod, then two rods, then this, and then one. Yeah, you are correct. Okay, it's one only. That's what I described, just that I marked the wrong option. So this is ACBD. Fine. Okay. Then we have again Tredelenburg. So if you were listening, this will be very easy. So patient was asked to bear weight on the right lower limb, left-sided droop down. So Dolly is opposite, so droop is opposite, so the problem is on the right side. So now right inferior or superior, so right superior, either of the options they'll give you, either it was maximus or it was or it will be minimus and medius. So we have to go with medius minimus, superior gluteal. Okay, that is what you need to remember. Fine. So this is about this. All right. Okay, chalo आगे चले. All right, so now we are going on to anesthesia. So in anesthesia, first slide is on drugs, then we have few images, and then we have MCQ. So again, cute subject, let's finish it in 20 to 30 minutes. Right? Are we all on the same page? ब्रेक तो हो गया, अब कैसा ब्रेक? अब Zara को एंड में ही लाऊंगी. If I bring Zara right now, no, then she'll not go. She'll cry. Because you know she will want to be with me, she'll not go, वो रो धो के जाएगी, and that will take up a lot of time. So end में Zara को I'll bring. She's eating also right now. Ravi is feeding her food, so उसको भी खाना खाने देते हैं. If she sees me, no, she'll not eat also. So later on. ठीक है, चलो पढ़ लो, anesthesia पढ़ लो. Fine, quickly let's study anesthesia. So IV anesthetic agents, what is the drug of, चलो फटाफट आंसर बताओ. Drug of choice for day care, liver kidney, neurosurgery, total IV anesthesia, practically everything we use it as the drug of choice. It is propofol, right? So that is propofol. The one very important side effect, dissociative anesthesia, because it's a phencyclidine derivative. Drug of choice in asthma, cyanotic heart disease, and shock. It is ketamine. Why my time is not changing? That is how I get my work done. That is the secret of my success. Time doesn't move for me. That's why when I said we will complete 8 subjects in no time, that is what I meant. That time will not change and we will finish 8 subjects. So ketamine, remember, all pressures will increase. So it can cause increased blood pressure. It can cause increased intraocular pressure, increased intracranial pressure. This is why it is contraindicated in all of these conditions. Okay. Then contraindicated, so this only. So contraindicated hypertension, epilepsy, glaucoma. Okay. Then drug of choice in cardiac surgery and side effect is adrenal suppressant. Okay. So this is etomidate. Etomidate has one use only. It is cardio stable. And lastly, hyperthyroid and seizure, because it is a neuroprotective agent. Who am I talking about? We're talking about thiopentone. Okay, thiopentone. ठीक है, chalo. Next, the local anesthetic causing hypertension is cocaine. Has been asked too many times. Cocaine is the earliest local anesthetic, but obviously we don't give cocaine now to people. Most cardiotoxic is bupivacaine. Maximum dose of lignocaine, remember, 5 mg per kg without epinephrine, but if giving with epinephrine, we can increase to 7 mg per kg, because epinephrine will cause vasoconstriction, less risk of systemic toxicity. If there is systemic toxicity, again, CVS, CNS will go. The drug of choice is intralipid. Kitna intralipid? 20% intralipid solution. This has come as a repeat question. Can you tell me 2LA जो कि 2LA जो कि मेथ हीमोग्लोबिनीमिया करा सकता है? We have benzocaine and chlorprocaine. So chlorprocaine, benzocaine can cause meth hemoglobinemia. All right, so this is what we need to know. Now going on to next chapter, muscle relaxants. The muscle relaxant which is causing depolarizing. Then we have hyperkalemia, and the only indication where I use it is rapid sequence, because it's the shortest acting that we have. It's succinylcholine. Okay. Yeah, benzocaine and prilocaine also. Benzocaine, prilocaine, chlorprocaine, all three causing meth hemoglobinemia. ठीक है. Muscle relaxant, succinylcholine, most cardiostable one is V curonium. Okay, so heart ka HE, VE ka V curonium. Okay, is what you remember. Hoffman elimination. So the drug which is safe in renal and liver failure, because it can be eliminated by Hoffman elimination. What is that drug? That is atracurium. But the problem with atracurium is the fact that it produces a byproduct known as laudonosine, which can cause seizures, right? So that's why what do we prefer? We prefer the bi of atracurium, which is cis atracurium, which produces less of laudonosine. Okay, that is what you need to remember here. The reversal agent that we use for muscle relaxants is neostigmine, but because neostigmine will produce a lot of secretions, what else do I have to add to reduce secretions? We have to add glycopyrrolate. Okay. Now we have a new cyclical reversal agent which is known as sugammadex, that is useful for V and Rho, vecuronium and rocuronium. Okay, so this is a new reversal agent. Going on to inhalational agent, first identify the 4 ones. The one which has a distinct Tech 6 vaporizer. What is this? This is used for desflurane because it has a different boiling point. Then we have these 3. Yellow, children like yellow color. So you remember this is sevoflurane. It has a sweet odor. Okay. So this is the one that we prefer in children for induction of anesthesia because it has a sweet odor, but you know, some kids can be very toxic. So just like those toxic kids, it produces a compound A, which is nephrotoxic. Then purple, remember PIL that we keep filing for different cases ki date बढ़ा दो, date कम कर दो. So this is purple, it is isoflurane, okay? And then red because danger, it is most potent, but it causes autoimmune hepatitis. So that is halothane. So you need to identify the vaporizers first. Okay, how is it safe in renal failure patient if it causes seizures? So there are two different things. It is safe in renal and liver failure because it undergoes Hoffman elimination. It does not need that. But the side effect is it can produce seizures. Okay. So what you need to know now, MAC. The MAC is going to be inversely proportional to the potency. So lower the MAC, more the potency. So MAC 0.2. MAC 0.2 is something which is the most potent. Who is that? It is methoxyflurane. But because it is toxic, it is nephrotoxic, we don't use it, even though it is most potent. The other one that we use, which has a MAC of 0.75, is what we just discussed. That is halothane. Okay, that is halothane. And the one which is least potent with a MAC of 104 is N2O. All right. So this is what you want to remember. This is inversely proportional to the potency of a anesthetic agent. Okay. Blue के ऊपर लिखा है Tex 6. This is a special vaporizer. इसका डब्बा देखो, अलग डब्बा है ना. डब्बा means box. Okay. Tex 6 लिखा है. ठीक है. फिर हम जाते हैं blood gas partition coefficient. This is going to relate to the speed at which it acts, again inversely. So the minimum value yaad nahi rakhna, the minimum partition is the fastest agent, that is xenon, but we don't use xenon. So out of the one that we use, the fastest is desflurane. Okay, that's why desflurane is the one which is mostly preferred. Okay, and then the maximum one which has the slowest speed. सो जिसको पोटेंसी देते हो, भगवान अगर कुछ दे रहा है तो कुछ ले लेता है ना. हियर ऑल्सो इफ गॉड इज गिविंग यू पोटेंसी, ही विल टेक अवे स्पीड. सो स्पीड में मैक्सिमम, आई मीन द स्लोएस्ट इज मिथॉक्सीफ्लोरेन फॉलोड बाय हैलोथेन. Okay, that is how you can remember. And these three effects are all seen with N2O, so N2O, why do we use? It has no potency, it has very low potency, but I still use because it concentrates the next gas, the next inhalational agent that I give with N2O. The problem is when N2O comes out, it will also have diffusion hypoxia. All right, so this will also have diffusion hypoxia. So we need to give oxygen to the patient. This is what you have to remember. Fine. Now let's identify the cylinders. Any doubt that you have specific, which are not from what we are discussing, unko baad mein पूछ सकते हैं, right? We can just be cordial to the other people who are with us and ask doubts later so that we don't break the flow. Then we have all of these cylinders that we have to identify. So the first one is where you have black t-shirt and white shoulder. That's how you remember a girl with white shoulder and black t-shirt. This is oxygen. Complete blue is N2O. Then what you have to remember, white shoulder and then this also. So this is a mixture of oxygen and N2O. So this is what it is. It is a mixture of both, which is known as Entonox. So this is Entonox. Then you are seeing gray, black, white, everything mixed. So this is just like air, where you have carbon dioxide and you have oxygen. So this is air, and complete gray is CO2. Next point is we need to remember the pin indexes of everything. Entonox सबसे easy है, index 7. Then remember, I need air to survive, right? So that's where your next series starts off 5. So this is 1, 5. Oxygen में कितने letter है? O2. So this is 2, 5. N2O में कितने letter है? 2N और एक O. So this is 3, 5. So in this pattern only you will remember. Okay, 1, 5, 2, 5, 3, 5. And CO2 is 1, 6 or 2, 6 depending on the concentration. Now if they want to ask you very difficult question, they can show you this image and ask you, बताओ ये किसका cylinder है? What is the pin index being shown? So if it is just one, that is the easiest because it is Entonox. Agar ek hi hai, so I will do it. After that, you just have to see how the holes are placed. If they are lateral, this is how we have the 6 holes which are placed. If they are touching the wall, side mein hai, it is 1, 6. If they are lateral but not touching the wall, it is 2, 5. And if it is in the center, it is 3 or 4. You can notice how 4 does not come anywhere. So if it's bang in the center, it's 3. Okay, if you didn't understand, let's see now. Look at this one. Look at this cylinder. Okay, now what is this? You can see both are lateral touching the wall. तो ये क्या बनेंगे? This will be 1 and 6. Are you understanding? 1 and 6 किसका है? This is carbon dioxide. Now look at this. One touching the wall, one is lateral but not touching the wall. So this becomes 1, 5. 1, 5 कौन था? Air था, needed for breathing. And then what is this? One is in the center, one is lateral but not touching the wall. So this will be 3 and 5. 3 and 5 कौन था? 3 letter and 2. Look at this. Both lateral not touching the wall. 2, 5. 2, 5 for oxygen. Did you understand? This is the toughest possible question that they can ask you from pin index, is to identify. Are you guys understanding this? So this is pin index for cylinders. Cylinders are your high pressure system. One of you is asking about this diameter index is for the pipelines. The pipelines are your intermediate pressure system. Okay, I hope this is clear to all of you. Look at these 4 now. So this is the neuromuscular stimulation that I do. Can you tell me the most common nerve that I use for testing my neuromuscular blockade? What is the nerve that we most commonly use? The most commonly used nerve is the ulnar nerve, and the muscle is adductor, adductor pollicis. Okay, adductor pollicis is what we have to know. Without any drug, if I give 4 stimuli, here I am giving them at a frequency of 2 hertz. Every 0.5 second, I give one stimulus. So normally, all 4 will have the same height. Okay. Then, if I give a non-depolarizing, like any rocuronium, vicuronium, any non-depolarizing blockade, every one will reduce. It keeps reducing. So this is known as fade. If I give succinylcholine, it will have, because it's a depolarizing agent, right? So there will be TOF of 1. It will act just like normal, but the height will be lower. Do you see this? Because it's succinylcholine, it's not acetylcholine. So the height will be reduced. But what is asked is, in the phase 2, you see an abnormal response where the TOF ratio also becomes like a non-depolarizing. So remember, where do you see fade? I see a fade in phase 2 and I see a fade in non-depolarizing. Understood this concept? ठीक है, ये हो गया हमारा train of 4. It's the most common stimulation you give. TOF is train of 4. 4 stimuli we are giving. ठीक है. Now for capnography curves, which are very important. So for CPR assessment, what do I need? I needed, some people say more than 10 mm, some people say more than 20 mm. This tells you that this is an adequate, okay, this is an adequate CPR which is going on. Fine. This is about this. The Siri is moving constantly.
Interesting question.
Okay. Siri says it's an interesting question. Fine. So this.
Sure, just ask.
Oh God. How to end Siri?
Interesting question.
Okay, Siri is gone. So this is about CPR assessment. Now, when we have sudden increase in EtCO2. So now when we have sudden increase in EtCO2, very, very important. This is the earliest sign of malignant hyperthermia. Okay, this is earliest sign of malignant hyperthermia. Don't wait for hyperthermia. Okay, I mean, don't wait for increasing temperature here. ठीक है. So this is sudden increase in EtCO2. Then this already you guys know, drug of choice is dantrolene, rhinodine R, chromosome 19. I've already told you. Sudden loss of waveform ho gaya. There are 3 possible conditions here. One is your circuit only is disconnected. Second, you have cardiac arrest. And the third is most important for exam is air embolism. So in air embolism, what we have to do is the Durant position. Durant position is Trendelenburg, meaning head down. Okay, weird technological issues have started happening. So this is Trendelenburg position, and then we have left lateral. So you put right side up. This way the air gets trapped in the right atrium and we can suck it out through a central line. Okay, so this is what we do for sudden loss of waveform. And for decreasing EtCO2, remember decreasing EtCO2 means that there is esophageal intubation. esophageal intubation. Okay, so this is what you need to remember as far as these capnography are concerned. Okay, no, very good question by John Smile. Very difficult to name you have. So what you want to remember is, if the baseline keeps increasing, okay, if it increases like this, that is what is known as soda lime, you know, is exhausted. Your soda lime is not working, it's exhausted, hence the baseline CO2 is increased. So you have to just change. It's a rebreathing circuit which is happening. You have to change the circuit. Okay. Oh yeah, the time changed. Wow, this has never happened before. So today is very special day for all of us, where it is showing true time for the first time ever. But my concern with that is, those of you who noticed that, why did you notice that? Why is your attention on time and not on this nerve which is getting blocked? So what you have to now see is the nerve blockage. So two images have come in the exam. If they show something in the medial part of the eye being blocked, it is nasociliary nerve. So this is nasociliary nerve which is blocked. And if they show you this medial part of the eye, this is anterior ethmoidal, right? So this is where you have anterior ethmoidal nerve. Okay, यहाँ पे infraorbital करेंगे, below eye, above eye supratrochlear, medial and medial to the eye infratrochlear. So just remember this image. Okay. All right. Maybe Siri thought this was interesting question, that why is time always same in your iPad? Siri heard and she was like, oh, this is interesting. Let me work on that. And then she was working all this while. Cool. So now few one-liner question. Most common circuit in spontaneous is, I'm talking about Mapleson circuit. Which circuit? A. Circuit A. So here you have a name. If it is coaxial, we call it lax. Otherwise, we call it Magill's. Okay, so Magill's and lax is what is spontaneous. In controlled, we do D, Bain's circuit. Okay, so Bain's circuit, coaxial circuit is what we use most commonly in controlled. Then rate of breathing, very very important. CPR में बहुत सवाल आते हैं. Push hard, push fast. How hard do you push? 1/3 of the AP diameter, 5 to 6 centimeters. Allow complete recoil. Okay, how fast do you push? 100 to 120 per minute की rate पे we push. How is the breathing? The breathing is given at 10 to 12 breaths per minute. That becomes 30:2. 30 chest compression, 2 breaths. 30 chest compression, 2 breaths. In children, it is double. It is 20 to 30 breaths per minute. In neonates, it is even double, 40 to 60 breaths per minute. So in neonate, the ratio effectively becomes 3:1. 3 chest compression, 1 breath. 3 chest compression, 1 breath. Both of these you have to remember. Every number I have written here, you need to know. Fine. And finally, what is the epinephrine that we give in ACLS? The epinephrine dose we give in both. Epinephrine is the only drug that I give in shockable and non-shockable. What are the two things? What if there are two people still? One person will give this, one person will give this. Okay, right. What you have to remember, in epinephrine and ACLS, we give 1:10,000. 1:10K, I'm going to give 0.5. No, I'm going to give 1 mg of 1:10,000. Which route? We are going to give IV. If IV is not available, intraosseous. Whereas in neonates, we give it via umbilical venous catheter. Okay, that is what you want to remember. All right. If there are two people, remember, they can also change. If one person is tired after 15, you can also change after 15. Okay. But ideally 30:2. One gives breath, one gives this. That is what you want to remember. All right. Okay. So this is epinephrine. Now let's talk about oxygen delivery device. What you're going to remember are the two series of numbers. What do we remember, guys? Just tell me the series and I'll know you know. 5, 10, 15, 15, 60, any limit. All right. This is the first, which is about the rate, liters per minute. This is the rate at which you give. Then the second thing is about the saturation. For this, the number that we remember is 40, 60, 60. 85 to 90%, You can give 100 for the other two. So this is what we have to remember as far as the saturation and the maximum flow rate is concerned for these 6 things. So 5, 10, 15, 15, 60, infinity, right? So this is the maximum flow rate that you're going to give for these devices. The maximum concentration is 40, 60, 60, 85 to 90%, and 100%. Okay, what are these devices? This is nasal cannula or nasal prong. This is the simple Hudson mask. This is Venturi device. Venturi device, remember 2 points. This can give us fixed oxygen, and this can be considered a high flow. There are 3 high flow devices that we have. High flow is Venturi, high flow is HFNC, high flow nasal cannula, and high flow is non-invasive ventilation. So 3 high flow, this is extra point for you, 3 high flow mechanisms here. And lastly, this is your non-rebreathing mask where you're gonna have this bag here. Okay, I hope this is clear to all of you. Okay, so this is about oxygen delivery device. Lastly, CPR ACLS I've taught you already. This is just for a pregnant female. A few points that you want to remember. This was asked as an all except question. We do give CPR and defibrillation. If they give you an option that defibrillation is not done in a pregnant female to prevent the risk of cardiac arrest in fetus, that is completely wrong. Defibrillation is done. It is safe for the pregnant mother. Okay, then what you have to remember, airway, oxygen. This is important question. The IV line should be above the diaphragm. Then you want to remember, if she is getting magnesium, give her antidote calcium gluconate. Maybe cardiac arrest is because of magnesium toxicity. Then what can be asked is lateral uterine displacement. This is done to prevent hypotension to the fetus. Next point is perimortem. If you can't save the mother in 5 minutes, save the fetus. Will perform a cesarean in 5 minutes. My question to you is this: does this require OT? Does this require a Fannelstein incision? Does this require an LSCS? Answer is no for all of them. We can do an upper incision. We can do a classical LSCS because now we don't care for mother's next delivery, right? Mother is dead already. So what you have to remember, none of these are required. We can do an upper classical cesarean. It has to be done within 5 minutes. Okay, so this is what is very, very important. The important points I have told you. All right. Above diaphragm means put a line somewhere in the hand, upper limb में देंगे. ठीक है? चलो. This question again. So the controversy is on the most susceptible. I think least susceptible is not a controversy, and that is what they are asking. So the least susceptible is C fibers. The most susceptible is gamma, according to me, because what is our mnemonic? Our mnemonic is God. When will this end? है ना? So gamma, alpha, delta is what is the order for us. What is the order of sensitivity for hypoxia? बताओ, चलो. Hypoxia. If there is hypoxia, what will you say? You will say bako. You will say bhago. You will say bako. So BAC. If I ask you what is the order in pressure, when you are under pressure, what do I tell you? Stick to basics. है ना? BTR करो. ABC. All right. So this is about all of these. Then at what level does spinal cord end in adults? ऐसे सवाल please गलत करके मत आना एग्जाम में. So in adults it is L1 lower border. In infants it is L3 upper border. Okay. So this is in newborns. L3 upper border. This is L1 lower. So answer will be L1 L2. अगर newborn पूछ रहे हैं, then you will mark L3 upper border. So you will mark L2 L3. Okay. So this is about this. Which of these can be used as IV induction? So benzodiazepine we can use. Bupivacaine and all of these are not used as IV induction, but benzodiazepine can also be used. Mechanical ventilation has to be started, which is not correct about initial setting. So PEEP is always given. Tidal volume, remember, we give a lower tidal volume. This is the only fact you want to remember. So it's somewhere close to 5 to 7 ml per kg of body weight. So itna high tidal volume is never given. तो बाकी सब automatically सही हो गए हैं. ठीक है. Which of the following is not a contraindication to use of morphine? So morphine can cause bronchoconstriction. It can not be excreted in renal failure. It is contraindicated in head trauma. It is contraindicated in biliary colic. But MI में तो हम देते ही है ना मोना, है ना, तो मोना तो हम देते ही हैं. Why would it be a contraindication? Then, how long should a patient be deferred from an elective surgery if he has recovered from COVID but not has had any hospitalization? So here answer is 6 weeks. If I tell you he was hospitalized, then it is 8 to 10 weeks. If I tell you he was in ICU, then it will be 12 weeks. Okay, so this is what we need to remember here. Then next question, grade 3 ASA, what bronchodilator findings will require further evaluation of the patient? So this is what they are asking. So here just the normal cutoff you have to remember. FEV1 less than 0.8, FEV1 by FVC less than 0.7 is the cutoff for evaluation of any obstructive lung disease. Okay, then you are an intern posted in ICU while taking blood sample for ABG. Which of the steps would you not do? Again, not do. Normal pH can't rule out acid base. That's true, because you can have a mixed acid base imbalance. Add 0.5 ml heparin. Have you ever taken ABG? ABG में we take 1 to 2 ml of blood. उसमें आपने 0.5 अगर heparin डाल दिया तो कैसे चलेगा? So this here we use 0.05 or 0.1 ml of heparin, not 0.5 ml of heparin. Okay. Then Allen's test we always have to do. You know Allen's test. We press them both, then you release one by one. Radial artery is preferred. All of the others are true. This was a repeat question. Proparacaine, the duration is 20 minutes. It is one of the shorter acting LAs. It is used for ophthalmic, short ophthalmic procedures. We will use it. Okay. RSI, this is definitely important statement. So we have to pre-oxygenate with 100% oxygen for 3 minutes. If it's rapid sequence, high volume, low pressure cuff is what is preferred. Do I in rapid sequence intubation in cardiac arrest is not something we do. When would you do a rapid sequence? When anytime there's an emergency, person is not fasting, you know, that is what you would do. In a cardiac arrest patient, we have to follow the ACLS protocol. It is CAB. Only if airway is not patent, then we have to do intubation. Otherwise, it's not something which is needed. Fine. And we do give induction and muscle relaxant simultaneously. What is the frequency of tetanic stimulation in neuromuscular blockade? What is the answer to this? Don't mark 2 hertz. Don't be in so much hurry. This is where you will make silly mistake. Am I asking train of 4? I'm not asking train of 4. I am asking tetanic stimulation, right? So tetanic stimulation is when you will give it a higher frequency so that there is a tetanic stimulation. This is what you give at 50 hertz for 5 seconds. Okay, so this is 50 hertz for tetanic stimulation. इसमें बस जल्दबाजी में टूम नहीं मार के आ जाना. Which of the following can be used for induction maintenance? So that is sevoflurane. Okay, remember sevoflurane is the only one with a fruit smell that I can use for inhalation. If I ever use desflurane for inhalation, person will cough and they will have bronchospasm, laryngospasm. So this is something which is contraindicated. This is only one which I prefer for maintenance. For maintenance, it is the preferred agent, but never for inhalational. Okay. Maximum oxygen with conventional Hudson. तो बताओ ये कैसे आंसर करोगे? You will do this 5, 10, 15, 15, 60. ये तो Hudson ये था. So it becomes 10. Do this. Don't take shortcut. Don't jump. Okay. Fine. So this is about anesthesia. All right. 10 slides of ophtha, 10 slides of ENT. Are you guys good to go? Ophtha and ENT are both subjects which will suck out the life out of you if you see previous year questions. But every time they will give you new such questions which will suck the life out of you. So don't take them very seriously. Don't let them suck the life out of you is my advice. क्योंकि इनके PYQs देखोगे तो लगेगा why am I even preparing for INICT? I should not prepare for INI. I am preparing for NEET. I am not giving exam. We will go into that mode. So you don't see these questions only. You just see whatever you can do and ultimately बाकी जो भी होगा वो अपने को श्रद्धा श्रद्धा कौन है? श्रद्धा is just feeling of hope that dear God, please give me 2-3 questions which are answerable from Ophtha ENT, and that is good enough to get rank 1. Okay, that is what was my approach for Ophtha ENT. Dear God, 1-2 बस करा देना, out of 5 that they will give me, 1-2 बस हो जाएंगे, I will get rank 1. Never target 5 out of 5 for these two. You will not be able to do. अगर आ जाते easy, very good for you, but usually they will give you very crazy questions which you will only know in recall that oh ऐसा कुछ होता है, direct gonioscope नाम का कुछ होता है, oh good to know, and then you will just forget about it. All right, okay, now let's go. 2-minute bathroom break क्या होता है? Who is stopping you from going to bathroom and using your phone and listening with earpods? Use ना, use, take your phone to bathroom. इसमें किसने रोका है? All right, so this you can take your bathroom break anytime you want. Problem is when I want bathroom break, then you will all get break. But I don't want, so now we'll have to study. So we finish off the INT, only then Zara will come, because बीच में Zara जाएगी नहीं, ये problem होगा. All right, so now let's start. Chalo. So many eyes for you. Identify every eye. What is the first eye? First eye is easy eye. First eye is when you have a baby with a blue eye. So this is congenital buphthalmos. So this is congenital buphthalmos. Congenital buphthalmos, you will have a triad of blepharospasm, photophobia, lacrimation. There are 2 BPLs in BTR. What are 2 BPLs in BTR? One BPL is Bogdalek hernia is posterior and left side. This is second BPL, which is blepharospasm, photophobia, lacrimation associated with congenital glaucoma. Tell me which stria you will see. Vogt stria, Harp stria. Harp stria, very good. So this is where you will see Harp stria. Vogt stria, where were we seeing? Vogt stria we were seeing in keratoconus, right? Okay. Then what is this? This is a coloboma. This is a coloboma, which is a fusion defect. So coloboma can be of eyelid, like in this case. It can be with the lens. It can be anywhere in the eye. This is eyelid coloboma, a fusion defect. Then what is this? अगर ये उल्टा होता, I would have called hypopyon. But this is not ulta. This is really inverse. So this is inverse hypopyon. कैसे हो गया ऐसा anti-gravity? Why is pus ऊपर and not नीचे? So this inverse hypopyon is what we see in silicone oil. So silicone oil is what is put in retinal detachment. So when that leaks out, that oil is lighter than water. So the oil goes up, right? अगर आप एक glass में एग्जाम के बाद ट्राई करना, अभी मत करना. If you fill water and you put oil, oil will float, right? So when you have kids, no, then you try this experiment with them. Okay, anyways, so this is inverse hypopyon, silicone oil. Okay, next, what are these? What are these known as? Do you know of sympathetic and parasympathetic system? Right, when you have sympathetic system activation, when you are teaching like so many people and you are thinking, your brain is on hyperactive mode, your body takes care of it. Your GI tract, your bowel bladder, every muscle is relaxed, right? That is what is known as sympathetic and parasympathetic system. That is why I don't take bathroom break in entire. This is one question which in BTR offline class I used to get in every offline class. We had circulated Google form to ask doubt, ki koi doubt has preparation related, you can ask Ravi and me. And one common doubt in that was, why is ma'am not going to washroom? And we were like, why is this doubt we getting asked? So let me just put it out there for everybody that there is sympathetic, parasympathetic system, no? Okay, chalo, next, moving on. Others are like, ma'am, mujhe to pata bhi nahi karna tha. I didn't have that doubt also. You just wasted my 2 minutes for no reason. Anyways, so what is this? These are not Elschnick's pearls. This is also a repeat question. This is asteroid hyalosis. Okay, this is asteroid hyalosis, which is seen in elderly patient. These are calcium and lipid accumulates and they lead to floaters. है ना, floaters आ जाता है. Okay, that is what is asteroid hyalosis. So what looks like Elschnick pearls but is not Elschnick's pearls because they don't give you history of cataract. Okay, so then it's asteroid hyalosis. Fine. ये क्या है? This is Vossius ring. This is osseous ring, which happens after trauma. You have this pigment of iris, which accumulates. What is this? This is pterygium. Pterygium has a high recurrence rate. So what you have to do is you have to resect it with autograft. Okay. Autograft. I clarify autograft with spelling because किसी को लगता है उस पे autograph मत देना है ना, ऐसा autograph is not given on this. So this is pterygium. Treatment is autograft. And what other question is, what is this line called as? This line is what is called as the Stocker's line. Okay, so this is Stocker's line, which is iron deposition on the pterygium. Okay, fine. The difference between this and synopsis scintillans that one of you is asking, which means you have read off the very well, is that these are not gonna settle with gravity, whereas scintillans will settle with gravity. Okay, fine. That is what is the difference. All right. Then we have two macular pathologies. Two macular pathologies is what you want to remember, which is what? So when they tell you history of steroids, they tell you somebody with very high amount of stress. This is central serous retinopathy. But when they tell you that there is this flower petal, there is this petaloid appearance, this is cystoid macular edema. This is a complication of almost everything is what you need to remember. Cystoid macular edema, CME. This can be seen after cataract. This can be, which is known as what syndrome? Irwin gas syndrome. It can be seen as a complication of diabetic retinopathy. It can be seen with niacin toxicity. It can be seen with prostaglandin analogs. So this is what you need to remember. Here the fluid is in OPL. OPL sounds like petal, right? OPL petal. है ना थोड़ा थोड़ा. So outer plexiform layer. Then 3 tests for dry eye. So they have asked you this. This is the Schirmer's test. So this is Schirmer's test that I am showing you here. This is the phenol red, है ना? Phenol red thread test. And this is tear breakup time. Tear का breakup कितने देर में हो रहा है? That is what you are seeing. So these are the 3 tests for dry eye. They will ask you to identify. Then this time we got an anatomy question. So they are your anterior part. This is your posterior part. Okay. So anterior, posterior. Beach में we have canal of Hanover. This big space is canal of Hanover, and P से posterior, P से petite. This one here, posterior to Hanover, is petite. ठीक है, तो बस इतना ही कर लो, बहुत है. Posterior to Hanover is petite. Fine. So this is about the anatomy of canal. Then we have these charts that they have asked to recognize. So obviously the first one you know is your Snellen chart. This is the most commonly used chart that we have, where they ask you about the angle. They ask you about the arc of resolution, angle of resolution. So what you have to do here is, if they ask you from 6 meters, topmost letter, मतलब 60 की बात कर रहे हैं. So first of all, tell me what will be the visual acuity of a person who can ask. Okay, उसमें भी आंसर मार्क था तो बढ़िया है. ऐसे क्वेश्चन आए अगेन, डोंट बी हीरो दैट मेरे लिए आंसर मार्क्ड है. This is too easy. It means that they are trapping me. Delusion of persecution. मेरे पीछे ही है, मैं गलत करूं इसीलिए आंसर दिया है. I will not mark that. I will mark something different. In bipartite Patel also they had given answer. Lots of people didn't mark. उनको लगा कि अरे ग्रेस मार्क मिल जाएंगे, क्यों मार्क करना है, और you marked fracture patella. So what you have to remember is, if answer is given, just take it and mark it. Don't overthink, don't overcomplicate. Okay, anyways. तो अगर किसी का विजुअल एक्विटी उनको 60 दिख रहा है, देयर विजुअल एक्विटी इज गोइंग टू बी 6 by 60. सो नाउ व्हेन दे आस्क यू एंगल, जस्ट डू मी वन फेवर. ये जो विजुअल एक्विटी आपने निकाला है उसको उल्टा कर दो. मेक इट 60 by 6 एंड मल्टीप्लाई इट विथ 5. डिड यू अंडरस्टैंड दिस एवरीबडी? जो भी विजुअल एक्विटी मिला उल्टा कर दो. 60 by 6, मेक इट इन्वर्टेड, मल्टीप्लाई विथ 5. सो दैट विल गिव यू आंसर. क्या मिलेगा? 50 minutes. Okay, so that will tell you that answer is 50 minutes of arc. So if I can read 6 by 6, it becomes 5 minutes. All right. So this is how we read Snellen chart. ये कौन सा chart है? This is your ETDRS chart. ETDRS chart में क्या difference है? it is ulta ऐसे जा रहा है. So this is something that I have picked up from internet. Maybe they'll ask, then I will take party from all of you. It has 14 lines of 5 letters, 5 Sloan letter octotypes. They are of equal difficulty and there is geometric as well as logarithmic progression. बस एक बार सुन लिया, अब मत सुनना. ETDRS chart. Then look at this. Here we are checking the contrast sensitivity. So this has come as an option here. This is known as Pelly-Robson contrast sensitivity chart. This video will be available later also, yes. Probably not on YouTube, but on the app for sure. So this is Pelly-Robson contrast sensitivity chart. What are these charts? This one is known as Amsler's grid. This is what is used for macular pathologies. Here, if you see this dot is dancing, metamorphosia ho raha hai, means you have a problem with macula. And what is this? This is what is known as Hess chart. Hess chart is what you use for diplopia. This is something that helps in diplopia. ठीक है? Then we have color testing के लिए. This is Ishihara chart. You know Ishihara chart. Then we have this one. इसका नाम पता होना चाहिए. This is known as Farnsworth Munsell. Okay, so just remember ऐसा कुछ है. Farnsworth Munsell. The name is 100U test, but they are not testing 100Us. वो भी गलत रख दिया नाम. They are only testing 84Us. Okay, so इसमें भी misnomer. So this is 100U test, and what is this? Where they are showing you one insect. The name of this insect is Titmus. So this is Titmus stereopsis test. Okay, that is not correct. The name of insect is not Titmus. This is just how my funny brain has remembered कि Titmus कुछ दिखे, and you are testing 3D vision. It is Titmus stereopsis test. Okay, this is what you have to remember as far as all charts are concerned for all of you. अब कुछ और eyes देखनी है. What is this? When you see blurring of optic disc bilaterally, patient is in trouble. This is papilledema. It is because of raised intracranial pressure. Then what is this? This is diabetic cataract. You are seeing snowflake cataract. This is what is because of sorbitol pathway. What is this collar stud appearance? A bluish appearance on the fundoscopy. This is nothing but a melanoma, obviously. So this is a choroidal melanoma. If I do an MRI, the T1 weighted image will show me hyperintensity. Very unique. T1 hyperintensity typical for melanoma. ठीक है, बहुत मजा आ रहा है. थैंक यू सो मच. अगर ऑफ्था में बहुत मजा आ रहा है, आई थिंक आई हैव अचीव्ड एवरीथिंग इन लाइफ. इफ यू कैन स्टडी ऑफ्था फ्रॉम मी एंड से दैट मैम क्या पढ़ाया आपने. So that is melanoma. Then after cataract means not after cataract. After cataract is the disease here, which is a complication. It is the most common delayed complication of cataract. नाम ही है after cataract, also known as posterior capsular opacification. This is known as Elschnig pearls. All right, so Elschnig pearls होते हैं, Sommering की ring होती है. Don't have to see everything. Just remember Elschnig pearls ऐसा होता है. पोस्टीरियर कैप्सुलर ओपैसिफिकेशन. ठीक है, चलो इसका ट्रीटमेंट अभी बताऊंगी 2 मिनट्स में. बिफोर दैट जस्ट टेल मी लेयर्स ऑफ रेटिना. सो नेवर बी हीरो. एंड अगर ये पूछा है डोंट बी हीरोइन से अरे मुझे ये पूछा दिस इज न्यूक्लियर लेयर. नो, यू हैव टू गो स्टेप वाइज. सो फर्स्ट यू सी दिस वन. दिस इज द कोरोइड है ना, जहाँ पे वेसल्स है. Then you will mark out where is pigment. This is retinal pigment epithelium. Then you see this is photoreceptor. Okay, now how to know is what is outer, what is inner. So obviously choroid means outer and under ka part is inner side of retina. That is what you have to first see, what is outer, what is inner. So now I know what is outer. So this is nuclei, so this will be outer nuclear, this will be outer plexiform. So obviously this will be inner nuclear, this will be inner plexiform. Inner nuclear and inner plexiform. Then this will be ganglion cell layer and this will be nerve fiber layer. And ऊपर जो आता है वो है internal limiting membrane. बीच में एक external limiting membrane यहाँ आता है between photoreceptor. All right, so this is how one by one you have to see. All right, is this clear everybody? अब यहाँ पे मुझे ये बताओ, वेर आर बाइपोलर सेल्स, वेर आर एमक्राइन सेल्स, म्यूलर सेल्स, ये सारे ही नाम वाले सेल्स आर ऑल इन द इनर न्यूक्लियर layer. Okay, so that is what we have to remember here. Fine. Now, types of lasers, very quickly we just have to combine all of the lasers in one place in ophtha so that you know. So photocoagulation, we use these two lasers. These are used in two indications. One is pan retinal photocoagulation that I'm going to do in proliferative diabetic retinopathy, and for laser trabeculoplasty. Laser trabeculoplasty is done for open angle or angle closure. Obviously for open angle glaucoma, because trabeculoplasty means we are clearing the mesh, है ना, नाली साफ करना in our terms. So we are clearing the mesh means you have to do trabeculoplasty. We will use this photocoagulation, burn कर देगा. Photoablation, which is your argon fluoride, is what you use for LASIK to flatten the corneal stroma. Ablate कर देगा, जला देगा stroma को. Photo disruption, here the Nd:YAG laser is what I use for this posterior capsular opacities, and I also use it for laser iridotomy. Laser iridotomy किसमें करेंगे? This is used in angle closure glaucoma, where the angle is closed. I have to cut the iris only, then the angle will be opened. And femto laser नाम में ही है, this is used for a new cataract surgery, which is flax, femto laser cataract surgery. Just see the wavelength of all of these. Okay, so I've just compiled. It took a lot of effort to compile these lasers, so just see these. Okay, all of your ophtha laser treatment will be done on one slide. If they tell you there is penetrating trauma to ciliary body, following which contralateral eye develops panuveitis, I'm sure all of you know it is sympathetic ophthalmitis. Why does this happen? This happens because of immune privilege. What is immune privilege? Immune privilege is when, so there are two immune privilege sites. One is the eye, all right, and the second one is the seminiferous tubules. Here our self antigens only are, recognized as foreign antigen. They have not gone to the thymus, they have not undergone selection. So if they leak out, our body is going to treat them as foreign antigens, and they're going to mount an immune response. So if you have a penetrating trauma to the ciliary body, these antigens get released, and the other eye, uska बेचारे का तो fault भी नहीं था, but these antigens get leaked out, so now body is going to attack the other eye. That is what is known as sympathetic ophthalmitis. So two concepts I've taught you in the same thing. I've taught you one immunology concept, and I've told you diagnosis. How do you prevent this from happening? Before they can leak out, nikal do aankh ko, we will do enucleation, right? So enucleation of the affected eye will prevent this. Fine, but once it has happened, एक बार हो गया, फिर क्या कर सकते हो? Give steroids. So for treatment, now I can't do anything. Once they are leaked out, I can only control, right? So that is steroids. Fine, so this is what we need to remember. So finally, we have anti-glaucoma drugs that we need to know. So mechanism. What increases the uveoscleral outflow? So this is going to be the PGF2 alpha analogs. So latanoprost and bimatoprost is what we use here for increasing the uveoscleral outflow. Side effects, very, very important. What are the side effects? One, you already know, cystoid macular edema. Then it can also cause iridocyclitis, so you should avoid it. This is a repeat question. Avoid it in patient who has uveitis. And it can also cause HSV keratitis. Okay, so these are three fulminant side effects. Baki do अच्छे beautiful side effect. One, it can cause heterochromia iridis. Don't you guys like it when you have light colored eyes? I used to always love it. So it is heterochromia iridis. उससे हो जाएगा, ये डाल दो, but शायद vision भी चला जाए. And the other is also very nice, hypertrichosis. You know how people get eyelash transplant? Now they get implants and transplants to get bigger, beautiful eyelash. They can just put this PGF2 alpha. If they're ready to lose their vision, but they want beautiful looking eyes, they can use PGF2 alpha analogs. Okay. Then we have increasing trabecular outflow. One is pilocarpine. So pilocarpine is a meiotic. So eye pupil size कम करेगा, and साथ साथ it will also reduce NLD. So NLD stenosis and meiotic. And finally, netrasudil causes vortex keratopathy. So remember the mechanisms and side effect of everything. Then decreasing production will be beta blockers. Beta blockers produce corneal anesthesia. Then dipivafrin, remember ABCD. Alpha agonist dipivafrin causes BC, black conjunctiva. ठीक है? Yeah, vortex keratopathy is seen in a bunch of other drugs. Okay, bunch of other, lots of other drugs. Chlorpromazine में भी मिलता है. Multiple things. Okay, but not seen. Where is what is very important. So in I forgot that question. What was the answer to that? Ki all except, but it is seen in a lot of other drugs. Okay, so this is ABCD. So we have alpha and D, which is black conjunctiva. Then we have alpha 2 agonist, which is apraclonidine and brimonidine. Here, what you have to remember, clonidine is lid. Okay, so this causes lid retraction, and brimonidine is brain inhibition. नाम से पता लग रहा है, this causes apnea. Okay, so this causes apnea. All right. Okay. Then carbonic anhydrase inhibitor, remember acetazolamide. What do we call it? We call it acidazolamide. So this causes metabolic acidosis. Okay. Quinine not seen. Okay, fine. Yeah, probably that is what was it. So quinine does not show you vortex keratopathy. All right. So this is about anti-glaucoma drugs. Chalo, fatafat, let's do the previous year questions from theory, which is not a feature of complicated cataract. It is Krukenberg. This is what is seen in pigmentary glaucoma. In pigmentary glaucoma, we will not see Krukenberg spindle. Intraocular lens was placed during cataract surgery. What should be done? Nikalna hai? No need to remove. If there is no complication, we need not do anything. So it is never replaced unless anything else happens. Okay. Then we have a neonatal conjunctivitis. When 14 days. So here the timeline is very important. If it is less than 24 hours when it's happening, that is chemical conjunctivitis. Okay. If it happens around 1 to 5 days, the most common cause is gonococcal conjunctivitis. Anything after 5 days, the answer is chlamydia. Okay. So this is how you can answer on the basis of timeline. Plus you are having lung infiltrates. So this is about chlamydia trachomatis. Okay. Safe strategy. Yes, surgery. Yes, antibiotic. Azithral is the drug of choice. Yes, facial cleanliness. It's a water washed disease, that is trachoma. And not evaluation of control program. What is it? It's environmental control, right? You have to also keep your environment clean. So this is safe strategy. This is what is a stenopic slint. This we use for Fincham test. Fincham test क्या होता है? Third year में पढ़ते थे नहीं? Fincham test is when you want to distinguish the colored halos of cataract from corneal edema. So वो colored halos को distinguish करने के लिए you will use this. Corneal tattooing में इसका कोई role नहीं है. Fine? Oh, one person has very nice lava. Vortex keratopathy is caused in Fabry's, phenothiazine, indomethacin, all causes you have given. So ultimately answer remains not seen in quinidine. That's what you remember. ठीक है? Right. Abrasion, ulcer, perforation. Which of the following will not cause hypotonic maculopathy? Which will not cause reduced intraocular pressure? So cyclodialysis of uvea can cause reduced IOP. Corneal perforation can cause leakage. Filtration site leak can cause leakage. So all of these will reduce the intraocular pressure, but just bleeding will not cause. Okay, that is what you want to remember here. So कोई पार्क्स 3 स्टेप की याद कर रहा है ना, ये देखो, दिस इज व्हाट वी हैव टू डू. क्या याद रखना है? इंदिरा गांधी इंटरनेशनल एंड ITO. These are the 2 metro stations that you remember which will save your life. So क्या दिया है? Left side head tilt which on straightening leads to right hypotropia. So what you have to remember, right hypotropia को कर दो left hypertropia. We always have to start with hyper. Okay, so left hypertropia is what you have to remember. Yeah, cataract, glaucoma, corneal edema, all of these can have colored halos, no? So that is what we are distinguishing. So left hypertropia hai. This is increasing on on right head tilt. So what do we have to see? Ipsilateral tilt में increase हो रहा है तो वो oblique है. So यहाँ पे क्या है? Right head tilt. Contralateral tilt पे increase हो रहा है. So this means it is a rectal rectus that I am dealing with. And wow, my trick works here only. So my answer is here. But then let's just confirm. When they say extroversion, matlab contralateral gaze. So contralateral gaze पे increase हो रहा है, matlab it is not I, है ना? It is superior. So IGI means ipsilateral gaze पे अगर increase हो रहा है, it is inferior. So now I know it is superior rectus. अब मुझे देखना है right superior rectus और left superior rectus. So how do I see? If there is left hypertropia, superior rectus is what is a muscle which causes up gaze. Agar left superior rectus, it can never lead to left hypertropia, it lead to left hypotropia. So it has to be right superior rectus. So this is how we solve. Aaya samajh mein sabko? So this is about this IGI, ITO. This is your PARC 3-step test. If you didn't understand, just see this part one more time. Okay. What are these? When you see them between the retinal pigment epithelium and the Bruch membrane of the choroid, these are your drusen's. Okay, this is drusen's. Fine. Okay, this is drusen. If you couldn't find answer with this method, then you see your own method. Okay, then whatever works for you, you can see the older method. Okay, fine. All right, Balram, you can find your own method and also teach me. I will also learn the correct method. So this is drusen and this is what we see in ARMD. Fine. Then what are these? These are bifocals. So these are bifocals where you have two different powers. So what you have to remember here, that there is no indication in hypermetropia. This is used for presbyopia, aphakia, and pseudophakia. All right. So this is hypermetropia. Then this was the last year question, which you are not expected to answer. Such questions, remember, don't change your rank. We may criticize paper, we may criticize exam ki aise sawal aaye hain, how do they expect me to get rank? Such questions don't change your rank. Even if you get them right or wrong, doesn't matter. Okay, so focus on the ones which you have to get correct. So what are the ones which are direct gonioscopes? So you have to remember that it is Goldman and Zeiss, which are your direct gonioscopes, right? Or is Richardson also direct gonioscope? So you remember that we have, no, sorry, not Goldman. Goldman is indirect. We have Richardson, which is a direct gonioscope. So answer here is going to be 2 and 4, right? So it is your Richardson and Cope are your direct gonioscopes. Fine. So this doesn't really matter too much. Then, so the ones which I marked are your indirect gonioscopes. ठीक है? चलो. Identify the surgical step. This is capsulorhexis. You are doing a circumferential incision. So this is capsulorhexis. Then these questions are asked a lot of times. So what are you seeing? You are seeing that when the light is flashed on this eye does constrict. There is constriction which is happening. But I flash the light on this eye, it is not constricting. It means problem is in afferent or efferent. Problem is on this eye, afferent or efferent. Efferent is not an issue because this light is showing constriction when the opposite is being done, right? So this is what is an afferent pupillary defect. It's known as a Marcus gun pupil. Marcus gun pupil is what is also known as RAPD when you have a problem with optic nerve. It is seen in optic neuritis. Pupil can paradoxically dilate in both eye because इस तरफ का signal ही नहीं गया. Very, very important Marcus gun. This they have again asked. Which will you see in primary open angle? So again Marcus gun, because this can affect the optic disc leading to optic nerve issues, right? So in open angle glaucoma, we have Marcus gun. Lots of questions have come on Marcus gun pupil. All right. So that is what we need to know. Do you want me to stop and do ENT next time, or you just want to finish? It'll take around 30 minutes more. Can I take this up in the next class only with intermediate subjects? Because Zara has been without me for a very long time. Can we do this in the next time? Yeah, with the next class. So the next class is going to be on day after tomorrow. We will be having it at 10 a.m. Is it okay? Is that okay? Can we stop here at this point? Huh? You want to finish? All right, chalo, let's just finish. Let's just finish it off so that it's closure for you. All short subjects are done. All right, chalo, let's start. So we have epistaxis. Epistaxis ka cause hota hai ICA and ECA, right? So what you have to remember, there are two kinds of questions that can be tested. Which artery is not a part of Little's area? So remember, posterior ethmoidal artery, posterior, not part of Little's area, not part of Kisselback's plexus. Then the other question they asked, there is anterior epistaxis. We blocked the ECA. Still the bleeding is persisting. What is the culprit artery? Then the culprit artery becomes anterior ethmoidal. So remember, anterior ethmoidal is the only branch of ICA which is a part of the Little's area or the Kisselback's plexus. Fine. So this is what you want to remember. Which is the artery of epistaxis? It is sphenopalatine. Sphenopalatine is the artery of epistaxis. So remember, how do you manage epistaxis? The first is Trotter's maneuver. 80% will resolve with this. When you pinch the nose and lean forward. Then if it doesn't resolve, you're going to do nasal packing, and second one, and if it doesn't resolve, then we have to do endoscopic ligation of sphenopalatine artery. Okay, this is what you want to do here. Let's talk about the sensory supply of the pinna. Very, very important question. So what you remember is that greater occipital is not a supply. No go. Go no. You have lesser occipital, you have great auricular, but not great occipital. Very, very important. Here, what are the important points is they have asked you what supplies the lobule. So everything in purple, the great auricular, uska naam hi hai, I am the great auricular nerve. This is the one that is supplying most of the ear. Important part, V3, auriculotemporal, supplies the upper half and it supplies the anterior wall and the roof. Anterior wall and the roof of external auditory canal. A. All right. Then what you want to remember is 7 and 10. Next class, I will let you know whether it will be on YouTube or whether it will be on the app. If we will try to keep it on the app itself. Okay, it will be on Zoom like always. Okay, so 7 and 10 is posterior wall and floor. So two questions have been asked. If a person, we were doing syringing of the external auditory canal and resulted in syncope, what is the cause? The cause is the 10th cranial nerve, the Arnold's nerve, which is supplying the posterior wall and floor. Hitzlberger sign is what? In a case of vestibular schwannoma, if you have 7th cranial nerve involvement, there is anesthesia which affects the posterior wall of the external auditory canal. All right, so that is what is known as Hitzlberger sign. Okay, right now focus on ENT, guys. I don't want any opinions on where it should be and how it should be. If I want opinion, I will ask. Right now, just focus on ENT. Okay, so this is about the nerve supply of the ear. Very, very important. Then two kinds of perforations of the tympanic membrane. Here, when you see these pale granulations and you see, yes, I will ask team to upload today itself on the app. We will try our best. It's a long class. It takes time to process. All right. So we will try our best. It will be uploaded by tomorrow morning for sure. Okay. Right. So when you have these perforations and pale tissue, this is what is known as TB. TB, otitis media. Remember, this is something which is painful. This is something where you have pale granulation tissue here. Then when you see perforation because of trauma, if you see traumatic perforation, what is the management? Traumatic perforation of tympanic membrane, what will be the management here? Shaving area is great auricular nerve, right? The same one, great auricular nerve, is also in the shaving area. So it starts from the ear and the entire shaving area is the great auricular. Okay. Right. What was I asking? Yeah, traumatic perforation, the management is conservative. Remember, it is conservative management. We are not talking about TB laryngitis, guys. Are you talking about painless of TB laryngitis? I'm talking about TB of the ear. Okay. Remember, don't mix organs. This is something where you will have pain and you will have hearing loss. It is also painful, but the hearing loss is far more than the pain. All right. So remember that yes, it is painful, but the hearing loss far exceeds the pain. All right. So it is not painless. Even TB larynx is not painless. Even TB larynx is painful. But when they tell you, is it exquisitely painful? Answer is no, it is not exquisitely painful. Same here. It is not exquisitely painful. It is something which is having pain, but you can remember, maybe if you want to remember it as plus minus, just like TB larynx, plus minus painful. So remember, hearing loss exceeds the pain. That is what is the fact. If they tell you can it be painful, you say yes, it can be painful. All right, just remember this. Fine. So this is about TB otitis media. In traumatic perforation, the management is conservative. If the perforation doesn't heal in 12 weeks, then we can surgically repair. All right. Then we have a few anatomy points that you want to remember. What is the point here? Between the nasal bone and the frontal bone, what do we call this? This here is the nasion. All right. So this is nasion at the frontal nasal intersection. What is this point between the nasal bone and the cartilage? Between nasal bone and cartilage is the rhinion. Okay. So this is nasion and rhinion. Yeah, I think we have now clarified TB painless, painful. Is this clear, all of you, that if they tell you the hearing loss is more than the pain, that is a correct statement. All right. Okay. So we have nasion, we have rhinion, and then between the upper lateral cartilage and the lower lateral cartilage, this point here is what is known as Lyman nasi. All right. So this is Lyman nasi, and this is the site where you are going to do internal rhinoplasty. This is the site for internal rhinoplasty. So these are anatomy questions from basics that you can't afford to get wrong. Okay. Then what is this? This is Ramsay-Hunt syndrome. Ramsay-Hunt syndrome. This is when you have geniculate ganglion. Geniculate ganglion involvement by herpes zoster oticus, and this is something which does not have a good prognosis. So usually Bell's palsy overall has a good prognosis, but here you have Bell's palsy which does not have a good prognosis, and you are going to have these vesicles which are there in the external auditory canal. All right. Chalo. Now talking about surgeries, very, very important. So we have canal wall up, canal wall down operation. This is something that you confuse a lot. Okay. So remember, simple cortical mastoidectomy is what is known as canal wall up, where you are not removing the external auditory canal. Okay. So this is something that you're going to do if you just have mastoiditis, uncomplicated, acute otitis media, or if you just want to go into the inner ear, you don't have to remove the external auditory canal. But if you remove the canal, you make a complete cavity of mastoid and you remove the canal. This is what you have to do in cancer. So glomus tumors, cancers and cholesteatoma. This is what is radical mastoidectomy. So agar bahut severe cheezein hain, canal wall down. Now let's look at the anatomy aspect of it. So what is this triangle here? The triangle that you are seeing here, the anatomy is very, very important. This is the Mc-Evans triangle. It's the landmark for the mastoid antrum, right? So this is where you're going to find the mastoid antrum. Okay, just lost the live chat. 1 second. Right. So this is what is the Mc-Evans triangle. If you drill in this triangle, 1.25 to 1.5 centimeter below it, we have the mastoid antrum. So here they can ask you questions from the boundary. Ek to question ye ho gaya, kaise pahunchoge? So through this triangle. Now what are the boundaries here? So the first one, do you see this external auditory canal? There is a spine which is known as Henle's spine. Okay, so this is the Henle spine. This Henle spine per se is a landmark for the 7th cranial nerve. We never drill over this. This is known as 7th cranial nerve, Henle's spine. Then you have the roof here, which corresponds to the tegmen. All right, so this is what corresponds to the superior part, which is the tegmen tympani. All right, so this is the superior part. Then we have a tangent just connecting both of these. So this is the tangent connecting both of it, which corresponds to the sigmoid sinus. So they can either ask you individually what corresponds, which margin corresponds to what, or they can ask you what McEwan's triangle corresponds to. That is what is correspond to mastoid antrum. So this is McEwan's triangle which is corresponding to mastoid antrum. Okay, तो अभी देखो ना, अभी तो फ्री चल रहा है ना. Why are you wasting time right now commenting? If you were really wanted to utilize this class, you would have just focused and seen the entire class and got done with all of the revision, right? So if the intention is right, no, then you can achieve anything. To be very honest, if your intention is right and you prepare well, so much content is there on YouTube, you can get rank 1 without subscribing any app. And I'm saying this, without any sort of motive. You can crack exam. There is so much content on YouTube that you can crack an exam, right? So if your intention is right to study, you would have already studied right now only. When we talk about making free and education free, I am somebody who always supports that, and I have tried my best, but certain things are beyond my limit also. So I will try my best that I can give you as much education as I can without any fees. Hopefully one day everything will be available freely, but in today's time there is already so much that you can get without any subscription. You can get a rank 1, I can tell you that. But for that, you need to stop having the FOMO. You need to utilize your resources well. How many of us do that? We keep asking, no ma'am, is this enough, is this enough? Yahi karte reh jate and you don't even do one thing well. So this is what all of you collectively have to understand, that whatever you have, usko to अच्छे से करो. Before asking for more stuff, before asking for, ये ले लो, जो आपने करा है, can you give me 100% guarantee that whatever is there with you, if I ask you one question from that, you will get it correct? If you can guarantee me that, you are sorted, you are anyways getting a rank. So the idea is, what you are reading, whatever you are studying, do it well. Don't keep asking for more. Don't keep asking for more stuff. Ye kar le. Don't keep doing more stuff. Just do one thing, do it well. Do it again and again, such that you don't get questions from that wrong. Okay, that is what is my common message, and it's something that is very common now. It's very irritating also, to see students keep messaging ki ma'am ye le lo, ye kar do. It's not irritating. I mean, I get from where you are coming, but I get irritated because you are on the wrong track. You are doing the wrong approach, क्योंकि आपके पास जो है वो आपने master ही नहीं करा. Your foundation is not strong. You are going on doing multiple resources. Don't do that. Don't fall into this trap. Okay. Anyways, coming back. So McEwan's triangle. अब आते हैं, आपने मेस्टॉइड को खोल दिया, राइट? यू हैव ओपन दिस मेस्टॉइड, यू हैव ड्रिल्ड. नाउ व्हाट आर यू गोना गेट? सो द सेम बाउंड्रीज दैट आई वाज टॉकिंग अबाउट, sigmoid sinus, facial nerve, and then you have the tegmen, right? So when you drill, this is where you are gonna come. So this is the posterior tympanotomy approach that we need to remember here. So this is again the sigmoid sinus, this is the facial nerve. They keep asking you this anatomy here. So what are you doing? You are drilling a hole here from mastoid and you are entering the middle ear. Okay, so middle ear जाने के लिए कहाँ से तोड़ते हैं? What I break is the facial recess. Okay, so this is what you need to remember, that we break via the facial recess, and because you're coming from posterior wall, you're coming from the posterior mastoid wall, this is what is known as a posterior tympanotomy. So anytime surgeon wants to go into middle ear, ENT person will not go through external auditory canal, open tympanic membrane and go. They are going to come via mastoid sinus, via this approach that we just learned. So they have asked you, what is the bone here? It is incus. What is this? It is lateral semicircular canal. Very, very important. Fine. Then they can ask you boundaries of Trotzman triangle. So here the boundaries are going to be superior petrosal sinus, it is going to be sigmoid sinus, and you have the bony labyrinth or the semicircular canal. So bony labyrinth or the semicircular canal, these are the three boundaries of the Trotzman triangle, which is a marker of the posterior cranial fossa. Okay, so this is a marker of the posterior cranial fossa. Fine. So this is about this. ठीक है. चलो अब जाते हैं into hearing loss. If you have analyzed INICT pattern, you will realize that there is always one question from this. There is one question from hearing loss that we need to know. ठीक है. चलो तो रिनी सबसे पहले ट्यूनिंग फोर्क टेस्ट से शुरू करेंगे. यू गाइज नो एयरबोर्न गैप. 3 टाइप के ट्यूनिंग फोर्क है हमारे पास. 256, 512, 1024, 15, 30, 45. This is the airborne gap. All right. So they have asked you this once. Just gonna write it somewhere. Okay. So we have 512, 256, 1024, right? So we have 15, 30, 45 decibel. These are the airborne gaps. This is the one that we use most commonly. ठीक है. Previous page में abscess था. Yeah, I'm sorry. So these are the 3 abscesses of CSOM that you need to know from the anatomy. So जो abscess sternocleidomastoid पे जाता है, उस abscess को क्या बोलते हैं? We call it bezoid abscess. So this is the bezoid abscess along the sternocleidomastoid. The one which is going along digastric is Citelli, C and D. Remember, C and D go together in 3 places throughout all subjects. One is Citelli is digastric. Second is Colles is dorsal displacement. Colles is dinner fork, like we just saw. Third CD is Cory's disease is debranching enzyme from glycogen storage. ये साथ में याद रखो, तीनों ही क्वेश्चन है, बहुत भला हो जाएगा. So Citelli is digastric. Meatal is what is known as Lux abscess, but the most common is behind ear. Retroauricular abscess is the most common one. So these are all abscesses from CSOM. All right. So this is what you want to remember. Okay. Chalo, very quickly. Now we go to tuning fork test. So we have Rinne's positive. Rinne's positive means if I strike on the bone and then I keep hearing air conduction more than bone conduction. This is what is normal. But this is what I will also see in sensory neural hearing loss. ठीक है? Negative is what is conductive hearing loss, where obviously air conductive pathway is not working. False negative, however, can also be seen in unilateral severe SNHL. ये बस side note में थोड़ा याद रख लो. This is the most important mnemonic ever. Weber will lateralized same side in CHL, contralateral in SNHL. So this is our cross mnemonic. Okay. So remember, yes, this is very, very useful. All right. So this is how you will remember this. Now talking about stapedial reflex. Stapedial reflex का afferent कौन है? Who will take the afferent? It's the 8th cranial nerve, right? It's the 8th cranial nerve which will take it to the olivatory nucleus, and this will give rise to the 7th cranial nerve which will cause impedance of the sound, है ना? तो loud noises से बहुत ज़्यादा we will not startle much. So this is what is known as the stapedial reflex. Okay, right. This is what we use for malingering. Remember, for malingering, we will use stapedial reflex, and we will also use it to distinguish cochlear, retrocochlear, that I will tell you in a while. ECOG में we use this summating potential action potential का ratio. The summating potential is from the cochlear pathway, action potential is from the 8th cranial nerve. So if this is less than 30, it is very typical of Meniere's. So Meniere's के लिए investigation of choice is ECOG. That is what you want to remember here. Fine. So tell me, if there is 7th cranial nerve palsy, will bilateral stapedial reflex go or unilateral stapedial reflex go? So obviously, if efferent is gone, we will have unilateral. But if afferent is only gone, we will have bilateral. Just like RAPD. है ना? RAPD में afferent was gone, so दोनों ही आँख dilated थी. That's how you will remember. So this is about Meniere's. Now let's look at all of these studies. क्या study है? Pure tone audiometry, impedance audiometry or tympanometry, auto acoustic emission, only in ear you will see. If you see probes everywhere, this is BERA. Out of all of these, which is the only one which is subjective? The only one which is subjective is a pure tone audiometry. Okay. So this is what is pure tone audiometry, which is seen in subjective. All right. So here what you have to remember is, First of all, tell me which ear is this? Ajit, you can just focus on studying right now. Stop commenting the same thing. So here what you have to remember is right is red, blue is left. All right. So right में red color का graph दिखेगा. Blue is going to be left color. So first of all, we are seeing the left ear. This one where you see a cross, this is air conduction. The one where you are seeing arrow is bone conduction. Okay, so we have bone conduction and we have air conduction here. When you see a gap that the air conduction is lesser, this is what is known as an airborne gap. So what is the problem? This person has a left-sided conductive hearing loss. This is our interpretation from this. Now let's look at the tympanometry graphs. I'm sure you all know it. So A is what is normal, जहाँ पे 0, -100, 100 के around curve है. AD is what is seen in ossicular dislocation or discontinuity. AS is what is seen in otosclerosis. C is what is when you have a negative pressure curve, means your eustachian tube is not working, eustachian tube dysfunction. And B, 10 minute. And B is where you have fluid in the ear. So this is what is known as serous otitis media. All right. So this is how we interpret the difference impedance audiometry curves. Autoacoustic emission is testing outer hair cell, right? It is testing outer hair cell function. Then Bera has these 5 waves. How do we remember? We remember the entire auditory pathway. E colima are the waves that we see here. So what we have here is 1, 2, 3, 4, 5, and 6 and 7. 7 waves of Bera. Remember, cortex does not contribute to any wave, right? So 2 from the 8th cranial nerve, cochlear nucleus, olivary nucleus, lateral lemniscus, inferior colliculus and medial geniculate body. Most important कौन सी wave है? 5th wave hai. This is what you want to remember here. So this is an important table to localize cochlear versus retrocochlear lesion. We use a speech audiometry. Remember, a speech audiometry is going to be very poor in retrocochlear and we see a rollover phenomenon. Remember, both of these things are going to be features of retrocochlear. ठीक है? Then what you want to remember here is recruitment and CC. Okay. Recruitment and CC score both are what are features of cochlear lesion, threshold decay and stapedial. We have already seen stapedial reflex matlab 8th cranial nerve, so retrocochlear region. And 5th wave is what is most important. If that is delayed or absent, again a problem with the nerve, right? We are testing the nerve here. All right. So this is about cochlear versus retrocochlear. Just go through the terms which I have highlighted. This is what is very, very important. Okay, fine. This is blue, right? This is blue, no? So this will be left. Why do you think it is right? Okay, next one. So this is what we need to remember here. Chalo, ab jate hain into nystagmus, something that they give you a lot of questions from. Remember, peripheral nystagmus will go away in some time. It is fatigable and the direction is fixed. Whereas here, the direction will keep changing and it is not fatigable. Now the direction, if it is a hyperactive labyrinth, same side mein hoga. When I say same side, which component? Fast component or slow component? We are talking always about fast component. So fast component, same side, hyperactive, hypoactive, opposite side. Okay, this is what we have to remember. Then let's talk about the fistula test. What is fistula test? We take the Seagull speculum and we are going to change the pressure. E. colima full form I already said, right? I think you should be aware of that by now. If you are not aware, we will revise one more time. Okay, I'm not repeating it. Very sorry. So fistula test is Seagull speculum where I change the pressure. Normally, it will not transmit into inner ear. But if it gets transmitted, means there is some fistula. Either there is erosion of the semicircular canal, which is a true fistula, or there is a fenestration surgery. Yeah. You have created a fistula, or Again, a post-appendectomy fistula. When will I have a false negative? Even though there is fistula, you still don't have a positive test. That is if you have dead ear. है ना? So dead inner ear है, dead labyrinth, not dead ear, but if you have a dead labyrinth, then you will have negative fistula, and a false positive is seen. That is known as a Hennebert's sign. So this is known as Hennebert's sign, and this is something that you will see if you have a hypermobile stapes. So one is hypermobile stapes that can be seen in congenital syphilis, or sometimes in Meniere's disease, you may have these adhesions which can mimic a fistula. All right, so these are the two things that you want to remember. All right, as far as false positive fistula is concerned, and yes, another false negative can be a residual cholesteatoma. If you have a cholesteatoma blocking the fistula, then it can be negative. So these are all very logical things, right? When will fistula test be contraindicated? When will you not want to put water? So not fistula test, it's not fistula, but it is your caloric test, right? It's your thermal caloric test that will be contraindicated if you have a perforation. Okay, so I'm coming to that. This is your caloric test when you put hot and cold water and you see the nystagmus. So very important, what angle? 30 degree. What temperature? Room temperature, I mean your body temperature plus minus 7. So 37 plus minus 7, 30 degree, 44 degrees Celsius. You all know cows. So what is cows? Cold water डालोगे, opposite side nystagmus. Warm water डालोगे, same side nystagmus. And this is again the fast component. I will not do this caloric water test if there is perforation. That is when it is contraindicated. I will put air via this tube, which is known as the Dundas Grant tube. Okay, so this is about this. Fine. Then few anatomy questions. What are these two noses? Please recognize. Is this rhinosporidiosis or rhinoscleroma? That is the only thing I want to know. This is rhinoscleroma, whereas this is mulberry rhinosporidiosis. If you know this, you know everything from our tables, right, of BTR. Then the anatomy between the constrictors. So the space, this is the Morgagni space between the base of skull and the superior constrictor. Here you have four structures. One is levator palati, second is tensor palati, ascending palatine artery, and you have the auditory tube. You can remember LATA as the mnemonic. So levator and tensor vela palatini, auditory tube, and ascending palatine artery. Okay, so these are the structures passing through sinus of Morgagni. Then what passes between superior and middle constrictor? We have stylopharyngeus, glossopharyngeus. What passes between middle inferior? We have internal and superior laryngeal nerve, and below inferior constrictor we have recurrent laryngeal nerve. This is what you have to remember here. Fine. Now going on to the MCQs. So which is not used for post-laryngectomy rehabilitation? Remember, supraglottic swallow is not used. We use this prosthesis for speech. We use esophageal speech, and polite yawning is used for olfactory rehab, but supraglottic swallow is used to prevent aspiration. Anybody who has dysphagia, we are going to use this. Okay, we are going to be using supraglottic swallow. Another question which got asked from the same, what is the prosthesis that you are seeing? It is the tracheoesophageal prosthesis that we are seeing here. ठीक है, अब ये ऑडियोमेट्री ग्राफ देखो. ऑडियोमेट्री ग्राफ में this is right, this is left. I don't see any airborne gap, right? तो यहाँ पे क्या दिख रहा है? This is in the normal frequencies. This is where is we have left hearing, which is left sensory neural hearing loss. So now we need to know the findings. So always start with Weber's. अगर SNHL है, contralateral side. So Weber's lateralized to right ear. Two options hai. What will happen to Rinne's? Rinne's will remain positive, isn't it? So left Rinne's positive. So this is how you will go about this. I hope this is clear. Everybody, is this clear to all of you? The approach to tuning fork and audiometry, we have revised it today also. ठीक है? What is this? When you see दोनों में ही blades है, this is what is Mollison's mastoid. Jawls is your thyroid retractor. Lagenback तो पता ही है, L-shaped surgery में पढ़ेंगे. Perkins is also mastoid retractor, but this blade will be solid. ये blade solid होगा, उसमें से 4 forks नहीं होंगे. Fine. फिर JNA का स्टेजिंग पूछा है. दिस इज योर Radkowski staging. You need to know this in detail. So they are asking it has spread into sphenoid sinus. So if it is in nose nasopharynx, 1A. If it has gone into paranasal sinus, it is 1B. Then we have 2A, 2B, 2C. 2A is when it is in the sphenopalatine foramen. 2B is when it is in the pterygopalatine fossa, and 3C and 2C is when it has gone into infratemporal. So this is medial to lateral. कहाँ है एयरबोन गैप? अरे ये मत देखो ना, ये गैप नहीं है ना, ये दो अलग अलग कान है. दिस इज राइट एंड दिस इज लेफ्ट. ये रेड है, ये ब्लू है ना? तो ऐसे मिस्टेक नहीं करने. ये देखो, दिस इज एयरबोन गैप एंड बोथ आर लेफ्ट ईयर. ओके, आया समझ में? And this is not looking Perkin. You can see how there are different forks. No, there are 4 forks. In Perkin, it will be one round, solid blade. Okay. All right. ठीक है. So this is 2C. Then we have 3A, 3B. Intracranial extension is stage 3. Fine. Then what is this? This is when you have boxer's ear. You have perichondrial hematoma. It can lead to pugilistic or boxer's ear. It is blood in perichondrial space. It does not resolve spontaneously. It is blood in cartilage. Nahi jayega. What will happen is it will need surgical evacuation and they should receive antibiotics. Okay. Next, what is the structure mark? तो पहले ये सीधा देख लो. It will have no projections. This is the septum. This is the inferior turbinate, right? So this is the inferior turbinate. इसके अंदर जाएंगे तो uncinate process दिखेगा. All right. Then which of the following will not be manifested in the post-styloid compartment? So post-styloid compartment मतलब carotid space. याद रखो, carotid space. So you will have vocal cord palsy, 10th cranial. You can have Horner's because sympathetic chain. You can even have involvement of the parotid gland in the post-styloid. But trismus, masseter muscle, the masticator space is anterior, right? So if you know parapharyngeal, if you just know basic head and neck space, the masticator space is much anterior. You have parotid and carotid space, which are behind the styloid. Okay. Then radical neck dissection, you know this from BTR, right? This is what are all the structures we are removing. We never remove sublingual. We always remove submandibular, level 1 to 5 lymph node and parotid tail. ठीक है? In type 1, I will save SAN. In type 2, I will save IJV. And in type 3, I will save all 3, including sternocleidomastoid. But sublingual is never removed. The others are always removed. All right. So this is about radical neck dissection. During caloric test, what type of nystagmus one should get during cold water nystagmus? So always we are talking about the horizontal component here, right? We're not talking about the vertical component. Horizontal fast is what is mentioned unless mentioned otherwise. So cows, so cold पूछ रहे हैं, so opposite side पे horizontal nystagmus. ठीक है? That is what you need to remember. Metal factory worker suffers from noise-induced hearing loss. Noise-induced is outer hair cell. OAE is also outer hair cell. Noise-induced is also outer hair cell. Then we have two questions, last two questions. Foreign body में cuff reflex चला गया है. So cuff reflex का afferent is the internal laryngeal nerve. Okay, so internal laryngeal nerve will take the sensation and that will cause cuff. So this is what is impaired here. This is an interesting question. If autoacoustic emission are absent, for autoacoustic emission, what do I need? What were we doing? हमने एक रिमोट कंट्रोल यहाँ रखा था and we were giving the stimulus, right? So if somebody has a middle ear problem, again these emissions will not reach the outer hair cell, right? So what do I need? First I need to see tympanometry also. I need to see tympanometry to rule out middle ear pathologies, to rule out conductive hearing loss. And then we were also doing speech audiometry. Remember, speech audiometry will tell us whether it is cochlear versus retrocochlear. So for that, I need this. Pure tone audiometry and free field are both subjective tests. Remember, I told you out of all the ones that I was showing you, pure tone audiometry, I did mention that, didn't I? मैंने mention करा था. This is the, yeah, I did mention. This is the only one which is subjective. Everything else is objective, right? So subjective test after doing autoacoustic emission has no role, है ना? ये पहले कर सकते हो, but after autoacoustic it has no role. So we have 2 and 4 that can be used here. All right. This is what is your answer in this case. Fine. So a lot of you saying D, it is not D, it is 2 and 4. It is tympanometry and speech audiometry that we can do. So this marks the end of all subjects. I think we finished like right on time. We had a 20-minute delay and that is what is the delay that I had in the class. So thank you so much for listening. I hope this helps you and I hope you like the class. We will see about the recording. We'll try to upload it as soon as possible on the app. All right. Thank you so much. Speech is not subjective. Speech audiometry, you saw the table, right? This is the one. So this tells us about the speech discrimination score. So this is what I need for cochlear and retrocochlear. Next, I'm going to see you all now. Day after tomorrow, 10 o'clock. We'll have a morning class, 10 a.m. to 2 p.m. The subjects to be covered will be PSM, OBG, and all intermediate subjects. So biochem, anat, micro, and pediatrics, and PSM, OBG from long subjects. This is what is your homework for the next 2 days. Finish off all short subjects. This class should serve as closure for all of that. Fine. And just finish it off. You want to see Zara? I will just bring her. Okay. I will bring her. Give me 2 minutes. Hello.